go ahead and get started. Again, I'm Eric Berneker. I'm a thoracic medical oncologist here at Houston Methodist, and on behalf of my co-course director, Dr. Shilpan Shah, who allegedly is at home recovering from COVID, but don't worry, we'll be moderating the afternoon heme section. We'd like to welcome you again to the Houston Methodist Cancer Symposium. This is the 9th year that we've done this. The 2nd year we've done it in an empty auditorium.
Go ahead and get started again. I'm Eric Berneker. I'm a thoracic medical oncologist
being able to be patient with us and
on behalf of my co-course director,
I'm going to do a couple of announcements for bookkeeping stuff, and then we'll get started. Basically, for your reference, financial disclosures of the speakers are available on the Symposium's live stream webpage. If at any time during the activity you feel that there's been a commercial or promotional bias, please let us know. You'll also be able to get the CME activity evaluation at the end. And again, if you felt there's been any bias or commercial promotional stuff, feel free at that point to bring it forward. Along those lines, you'll be able to apply for CME credit when you'll be emailed the course evaluation at the end, and at that point, after you fill it out, you can request CME credit. Really want to thank our sponsors and our exhibitors, again, who've been very patient working with us in this virtual environment. There's a virtual exhibit hall on the webpage. Please feel free to jump in and out during the day and take a look at the exhibits. Also on the webpage, there's a link to the abstracts. At the end of the day, we'll have 3 abstract winners present orally their work, but please go to the abstract page and look at all the other abstracts that were presented. You can ask questions of the speakers. There's either in the chat function or there's a link to questions. So as those questions come in, we'll make a list, and then at the end of each talk, we'll be able to ask questions of the speakers. So please feel free to liberally use that and to participate. It's my pleasure now to introduce Dr. Jenny Chang, who's the director of the Houston Methodist Cancer Center and the Emily Herman Chair in Cancer Research. She obtained her medical degree at Cambridge in England, and then completed fellowship training in medical oncology at the Royal Marsden Hospital and Institute for Cancer Research in the UK. She's an internationally known breast cancer researcher and has done a lot of very important work on intrinsic therapy and resistance of cancer stem cells. She's an extraordinary leader of our growing cancer center, and importantly puts up with my office being next to hers, which is probably not easy. She's going to give an overview of what we've been able to do as the Cancer Center expands. So, Dr. Chang, take it away.
Hi, Eric. Thank you so much for your introduction. This is a fantastic symposium, the 9th symposium. We are delighted to have everybody join us. And again, heartfelt thanks to Eric Berneker and Shilpan Shah, who is, as Eric has said, has actually got COVID, but has been soldiering on and hopefully will help us this afternoon. You know, I spent some time thinking about what we should be talking about as to where we are in the Cancer Center as we move towards the next phase. The first 5 to 10 years was spent in clinical building, and the next 5 to 10 years, I think, moving forward, we'll be looking at basically coalescing all the efforts, not only in clinical care, clinical research, and basic research, but, you know, pushing these frontiers forward, applying cutting-edge technologies, not only to our main campus here, but our wonderful work that has been done by all the community doctors in all our regional hospitals, where clinical trials are being run, where patients have equal access to care. So I was just going to do a very quick overview over our structure of the Cancer Center. This is the academic structure and the basic science structure as we move forward. So this is a whole range of people that we have that run both the basic science as well as the clinical side. We have Dr. Shen, Susha Shen, who and her team, who have been wonderful in our immune monitoring, helping us with many of our clinical trials, looking at the tumor microenvironment, and Dr. Bernica, myself, and others, Dr. Naravath, Dr. Darcourt, have a lot of excitement around a lot of this immune monitoring that is being done. And she does a spectacular job, as well as once weekly, I'm going to give a shout out, she has a work in progress meeting. Since she's been here, she has kept that meeting going really rather religiously, and through a pure love for science, bringing together the team. And it's a wonderful testament to her commitment. In 2018, we brought our two associate directors, one for basic science, Dr. Cheng Yi, he was the chair at Cleveland Clinic, and Dr. S. Nunola, who was basically the AD for cancer prevention in Fox Chase. And then in 2019, basically, we were a huge recruitment. Dr. Gaia came to us from VCU. He is the Deputy Director of the Cancer Center. He is also the Associate Director for Clinical Investigation as we move forward. Tamim is our AD for Administration. Steve Wong, who's been here longer than I, helps us with our shared resources. If you need help in biostatistics, bioinformatics, systems biology, he's the go-to guy. Haifa Shen, again, a wonderful biologist interested in device delivery, and Renda Elzine. And last year, during COVID, we appointed Jane Bolin to be our community engagement and outreach associate director. So this is building up the leadership team as we move forward, not only in our clinical research, our clinical service, but also basically our basic science, translational, and community engagement and outreach, and all the core facilities that we need to bring forward this cancer center into the next decade. For clinical research under the care of Dr. Gaia, he was recruited from the Massey Cancer Center. He was the Associate Director for Clinical Research, and he was also a PI on the NCORE grant. This NCORE grant is a critical grant which helps basically bring clinical trials to the community. And with that in mind, we're going to work towards getting an NCORE grant here in Houston Methodist, where we can fund, actually, to be honest, clinical trials in our community, bringing together with a shared vision what is in the main campus and in the community, and that is to serve the community of our patients with the right ethnic background, with all the right outreach behind that. Dr. Gaia probably does not need much introduction because he's extremely well known and he's very basically well renowned. He serves as the co-chair for the NSAP NRG Oncology Breast Committee and has been the genius or the evil genius behind many phase 3 studies that essentially have transformed the way we practice medicine. The latest being Catherine for HER2-positive breast cancer patients. He was the PI. And we now know that if you have residual disease following chemotherapy, HER2-targeted therapy, essentially you need to switch to antibody drug conjugate called TDM1. So this is how we've built the regional, our clinical trials office under the directorship of Dr. Gaia. We have a new CTO admin director who just started 2 weeks ago. We have a multi-center care consortium. We have central RB for NCTN studies. And through the years, what you can see is this wonderful increase in interventional accruals, which is done not only in the main campus, but throughout the community. This takes a lot of work. Our disease-oriented groups, our protocol review committee, and everybody in this group here that you will hear from, Dr. Abdurrahim, Dr. Bernager, Dr. Shaw, everybody participates in these disease-focused groups. We discuss the protocols. We basically bring together not only the medical oncologists, but the radiation oncologists, the surgical oncologists, together to discuss a protocol. And this is shown very nicely in a decrease in time to activation, though I must confess, this year has been quite a grim year, and it's COVID related. and we've had a lot of turnovers in our clinical research coordinators, again, all due to COVID. It's been a very difficult time, but I believe that we're getting used to this new normal, and I think that we will actually have a very productive next few months towards the end of the year. Basic science is basically under Dr. Ching Yi, as I said. He was recruited from as a department chair in Cleveland Clinic. He's a CPIT scholar, and his main thing is tumor immunology and immunotherapy. What is really, really exciting about Dr. Ching Yi's, and I don't have everybody's slide here, and I'm going to just talk off a little bit more. What's really exciting about this is in the next few years, in fact, hopefully next month or soon, we will have a GMP facility for CAR T therapy, cellular therapeutics. Cellular therapeutics, as you know, has changed the way we've treated a lot of hematologic malignancies, and there is great potential that perhaps we could transform this in the way we treat solid tumors as well. Dr. E is the basic science component, but leading this effort in the Houston is our wonderful Dr. Ravi Pingali, and together with our very new recruit, again, is the chair of hematology, is Dr. Sid Ganguly, and together I think we have a fantastic team for cellular therapeutics as we move forward. And so now we have a wonderful team in immunotherapy, innovative therapeutics, cancer prevention. And we've invested a huge amount in basic science recruits. And again, we're concentrating on can we find new targets that we can translate in our GMP facility into clinical trials. And you have some of the examples here. Dr. Hyper Shen is one of the most well-funded. His role is, again, to look at novel therapies that we can work with, working with Dr. Gaia to bring forward this into clinical trials. Des Nola is basically our chief in surgical oncology. Again, he comes from us. He's an expert in complex surgeries like sarcomas. But his great interest is basically cancer health disparities research. Until his arrival here, he was actually the AD at Fox Chase. And he works closely with Dr. Boland in trying to now look at whether we can apply what we find in our basic science, in our clinical trials, to the community we serve. And we have our future direction. It is up and up. We're going to basically find new stuff in our basic science laboratories where we now have a great number of new recruits. We're basically going to translate that into clinical trials, and we're going to expand that into our catchment area and basically serve the people that we have. And that is the end of my slides. And again, thank you very much for giving me a few minutes to share my thoughts. Again, deep thanks to Dr. Bernaka, Dr. Shah, and everybody else who's put this together. Thank you.
It's truly my privilege to introduce our solid tumor keynote speaker for the symposium, Dr. Graham Warren. I'm fortunate enough to serve on ASCO's Tobacco Cessation Committee with Dr. Warren. You know, in an age of immunotherapy and targeted therapy and phenomenal breakthroughs in science, I think it's really important, and certainly COVID has taught us, that public health really still matters, and that certainly as oncologists, if we don't also focus on diet and tobacco, we're really missing out on a lot of interventions that can really help with patient wellness and hopefully improved societal health. Dr. Warren has spent his life working on that project. He's the vice chairman for research in the Department of Radiation Oncology and the Mary Gilbreth Endowed Chair of Clinical Oncology in the Hollings Cancer Center at the Medical University of South Carolina. He is, besides his work as a radiation oncologist, he's been very involved in tobacco cessation endeavors in multiple venues. He's been the expert advisor for the Canadian Partnership Against Cancer, and he works with the NIH to implement strategies to address tobacco use across cancer care. I think he's on the majority of tobacco cessation committees through most of the large oncology groups. And so he's going to talk to us today about smoking as a critical determinant of cancer treatment outcomes. So, Dr. Warren, welcome.
Thank you, Eric, and I will thank you all for the opportunity to speak. I will apologize a little bit ahead of time. I unfortunately was diagnosed with COVID as a breakthrough a few weeks ago, so I talk a little bit slower, and COVID for some reason seems to like me, so still sticking around a little bit. But today, hopefully, we'll get through something that's extremely important, something that can actually help us make a difference this afternoon. Again, as Eric was mentioning, I've worked a lot with addressing tobacco use in cancer care. And today I wanted to talk to you about why this is such an important thing for us to think about. My disclosures are here. I have received funding from different agencies. I'm an editor in several journals, but that being said, I will not be paid for this. I will not be trying to sell you any snake oil or anything strange. It's important to note that NCI continues to fund me specifically to try and help in this area, but I'm not speaking on behalf of the NCI or any of the institutions that I work with. What I'll present will be the evidence-based and hopefully will convince you that this is an important area to think about. So when we think about cigarette smoke, we know that smoking is the largest single contributor to cancer risk. Over 7,000 known compounds in cigarette smoke, 65 actual known carcinogens, and a large number of things that have been added to tobacco, specifically to try and increase absorption and flavor and addiction. And it was kind of funny because what happened was about 15 or maybe 20 years ago, I downloaded a list from a tobacco website showing the things that have been added to tobacco to try and increase addictiveness. There's over 600 things that have been added to cigarettes. You light them on fire and inhale them. It's not rocket surgery. It's going to be bad for you. These are the first 65, just in alphabetical order to give you some of the ideas, things like acetic acid and ammonia and apple juice. And if you want to know what the whole list of 600 looks like, there's a list of whole 600 that have been added to tobacco. Of course, light it on fire is going to be bad. And the interesting thing about this is that the distribution of this problem has changed over years, but it's a very important for us to recognize the geographic distribution of risk. This is an older slide, but perhaps one of the best slides that I can see with regards to lung cancer death rates, and this is certainly tied to tobacco use. And you can see I actually grew up, I spent a lot of time in Kentucky, which is that brown state in the middle of the United States. I always joke with people, there's a couple of small white areas in Kentucky that are areas that I always joke with people. It doesn't mean that they didn't have lung cancer. It just means maybe they didn't walk in there to ask any questions. The reason I mention this is because a lot of times smoking and things like this occur in disparate communities, and our access can be limited, and our evidence and information we get can also be limited. The personal significant bests that I've had are a 267 pack year history in a gentleman over 55 years, and I've had several people mention smoking starting smoking when they were approximately 4 to 7 years old. And you may say to yourself, how do you get to smoking 4 to 7 years old, cigarette smoke? And it's because your mother would give you a cigarette and get it warmed up on the way to class. You might ask, why is it that we can have people smoke at such a young age? This is a slide actually of my son, who's now 17 years old. If your mother smokes, your brother smokes, your father smokes, there's a good chance you're going to smoke. Just so that you know, this was actually a joke by one of our family members who put stogie in his right hand. But that little mom tattoo on his left arm, that's really there, and he really loves his mom. So anyway, he's 17 now, graduated high school, ready to move on to the next thing. The important thing is that you have to remember is that when we think about smoking, especially in the context of adults and addiction, this is something that started very early in life and an extremely difficult habit to try and break. So this is conceptually very easy for us to think about. The problem is that smoking, we haven't really thought about smoking in the context of the continuum of cancer care. We know that smoking is a very well-established carcinogen, and there's several different steps that lead to a diagnosis of cancer. But traditionally, what's happened is that we just stop after a diagnosis of cancer. We don't ask any more questions. But it's not that the effects of smoke go away. They continue even after a cancer diagnosis and can lead to significant biologic and clinical and value-based outcomes. So this is simple. If we just try to address tobacco use in cancer care, we're overcoming that historical disconnect and gives us the chance to try and ask some of these questions. In 2014, I actually wrote the section of Surgeon General's report was the first founding evidence or first synthesis of 400 studies taking a look at how smoking specifically affected cancer treatment outcomes. It was over 500,000 patients, went through 15 different levels of review, an enormous amount of work to try and ascertain what the relationship between smoking and cancer outcome was. This included positive and negative studies. This was all comers. And when it came out of review from the CDC, the conclusions were that smoking by cancer patients and survivors caused adverse health outcomes. It increased all-cause mortality, cancer-specific mortality, increased risk for second primary cancer, and had very strong associations with increased risk for toxicity, poor response to treatment, and treatment-related toxicity. And if we take a look at the magnitude effect across cancer treatments as a whole, the risk of overall mortality increases by a median of 51%, cancer-related mortality by 61%. And these were studies that from 1992 to 2012, but this was across all studies a very profound and significant effect. And if you think this is a head, neck, and lung cancer problem, well, you're part of the way there. This actually shows the number of studies from the report that showed significant associations between smoking and one or more negative outcomes. You can see that across cancer disease sites, hematologic, breast, gynecologic, this isn't a head and neck or lung cancer problem. This is really a cancer problem. And that's good and bad because the bad is that it affects such a breadth of cancer, but the good is that it gives us such a tremendous opportunity that if we tried to figure out how to address this issue, we might have a really good chance to improve cancer treatment on a very broad spectrum. Now, in the 5 years, we've done some work, and this is coming out. We presented this first at the Cancer Center Cessation Initiative, which we'll talk just briefly about in a little bit this past spring. And we've worked to really look at what was the evidence in the years following the Surgeon General's report. And so if we looked in the 5 years after the Surgeon General's report, between 2013 and 17, really focusing on current smoking, this actually was a significant advance because we had 490,000 patients just focused on current smoking. And you can see here for overall mortality, 61% increased median risk. We'll go back for a second. As compared to 51% risk here, so very consistent, possibly a little stronger median risk. But one of the things that we added here was that if you continue to smoke at follow-up, there's a doubling in the risk of overall mortality. That evidence wasn't in the Surgeon General's report, it just wasn't looked at in that context, but a huge issue with regards to risk of overall mortality. And you have to realize we're getting better at treating cancer as the years go on, so people are dying of non-cancer related causes. So smoking not only increases the risk of cancer-related mortality, but significantly increases the risk of heart disease, strokes, and other things. So overall mortality risk obviously makes a lot of sense, especially as we get better at our cancer treatment. If we looked at this across disease sites and treatments in the 5 years following the Surgeon General's report, again, this is tremendously convincing. Almost 80% of studies had a significant or near significant association. We broke this out even further into significant, near significant, and no association. It's just a dramatic relationship between smoking and increased risk of mortality. If we took a look at cancer-related mortality, the same issue. This is really, if anything, just strengthening the evidence that we really have a big problem, even in studies as they become more contemporary. So I hope this is convincing that really we do have a problem we've got to try and solve. So if we look at this, and especially with related to how we can address the problems, we have to look at something called attributable failure. And what I mean by that is, you know, if we have people who get treatment for cancer, some people are going to be cured, they're going to be fixed, but some are going to recur. And if we just focused on cancer-related mortality, because we were trying to figure out what's the societal and economic burden associated with this, we had to figure out what is the added problem or the added risk caused by smoking? And that's something we call attributable failure. And if this is an example from one of our previous studies showing survival in breast cancer patients, and you can see that current smoking significantly reduces survival as compared to former and never smoking. This is actually a pretty significant curve. And if you take a look at this difference between the curves, that red line is attributable failure, the extra cancer treatment failures or mortality risk associated with continued smoking. And when we take a look at this across cancer disease sites and treatments, this came out a couple of years ago, it was a profound effect. We looked at the risks where we changed, modeled this across all the different possible risks, the expected failure rate or cure rate in non-smoking patients, or the inverse of the cure rate. And then we tried to figure out how many people would have added failures. We looked at people who had a very highly curable cancer and unfortunately a very high risk of recurrence on the right. And you can see how these kind of balloon where your average cancers really have the strongest association with expected failures. But importantly, if we looked at this as cancer treatment as a whole across the United States, the cost of treating failures due to smoking, that attributable failure, patients that fail first-line treatment and need second-line therapy, third-line therapy, so forth. If we look at the cost of treatment failure, and that if we attribute it to just $100,000 for the cost of second-line treatment, in the United States, $3.4 billion annually spent just on medications, just on second-line cancer treatment. That doesn't include hospitalizations, heart disease, stroke. This is a conservative estimate. And so in the United States, it's certainly a very big issue. In Canada, we also have done an enormous amount of work in Canada. Canada also has a very significant financial association with that. And so this really impacts our overall healthcare system substantially and certainly financially justifies the need to try and look at this further. So let's go back for a second and say, well, great, but what about all of our really cool, neat, wonderful things? Well, you go back, I'm going to give a few examples of curves that hopefully all of you all have probably seen. These are different curves from different trials. This first is actually from the Keynote trial, taking a look at pembrolizumab with PD-L1 status in the New England Journal of Medicine in 2015. On the top right, this is actually survival of the Keynote 10 trial with high PDL expression, hazard ratio of 55. We take a look at the bottom left. This is the practice-changing PACIFIC trial for the addition of durvalumab after chemoradiotherapy for stage 3 lung cancer. And in the bottom right, this is smoking cessation added to first-line lung cancer treatment. You can see that if we compare some of these effects and the curves, these are significant differences. We have changed practice. Our immunotherapy, we just highlighted about the recruitment of people working in immunotherapy and how this has really changed practice for our cancer care. I just want you to look at the curves and the survival curves associated with smoking in comparison to our practice-changing trials of late. So this is something that we need to make sure we consider when we think about our overall cancer management. In 2020, Surgeon General's report looked at what the benefits of smoking cessation were, specifically after cancer diagnosis, and studies that looked specifically at quitting smoking demonstrated a 45% median reduction in mortality of quitting. 45% reduction in mortality. I want you to go back and think about all of the studies you can remember that look at mortality and see how many actually improved survival by 45%. Smoking cessation, something that's easy, cheap, something we can put into practice this afternoon, 45% reduction in mortality. Why is this such a big deal? Well, just Unger with SWOG actually looked at this last year, and I think this may be one of the most undervalued studies that's been reported in the past year. This was an impressive analysis. It looked at the SWOG trials, Southwestern Oncology Group trials between 1984 and 2014, and looked only at the trials that had a positive outcome. So looked at all the cooperative group trials in SWOG, excluded the negative ones, only looked at the best ones and said, well, what are the things that really kind of drive survival and improvement in these trials? And from this was very interesting because in these trials found that, the benefit was really limited to people who had good insurance. which was kind of striking because you think about all the work we put into trials over the past 30 or 40 years, and really the benefit comes down to whether or not they had good insurance. I'm not saying that's the only thing, but it's really important that we think about this in our clinical trial design. We have a cool agent, we put it in, but we need to think about the other factors that could affect outcome. Well, if you take a look at these specific trials, the median overall survival benefit across these 19 positive trials was 33%. 33% difference in survival with the randomization arm in the positive trials, excluding the negative trials. We've already been through this. We look at smoking, the positive and negative trials combined, we have twice the effect. We have a 60% difference in survival based on smoking. So the reason I bring this up and why this is such a big deal is because we're putting enormous effort and resources into clinical research and trial design. At the same time, smoking has a pretty big effect, maybe twice the effect, and we are certainly not addressing this particularly well in our cancer care. If we take a look at this in the context of genome-driven oncology, Vinay Prasad and his group, when he was back at OHSU, actually estimated at the time, this is a few years old, but that at the time, genome-driven oncology benefited 5% of patients. There's some costs that I tried to abstract at the time for sequencing and treatment. The clinical benefit from their paper was actually 54% response for a median of 29 months, and the cost per 1,000 total patients approximately $4 million. At the time, there was I kid you not, I read this, and there was a hurricane coming through Charleston in South Carolina. My family left me and said that I should come with them, and I said, well, I have to work on smoking, so obviously I'm going to sit through a hurricane for that one. But in this case, I went and said, well, this is interesting. I wonder what smoking cessation looks like in comparison to genome-driven oncology. And we modeled this in Canada, a 16.9% smoking rate. Actually, that's probably lower because a lot of people misrepresent. We obviously don't have to sequence anything. The cost of treatment was extremely well modeled with the work that we've done over the past 5 or 6 years. 40% reduction in mortality, actually 45%. And it cost $160,000 a year. So the cost benefit or the cost ratio for 1,000 patients to drive genome-driven oncology versus tobacco cessation is 25 to 1. Tobacco addresses 3 times as many patients, at least at that time. I'm not saying ignore genomics, but I am saying do not ignore tobacco. This is something we need to think very carefully about as we address advances in our cancer care. We've looked at some of the biology. This was our review in Lancet Oncology at the time. There were thousands of studies that looked at the effects of smoking for the risk of developing cancers, but unfortunately, we only had about 34 studies that looked at the effects of smoking on cancer cells and biologic effects. So there was not that much work that had been done. It's very difficult to get any funding in this area. However, what we did is we said, well, we want to try and find out what cigarette smoke does to some of our best therapeutics. You know, what are the effects on radiation and chemotherapy? Now, this slide's got a few things in it. This demonstrates actually that smoking in the top left, if those bars go up, that means that it decreases response to radiation. You can see there's a dose and time-dependent effect of cigarette smoke. So if we expose cancer cells to cigarette smoke throughout the week for 3, 6, 12, 40 weeks, we actually demonstrate that smoking significantly decreases response to radiation. The top right are in vivo animal curves demonstrating what cigarette smoke does for a tumor doubling time as compared to control. The radiation is at the bottom, radiation plus cigarette smoke at the top. The bottom left is actually slides taking a look at different therapeutics and relative survival fractions, which means that if they're above 1, that shows resistance, and you can see this across head, neck, lung, breast, and prostate cancer cells, significant effects. We're going to come back to those 2 circles in just 1 second. But what I do want to point out is that in this chronic cigarette smoke exposure in the lab, very well controlled, where we expose cancer cells in a very controlled environment, you can see that if we, in the middle bars on the bottom right, significant increase in survival in lung cancer cells. But then what happens is if we take cigarette smoke away for a few weeks and we do it again, we start to get a restoration in therapeutic response. This is really nice to see. We have not yet published this data, but I wanted to make sure we showed you that basically biologically the data support that if we take cigarette smoke away, we start to get a restoration in response to radiation and chemotherapy. So the two circles in the middle of these talks that I give, these are the ones, these two circles are the things I'm asked for the most. We do something called clonogenic survival, which means that we take cells and we put them in a plate and we do whatever we're going to do to them. We treat them with radiation or chemotherapy, whatever it is we're going to try and do. And then we grow them up for a couple of weeks and we stain them. And if they stain purple, it means it survives whatever we did. And here, these two plates are an example of cells treated the exact same days with cigarette smoke and with radiation. The top is radiation alone, and purple means that the cells survive. The bottom is radiation with cigarette smoke. This is what we leave behind. Now, this is an extreme example. Actually, this plate has so many cells on it, we can't use this for any of the graphs I've shown you. This is something that is a pretty dramatic difference. But the question that you have to ask is that if we're going to do radiation or chemotherapy, these toxic treatments for our cancer patients, why are we going to let them continue to smoke? I mean, are we really going to leave this much behind? This is a very practical, real-world issue. So those two circles showing that the amount of cancer cells left behind, that's the slide I'm asked to give to people the most. They want to put it in their patient brochures. Of course, then the explanation is kind of difficult, but it gives you a good visual representation of what you can see. So we also took a look. We're not going to look. I'm not going to discuss e-cigarettes to any significant degree. There's a lot of discussion in this area. The only thing I really want to point out here is that basically, if we look at the effects of e-cigarettes by themselves, they seem to decrease the effectiveness of radiation. But the bottom right curve, if we expose cancer cells to cigarette smoke for 6, 12 weeks, and then we transition to e-cigarettes, we actually get a restoration of therapeutic response. It's better than cigarette smoke. Now, this is what we've got in the lab. Again, this will be coming out shortly. But what I want to convey is that, in my opinion, cigarette smoke is by far the biggest evidence-based contributor to treatment failure. I do not think we have the answers for e-cigarettes, but I would, without a doubt, make sure that we try and get people to stop smoking. So if we start taking a look at this and the magnitude of this effect, this is a profound clinical magnitude. Smoking unequivocally causes adverse outcomes. It is very distinct from ever or former smoking. You can't just say people are smokers and that's it. You got to distinguish current from former or ever smoking. It has a very big effect, an even worse effect after diagnosis. And if we compare this to the big four here, this is a 2020 cancer incidence for breast, lung, prostate, and colorectal. If we take a look at what we have in the United States, we have about 1.7 million newly diagnosed cancer patients every year. About 20% of those patients are going to smoke at diagnosis, 340,000 patients. That's bigger than any of our big four. About a third of them could quit, about a third could reduce, and a third are going to continue smoking. That's using our current methods. But this is a profound issue that we've got to try and tackle if we want to try and make a big difference for a large number of patients. So as we move forward with a few solutions, I want to suggest the following. Smoking is a rock-solid critical determinant of cancer treatment outcome. Right now, evidence does not support analysis of clinical trials without considering smoking as an effect modifier. We have clear demonstrations that smoking affects overall survival and cancer-related survival, as well as toxicity. These are the primary and secondary objectives of our clinical trials, and this is something that we need to consider in the analysis. It doesn't mean that the clinical trials aren't significant. That's not what I'm getting at. It means that we need to, if we really want to identify benefit or harm, we need to think about smoking. Publication of results that do not report the effects on survival, toxicity, are at high risk for misinterpretation. And this is something journal editors should be aware of. There are groups, we may not be able to report smoking, but we need to try and find out where smoking causes an effect, where it doesn't, and we'll talk a little bit about maybe selecting the best cancer treatment based on smoking status. But right now, there were a couple of practice-changing studies in small cell lung cancer recently that had, I kid you not, 16-70% current smoking rates, no analysis of the effects of smoking on the outcome. And so there are conditions we really need to think about this in our publication. when we design research, we've got to think about this in our clinical design. That doesn't mean we add a lot. This is amazing how simple we can incorporate tobacco use into our clinical trial design. But this also requires substantive changes and focus from leaders in research, policy, healthcare administration, and so forth. There is enormous funding for immunotherapy, clinical trials, survivorship, things like that. There is almost no funding for smoking in cancer treatment. It's exceptionally difficult to try and do it, and there's a ton of excuses for trying to put it in. We need to change some of that work to, or some of that view to try and make progress. We've taken a look at this in cooperative group trials. This is a few years old. We looked at active cooperative group trials, and at the time we demonstrated that only 29% assessed any form of tobacco, but the tobacco assessment was extremely poor, and there was no assessment of tobacco whatsoever in 71%. Actually, we went back after this and looked at cooperative group trials that did collect tobacco information, and there was insufficient information for us to be able to correlate smoking with primary or secondary outcomes, because the smoking information was an optional collection instrument and it wasn't incorporated. So we made some progress there, but we're going to have to wait a while till we get good data out of trials if we start inflecting now. We've looked at oncology providers across 3 different surveys, ISLC, ASCO, and across NCI-designated cancer centers. And these are the largest surveys of oncology providers, very consistent, demonstrating about 90% asked about tobacco, and about 80% advised people to quit, but only about 30 to 40% reporting helping patients quit. And actually, if you look at patient surveys, it's about 15 to 20% say they received help to quit smoking. We went back and said, well, what are the predictive barriers? Because there's a lot of possibilities. You know, interestingly, more than 90% of respondents said that smoking affected cancer treatment outcomes and that cessation should be a standard part of cancer care. So it wasn't necessarily convincing on that effect. The predictive barriers to provide assistance was a lack of time, education, and resources. So we went back and asked, well, you know what, who would you like for us to help provide smoking cessation assistance? We gave all these different options. At the time, this was really funny, and I can't laugh, this COVID thing, if I laugh, I'm going to start hacking. So I won't laugh about this, but this was surprising because when we asked who would you like to provide cessation support, only 1% said they wanted to treat patients themselves. 50% said, I don't care who does it, just not me. And so trying to get oncologists to provide cessation support, there's definitely a role of oncologists, but getting them to provide support may not be an effective answer. 10% of respondents felt like they were trained adequately, but if we asked who could we train, 55% said train someone else. And so again, this is something that we need to think about where we focus our efforts. We went back and said, well, how can we try and address this? And at Roswell Park, when I was there before I came down to MUSC, we built the first, and I still think the largest, opt-out smoking cessation program. It was a phone-based program where we take all patients who came in, we screen them for tobacco use, and if they used tobacco, they were automatically referred to our cessation program. The cessation program would then reach out and try and contact the patients by phone and say, hey, this is our standard of care. We want to try and help them quit and get patients enrolled. This was remarkable. 12,000 patients that we analyzed, 2,700 people referred to the cessation program. Half of them we tried to call, and half of them we sent this big, fat, thick mailing. And in this case, we focused on the people that we called. We were able to reach about 80% of patients, and very few people refused participation. That means we got their interest. Doesn't mean they quit. It just means, hey, listen, you know what? I'm willing to try and participate. However, of the 1,381 people, we sent a big, fat, thick, brochure and information and packet that says smoking is bad. We're awesome. Give us a call. Only 16 patients contacted the cessation program. 16 out of 1,300 patients killed an entire forest for a very poor contact. So in this case, phones certainly work better than a mailing. I'm not a supportive person of mailing. I don't think that really gets us out of the problem. So we looked at this further, and I said, I'm a radiation oncologist. I have an active clinic, treat GI and lung, and I don't want to slow my clinic down. We got to figure out how to make this effective, because the researchers said we want 37 screening questions. I said, guys, that ain't going to work. Nursing's going to shut us down. Certainly, it got close to shutting us down, but we narrowed it down and found out that we could capture 98% of patients with 3 questions, and actually probably capture about 95% with 1. If we asked how long has it been since you smoked a cigarette, even a single puff, we'll get to the design here in a second. 1 question would capture about 95% of patients. That's good. That gives us an opportunity to do this efficiently and effectively. We also said, how often do we have to ask about this? Because in the general population, the smoking as a vital sign sounds great, but that's because you see patients once or twice or maybe 3 times a year. They come in every day for chemotherapy or radiation or something. You can't ask them every day. You got to wear the patient out, wear the nursing out. So we went back and found out if we extended asking patients to a month, if we asked no more often than once a month, we would delay needed referrals in less than 1% of patients. So we can ask 1 question once a month and do a pretty darn good job. That, to this date, I still think this is the only data that has looked at the efficiency of trying to do this in cancer care. Then we went back and said, hey, we got people in, we got them 12,000 people in smoking cessation. Well, does it have any effect? We got all these effects on clinical treatment, on mortality. Does our phone-based cessation program make a difference? Using the phone-based program at Roswell Park, we reduced mortality by 44% in lung cancer patients. So in addition to whatever they got for their first-line cancer treatment, we got them to quit smoking. They had a 44% reduction in mortality. That's outstanding. We could do phone-based support, broad reach. People are interested in participating. We get them to quit. We get a real reduction in mortality. And I would challenge anyone to figure out if there's anything we can add to first-line lung cancer treatment that addition will reduce mortality by 44%. I don't think there's anything else. I would also emphasize that we've expanded automatic referrals to more than just cancer care here at MUSC. We have opt-out inpatient cessation. Mike Cummings here has done an outstanding job leading this effort across the state. And when we take a look at inpatients, we were able to reduce hospitalization costs, reduce readmissions, and our cost per patient was about $30 to $35 per smoking patient. So the cost of providing support can result in significant reductions in readmissions as well as healthcare costs. And this is beyond the cancer sphere. So I would certainly advocate for trying to address this beyond just cancer care. Amazing how much easier it is for a team to work together when no one has any idea where they're going. I feel like this is kind of the mantra for the world right now. But one of the things we got to decide is how we're going to make forward steps and try and make our next steps as effective as possible. So when we think about cessation, this is going to just talk a little bit about how we might try to address this. We got to remember we got 3 different groups: patients, providers, and health systems. Patients really are limited with the ability to either choose to quit yes or no. And in this case, this may be the best thing they can do to make their cancer treatment better. Providers, we're limited. We can only provide, we can tell people smoking is bad, we can help provide support, but we are limited by what our health system provides and the resources that we have. And increasingly, we're having more and more restrictions on what we do for care. Health systems have the opportunity to make significant approaches, and we'll go through a little bit of how health systems can really change this. This can be, if we get our health systems to provide the resources to our providers in an efficient way, this really facilitates the ability for patients to try and quit smoking. I will be happy to say that we actually have done a good job of putting smoking into DaVita, so the Cancer Bible for oncologists. We've done this the past couple of versions, and we're doing another update as we speak. And so discussing tobacco in cancer care is very well, I'm tooting my own horn, I guess, but at least there's a very detailed discussion of this in DaVita. It can lead to other resources that can be used. We also worked very hard to get this in NCCN guidelines. Anyone who smokes within the past 30 days should receive support for smoking. And you might say, why do I have the 2015 edition? Well, I'm excited because this was the first edition. This is going to be a permanent slide. I wasn't a part of the cessation guidelines, but was a part of trying to help get this started. But when I left Roswell, not in NCCN, point of the matter being, this is a big deal. This is nice to have the support, and you can always say you're following NCCN guidelines. ACR and NCI really work to try and identify how are we going to ask about tobacco use this is a silly kind of thing to think about, but if I ask if you smoke, that's a lot of different possible answers. And so we work to try and figure out what's the best way to ask questions in research. And you can see that core items here, there's a whole bunch of additional items, but if you were to focus on one, I would focus again on how long it has been since you smoked a cigarette, even a single puff. And you can annotate your design to fixed variables that allow you to automatically make decisions for referrals or other decisions. So a single question can be effective not only at diagnosis, but also at follow-up. I've been very fortunate, excuse me. I've been very fortunate to work with NCI and with a lot of different centers. I've been to 80 different centers to try and help them build programs in the United States, Canada, and Australia. And I am very happy to say that the NCI really recognized the importance of this and funded the Cancer Center Cessation Initiative with 3 different cohorts, specifically to build smoking cessation, clinical smoking cessation support in cancer centers. I will also say that I've been working with the Canadian Partnership Against Cancer, and oh my gosh, the progress we've made over the past 5 or 6 years is enormous. I'm going to highlight that in a second. But this Canadian Partnership Against Cancer is an outstanding organization that really helped drive the logistics behind making a huge difference. And I'm going to give you an example of the difference we made. Across Canada, the vision statement, the clinical care statement for cancer care is that our vision is that every patient with cancer across Canada receives support to quit smoking for the best treatment and quality of life. This is not smoking cessation for cosmetic or behavior reasons or because your teeth or you smell bad. This is a national vision to quit smoking to improve cancer treatment and quality of life. I can't tell you enough how outstanding it is to have a national vision for cancer care that includes smoking to this degree. And the work over the past 5 years, we increased access across provinces in Canada from 26% in 2016 to 87%. 87% over the past 5 years. This has been a tremendous amount of progress with regards to access to treatment over the past decade, and certainly as a nation are doing very well. And this is the kind of information that we're looking at. You know, when we take a look at the metrics across different provinces in Canada, we made huge differences in the ability to deliver outreach, communication, partnership with leadership, medications, and so forth. So again, the work that we've done with Canadian Partnership Against Cancer, really outstanding and made a huge difference across the nation. This gives you an idea of the types of smoking cessation aids. A lot of times if you think, and the reason I keep using Canada as an example, when I started working in Canada 5 or 6 years ago, I thought, Canada, everything's the same. They all have their own health system. Everything works great. And I have learned a lot. It's like going through a whole other graduate program, learning about health systems. And every health system is different. Every system, every institution. The institution you have at Houston Methodist is going to be different than what we have at MUSC, different than Roswell, different with the quit lines we ran across all of Michigan to help cancer patients quit. Every institution's resources, strengths, and weaknesses are different. We have to try and focus on the strengths and weaknesses of these programs to try and help build a sustainable approach to provide evidence-based care for our cancer patients so we can get those survival and cancer control benefits. When you think about this gives you an idea of the different types of possible approaches. You can do a standardized screening where you identify smoking. On the left gives you some phone-based options. You can do phone-based on-site or off-site. Off-site could be something like a quit line. On-site could be a centralized service. You can do in-person, on-site, and off-site. But as it turns out, and we just finished analysis of our RO1 for in-person, and a lot of patients do not want to show up in person. As a matter of fact, our in-person show rates were very bad, but our phone-based were great. There's also interactive voice recorders, but again, the contact participation is probably less there. When we think about smoking cessation, you can come back and look at this slide because there's a few things on the right that are pretty busy, but really give you an idea. We got to think about how we manage cancer. We got something that leads to workup and diagnosis, treatment, follow-up, so forth. We're trying to stick this smoking cessation sort of here in the selection of treatment when we try and figure out cancer care. Well, we got to remember that we can address tobacco use across the continuum of cancer care. You can do this in primary care. It's a great outreach strategy, can really engage the community. You can get partners across the continuum of risk, workup, diagnosis, treatment, and follow-up. And you can emphasize tobacco across the patterns of care that patients have to emphasize the importance across the entire continuum of cancer risk and treatment. We got to remember that with this would work best if we integrate this well with primary care. The nice thing is that this can be a very easy message to primary care, who's probably been working with people to quit smoking for years before they saw us anyway. But we also have to remember that all of that effort's got to fit within a health system, and that health system has got to fit within a payment system. And so when we think about smoking, I will emphasize this is, I would actually say, fortunately, not a revenue generating activity. This is a cost savings activity. In the United States, that has actually made it difficult because we can't bill much for upfront services, but we can manifest in savings. And what I mean by that is we can have decreased second-line cancer treatment. I will also mention that decreased second-line cancer treatment means less drugs sold, less cancer care provided within a cancer center. And so there's a bit of a perverse financial disincentivization where since we are not able to provide as many medications, our revenues go down and so forth. I actually have an email in my folder of interesting emails that says due to the smoking cessation program and decreased revenues in the hospital, we have to talk about the sustainability of this initiative. And so everybody's incentives and thought processes are different. In this case, in plain terms, we can make a big difference for our patients, and we can have cost savings. Even if we don't bill as much up front, it can still make a very big difference for the outcomes of our patients. So when we think about the continuum of cancer care, we have an area of concern: diagnosis, consultation, treatment. We've been trying to figure out how to shorten this for a while, and unfortunately, COVID has made this work. I've got lungs that have been diagnosed in March and April that I'm seeing now. Same thing is happening nationwide. And I feel for y'all in Texas, at least from what I'm reading, it sounds like your basket is just as full as ours. But one of the things we've got to do as an oncology group is to try and communicate better with primary care and reintegrate. And if I was to say one of the next steps that could be extremely high yield, one, I hope this convinces you that smoking really is bad for cancer treatment, and you can start this afternoon. You don't need anything else other than engage your patients that you see this afternoon and say, hey, listen, smoking's bad. I've got to help you quit somehow. Find out how to do that. Find a cessation program with the institution. Send them to the quit line. Help yourself. I don't care how you get them to quit. I honestly don't care how you get them to quit. But if you can have them quit smoking, that can make such a big difference. And it can help their families too. However, one of the next steps that could be so easy is messaging by primary care. And what I mean by that is that it takes a while for people to quit smoking. They can't quit smoking today and start treatment tomorrow and expect to have a restoration therapeutic response. But what we could do is say, hey, listen, I'm worried about this finding. There's a lung mass or a breast mass or some rectal bleeding. I don't know what this is for sure. I'm going to work on this. But you know what? I'm a little worried about this could be cancer. And if it is, smoking really affects cancer treatment. And that's a very easy message for primary care to understand. Smoking affects cancer treatment. One of the best things you can do right now is to quit smoking, and I can help. So while we're working patients in, while we're getting them into screening, further workup, engaging about smoking cessation early can make, I think, a big difference. I would also say that you can build programs. The program we have here actually has gone up, but we built the smoking cessation program here in 2013. It was built to be a clinical service as well as to be used for research. And now the program that we built has 11.3. It's actually, I think we're going to get another grant, over $11.3 million in research funding since the inception, 4 R01s, 1 P50, and so forth. So you can build programs that not only provide clinical service, but also serve in a research capacity. What are the next meaningful steps? I want us to focus in, very important. You all have, Houston Methodist is in the news about a lot of different reasons, and you think proactively about how to impact your patients. I want to be very clear about that. You all do a good job. I hear about the work that you do, and the thought processes you have make a difference for our patients. So you, as Houston Methodist, have the opportunity to think about this. What are the next meaningful steps? We got 340,000 patients with smoke at the time of diagnosis. A third of them are going to quit or reduce, and if we get cessation, it's going to help impact those people. But one of the things we have not done well, and we can make enormous steps, is to stop thinking of smoking as a behavioral or social variable. If we start thinking differently and say, hey, listen, smoking is an effect modifier for an awful lot of cancer treatment, what is the best cancer treatment strategy for people who smoke at the time of diagnosis? And if we think about that differently, then maybe radiation is better than surgery, or surgery is better than radiation, or one systemic agent is better than another. And we're working now to try and figure that out, but we also have to work on that in our clinical design and research. This is effect modification. This is the last significant, or second to last slide. What we're doing today is going to affect about 1.6 million patients who smoke over the next 5 years. My suggestion is that we get everyone into treatment as a priority for starting cancer treatment. And this is my final question and suggestion. My question to you is it malpractice to omit smoking from cancer care, and is it scientifically ethical to omit smoking from research? Smoking has an enormous effect on survival, overall survival, cancer control, and toxicity. Those are our primary and secondary outcomes for cancer, clinical cancer research. I think that is my question, and my answer is that yes, I think it is malpractice to omit smoking, and yes, I think it's not scientifically ethical to omit it from research. I think we get bad results. This may be the cheapest, easiest method for us to improve outcomes and survival. Remember, it's difficult to comprehend how insane some people can be, especially when you're insane. I hope this talk has changed some of your thought processes. And I also want to point out the obvious. On the top left, statistics show that teen pregnancy drops off significantly after age 25. I don't need to know anything about how that study was organized. I think I agree with that result. So I hope you agree with me that smoking is important. And I'd be very happy to answer any questions.
Thank you for that.
Eric, by the way, I apologize. I can't hear you when you're talking very much, so I'm not sure exactly why I can't hear, but for some reason the line's not coming through. Let me know if you'd like me to stop sharing, or otherwise I can hear you about half the time.
Okay. Can you hear me now?
Yes.
Okay. Thank you for that. There are a couple of questions that came in, and then I've got some as well. The first one, I would love to have a one-page handout for patients regarding smoking and treatment response. Very good information. Is there a website? Is there a place people can go to? I mean, outside of a formal program, is there a place to either send patients or to print materials for the office?
So we have materials that I'm happy to share with you, and you can adapt to your own site that has information that we use. Most large cancer organizations now have bought into this, and we've made tremendous progress over the past decade. That being said, it's not extremely well organized, and I don't want to pick on American Cancer Society, but they still haven't really done this for cancer patients as much as we like. We certainly have information we can use for that. This afternoon, you can send people to the quit line, and that's a great start. I'm not saying it is the answer or the best answer. That's not what I'm getting at. It is definitely better than not providing support. And so I would say that you can give nicotine replacement immediately, and you don't have to write a script for that. And so changes can happen right away. With regards to smoking cessation programs, there are lots of options in Texas. Pharmacy-based programs, institutional programs. And again, we showed with the quit line in Michigan, I didn't put it in this presentation, very good participation using the quit line across community practices. So engaging with the quit line can be a great solution as well.
Great. Next question. Great talk. Have you seen any decrease in smoking cessation rates in the general population with lung cancer screening, the CT scans, giving false sense of reassurance if they have a negative CT?
Let me read that real quick.
So I think the question is, if a smoker has a negative CT for lung cancer screening, is that detrimental to getting them off tobacco, or is that an opportunity to educate and get them enrolled in a cessation plan?
So 3 things. One, CT screening for lung is a great opportunity to engage patients. and get them and help them recognize smoking cessation for benefit for cancer as well as heart disease, stroke, and so forth. 2020 report is a great reference for the benefits of cessation. It's very contemporary. Second, CT screening has been used by a crutch. There have been studies that show that people use that as a crutch to keep smoking and say, hey, I don't have lung cancer, so I'm fine. I'm just going to keep doing it. There's other studies that have shown some things that are different. And so, you know, in this case, I've seen studies that show both ways, and I don't know there's a clear consensus. I know there are things that national organizations want, but the evidence has shown a little bit both back and forth. Third thing, with regards to population impact, I don't know that in the context of CT screening that there's been a general population change. I don't think CT screening is necessarily going to be big enough to make a population change. We did see and I didn't highlight this, but our work in Michigan with the quit lines, we had 4,500 people when the quit lines for smoking cessation. We actually did see a decrease by about 20% in smoking rates from a separate behavioral research, the BRFSS data over that 5-year period we did the quit lines. That actually did decrease about 20%. So I think we are making some progress in some areas. CT screening, not sure from a population level it's there yet.
Great. Next question. Thank you for this excellent and thought-provoking discussion. I have 2 questions. Is there a correlation between smoking and PD-L1 activity or expression? And then the second question, with vaping and e-cigarette use on the rise, what is currently known, or with what is currently known, do you have any predictions regarding either possible oncogenicity or future public health concerns?
So with regards to PD-L1, we've actually looked at this in the lab, so I have two statements about that. One, in general, at least in lung cancer, PD-L1 immunotherapy seems to work clearly better in people who have a smoking history. I don't know about the data between current and former smoking. And what I mean by that is that I do not think we can justify continued smoking to try and get a better PD-L1 response. That is not a justifiable thing. The second thing is that we actually, from ISLC a few years ago, did extensive work, and I didn't present it here. There are clear associations between PD-L1 expression, modulation, smoking, and e-cigarettes, and the transition, as well as the constituents of e-cigarettes. It's fascinating. And there are a lot of implications to that. That's almost a whole other talk by itself. So I think from PD-L1, that's a very good question. With regards to the oncogenicity of vaping and e-cigarette use, I am very concerned about the bias in a lot of research now. I'm disappointed in the fact that we have people's feelings about e-cigarettes kind of shifting data towards one direction or the other. I anticipate that there's going to be some clear relationships between vaping and e-cigarettes and health outcomes. I don't know that they're well represented from the data right now. It'll probably take a long time. But I would also, my opinion, I'm not trying to change anyone's mind. I focus on cancer patients. If they smoke at diagnosis, I got to get them to quit. I want them to use nicotine, varenicline, whatever. If they use e-cigarettes and they stop smoking, I would rather have them do that than continue smoking, because I have 1,700 studies that show that smoking is bad for cancer treatment. I don't have one solid study yet that e-cigarette is bad for cancer treatment. So I anticipate e-cigarettes are probably not worse than smoking. We'll have to see. But I absolutely don't want patients smoking during cancer treatment.
Yeah, agreed. 2 other questions. With the expansion of legal marijuana, can you just discuss your feelings about cannabis and cancer risk?
I don't think I'm supposed to say this on a recording, and it's definitely not representing any organization, but I feel like the whole world needs to eat some brownies with marijuana in it these days. I think everyone needs to kind of chill out a little bit. With regards to marijuana and smoking and harms and benefits, I wish I had data. I don't have good, clear data on that. As an oncologist, this is a little different than this is a little tangential from smoking itself. I wish someone could ask some good questions about, would marijuana be useful for appetite, anxiety, and pain modulation in cancer care? I don't know what the answers are. However, if I can get someone off opioids and avoid constipation and the side effects, and if marijuana worked great, that'd be a great question. I wish someone would look at that. From a smoking standpoint, I'm not aware of any clear data, benefits, harms, or otherwise. I anticipate now is a time to ask those research questions, because now we have the ability to do that in the community, but I don't think it's there yet.
One of the big issues that's discussed a lot now around the topic of tobacco use, and certainly in the lung cancer community, is the issue of stigma. And how do you counsel people to kind of bring up the smoking cessation discussion while avoiding making the patients feel that they're being stigmatized for their choices in terms of behavior?
Well, we have to make sure we don't stigmatize them ourselves. I look at smoking the same way as having a nutritional compromise or having marrow failure after chemotherapy. I don't look at it as a lack of interest in their cancer care or anything like that. I am 100% converted to effect modification. That being said, I hope that the way I communicate with patients is not stigmatizing. I always encourage progress. I always tell patients I'm going to give them the best care, whatever their decision is going to be around smoking. And I 100% realize that smoking affects just about every cell in the body. Almost every cell in the body has got nicotinic receptors. And whenever you have something that's tickled those receptors for 40, 50, 60 years, and then you try and take it away, especially when you've got a cancer diagnosis, it's going to be hard. We have got to understand that this is an addiction with a rock-solid biologic justification that also is a huge effect modifier for our cancer treatment. Our job is cancer care, right? How are we going to achieve the best cancer treatment outcome? So looking at smoking as an effect modifier for me, and I think works very well, and I try and look at it in that same sense. Making sure we start with an empathetic, non-stigmatizing approach to our patients, I think, is a great first step.
Great. And one last question. As you had pointed out at the end, I think it's easier to sell health systems or hospital administrators on revenue-producing interventions rather than cost savings. And I'm curious if you think with the ongoing avalanche of data of not just the benefit to the patient, but the global decrease in funds for paying for subsequent illness, do you think we're going to really be able to see a expansion of support for the folks that we need to really have a successful smoking cessation program across this kind of fragmented healthcare system we have in the United States?
You know, and Eric, I think the word fragmented has been growing in my mind beyond even smoking. We have to have a commitment that we really are trying to improve outcomes and not trying to maximize revenue. And business models in healthcare really push revenue. They really, really push revenue. In Canada, I will give an excellent example. Canada in 2015 was behind the U.S. in addressing tobacco and cancer care. No one was doing it really well, but the U.S. was doing it better, I think, than Canada. Canada accelerated to where we now have access in 87%. 87% of provinces in Canada have access to cessation in cancer care, including national prioritization as a standard part of cancer care. They have completely outpaced the United States. They are leading internationally. One of the strongest rationales is that they recognize the cost savings. They're not trying to maximize upfront billing. They are recognizing, engaging, and actively trying to participate in cost savings. So I wholeheartedly wish we could change our thought process, but the political influence for revenue is overwhelming in the United States. I'd love that for me, the next 10 years is trying to work on how we can make progress there.
Well, we'll see. Thank you. Thank you. It was a very important and wonderful talk, and I know you're recovering from breakthrough COVID, so we wish you continued health, and thanks again. Really appreciate it.
Thank you for having me.
Go ahead. When I invited this next speaker, I should have thought that I was going to have to pronounce his last name, and I'm going to do my best. Not that that's a reason not to invite someone. We're going to move on to our next talk. Dr. Setkunasevam is a urologist here at Houston Methodist. He has a focus on minimally invasive and robotic approaches to the treatment of genitourinary malignancies. He received his medical degree from the University of Toronto. There's a Canadian theme through the talks so far. He completed his urology residency also at the University of Toronto and did his subspecialty fellowship training in urological oncology, advanced robotic, and laparoscopic surgery at the University of Southern California, where he developed novel techniques for robotic kidney-sparing surgery. So he's going to talk to us today about new paradigms for bladder preservation in non-muscle invasive and muscle invasive bladder cancer. Raj, I'll let you kind of come up.
Thank you, Eric, and thank you to the organizing committee for the opportunity to speak about something that's very near and dear to my heart. And really, the focus of this talk is to look at novel ways in which we can preserve bladders, and it really transitions quite nicely here. We're talking about a very heavily environmentally driven malignancy in which smoking plays a huge role. And while I'm talking about a lot of novel therapeutics, Dr. Warren has clearly reminded us also that, talking to our patients about smoking cessation still remains a very important priority. I do have some conflicts of interest related to this talk that are important. I have served as a site PI on several immune checkpoint inhibitor-based clinical trials in the treatment of BCG-naive and BCG unresponsive bladder cancer, and I'll be talking about the utilization of immune checkpoint inhibitors in this space. We're going to basically go through the current paradigm in the treatment of non-muscle invasive bladder cancer and then focus on novel paradigms that are emerging for treating unresponsive or BCG unresponsive non-muscle invasive bladder cancer. Then I'd like to take you through some of the issues that we face in treating muscle invasive bladder cancer and some of the emerging themes in trying to preserve bladders in a much more advanced and more aggressive disease that muscle invasive bladder cancer is. This is important for us to start off with by saying the predominant histology when we talk about bladder cancer is urothelial carcinoma by far and away. And overall, bladder ranks as the sixth most prevalent cancer in the United States. And it is a very expensive cancer, perhaps the most expensive cancer to treat based on the amount of healthcare utilization, particularly the operative room utilization amongst other cancers. We make this diagnosis by a variety of methods. The most important is an endoscopic assessment of the bladder to directly visualize the tumor called cystoscopy. We also utilize the ability to look at cells under a microscope that are shed from the urine and identify pleomorphic cells. Here is a picture of a abnormal-looking bladder tumor cell that's being shed into the urine. And of course, imaging plays a really important role in helping us clinically stage bladder cancer in terms of depth of invasion, but also look at concomitant cancers that can arise anywhere along the whole urothelium that are really important. So both CT and MRI are important. And the next step for our patients, once we've identified a tumor, is to go to the OR and perform what's called a transurethral resection of bladder tumor. And this is a procedure that is fundamental for us to go in and pathologically assess the depth of invasion of the bladder tumor. It is critical for diagnosis, and it is furthermore can be completely therapeutic if we're able to remove the entire tumor and it turns out to be not a deeply invasive tumor. And so this is the crux of the matter. We try to, obviously, in this field, match the aggressiveness of therapy to the aggressiveness of the cancer. And there's a real division here in terms of pathologic staging. So the tumors that are limited to the submucosa, to the lamina propria, are termed non-muscle invasive bladder cancer, and they account for about 75% of tumors overall. The other 25% are muscle-invasive bladder cancers that are invading deeper. Particularly, we're interested in invasion into the propria, the muscle, detrusor muscle, and potentially even deeper and potentially past the bladder as well. The AUA and the Society of Urologic Oncology has established very clear staging systems that help us stratify patients into the highest risk versus the lowest risk. The highest tend to be the tumors that are deeper into the bladder, those that have high-grade features under grade. And you can see that this is in quite a different contrast to the low-grade tumors that tend to, first of all, not progress very much into higher stage and do not recur as much. If they do, they can be easily handled and easily cured. However, the high-risk ones really tell us that these have higher chance of progressing to more lethal disease, and not only that, they are oftentimes coming back. And so about more than 3 decades ago, really one of the earliest uses of immunotherapy was in intravesical therapy. This is work from Dr. Al Morales, who showed that using BCG, which is an inactivated bacterium, Mycobacterium bovis, that's placed into the bladder, can elicit a response in the first 9 patients that were treated with intravesical immunotherapy. Since that time, there's obviously been a lot more work to really understand the underpinnings of this. We understand that BCG attaches to the cell surface by binding fibronectin, and really there's 2 pathways. One way is to get taken into the bladder cancer cells, causing cytotoxicity and release of antigens. And the other pathway is obviously through antigen-presenting cells. Overall, this really leads to a Th1-directed response, and there's both the cytotoxic T cell response as well as an NK response that's elicited. There's a significant amount of level 1 data that we stand on when we try to use BCG in the clinical setting. We know that it clearly reduces recurrence in comparison to intravesical chemotherapy. It also reduces progression to greater stage of disease. This is a pivotal study that showed us that BCG can't just be given as an initial induction phase, that is, we give once-a-week treatment for 6 weeks, but indeed we need to reprime the immune system and help it remember as it continues to maintain surveillance. And so this is a randomized pivotal study that showed us that clearly giving a total of 3 years maintenance with an interval usually about 6 months in between treatment is better than just induction alone, both in terms of recurrence-free survival and progression-free survival. And this has really been adopted as the standard of care now based on this SWOG study as well as data that's been replicated in Europe. So what I want to really focus on is what happens when BCG fails. Our guidelines tell us when BCG fails, the standard of care is radical cystectomy, to really talk to the patient about radical cystectomy, because the risk of progression in those who have failed BCG is quite significant. And radical cystectomy offers the highest probability of cure, highest probability of long-term survival. And this is really mirrored in this data here. If you look at patients whom have failed BCG, and these patients were either given an opportunity to proceed with early cystectomy or chose to have further BCG, you can see the clear separation in this Kaplan-Meier curve that this actually translates into a 5-year separation in cancer-specific survival that is quite significant. So we always want to keep this in mind. We're always talking about not just early cystectomy, but timely cystectomy when it's appropriate. But we all know that doing cystectomy in all patients is not feasible in the setting of BCG failure. First of all, many of our patients have many comorbid conditions and they're medically unfit for surgery. Obviously, we don't have everyone lining up at our front door for cystectomy. There is obviously a certain amount of patient refusal. And the surgery itself is a complex surgery with many moving parts, and there is certainly very detectable perioperative morbidity and mortality with this procedure. And so it was in 1998 that the last approval for BCG-unresponsive disease was seen with valrubicin by the FDA. And in 2015-16, there was quite a bit of talk about how does the FDA and how does the field spur innovation and creation of new drugs for registration in this space. And this really was highlighted by a white paper that was published and then subsequently revised. I'm showing you the 2018 paper, but the most important thing is that this served to highlight and harmonize the definition of what we consider to be unresponsive disease. It helped both industry and investigators really focus on what would be most critical for a registration trial in this space. And lastly, defined what would be acceptable in terms of the primary outcome that would be studied in a single-arm phase 2 type of registration study. I won't get into this in detail. It's a very thorough, complete definition, but basically what it speaks to is that we want to identify people that are most likely to not benefit from further BCG, and the definition basically has to include a way to say that they have adequately received BCG and that the timing of the recurrence signals aggressive disease and that they're coming back and recurring with disease that we do think is clinically significant and is aggressive. So how do we improve preservation in this setting? I told you that cystectomy could do it. Obviously, cystectomy is better for long-term survival, but we want to preserve bladders. And so the idea and the way that the field is moving is to try and induce better responses in the BCG-naive setting, and then really develop novel strategies in the unresponsive setting. And a lot of what I'm going to focus on and a lot of the development that has happened is in using novel immune-based therapies. This is probably very familiar to this audience, but I want to point to this, what is the cancer immune cycle, and really therapeutics can be developed at various stages in this cycle, starting from the point of increasing antigenic release from the tumor, as well as improving presentation by antigen-presenting cells, as well as affecting their homing and presentation to T cells. Obviously, the homing of T cells, recognition by T cells of the cancer, and lastly, obviously, the action of T cell-mediated killing of tumor cells. And so I will break down some of the big categories of looking at our immune-based strategies that are available now into BCG strains that are available and the engineering of BCG, vaccines that have been developed, viruses that are being developed, and of course, a lot of work has been done in immune checkpoint inhibition. So there's been work that has recognized that strains of BCG matter. Obviously, there's been a phylogenetic separation as geographically these strains have been separated. And this is a comparison of BCG Connaught strain versus Tice, which we have in North America. And there's a clear separation here, both in terms of recurrence and progression. This is somewhat of a moot point right now because we actually only have one strain of BCG available to us in North America. And this is a real important point also because as we're trying to treat high-risk non-muscle invasive bladder cancer and we were utilizing BCG quite frequently, we've had to put up with quite a bit of shortage, particularly related to not being able to keep up with the demand. And so this leads us to a very important SWOG trial that just finished accrual last year, which we were able to participate in. The PI is at San Antonio, Rob Svatek. And why this study is really important is that it's a registration study for a new strain of BCG called the Tokyo 172 strain. And so I'll tell you why the PPD is important in a little bit of time, but this is a study that's going to introduce Tokyo BCG potentially to North America in the next couple of years once we have a readout on the efficacy of it in comparison to Tice. And in addition to looking at this as a different strain that might be useful for us, it's also important because this is testing the concept of vaccination with BCG. As you know, PPD rates in North America are relatively low, probably lower than 3% of our population. And so in those patients who are negative, the study uniquely tries to prime them with an intradermal injection of Tokyo before they receive it intravesically in an attempt to improve the efficacy. So strain differences might be important. What about engineering the BCG such that it has a better effect? This is BCG that has been engineered to express the listeria toxin, and once the BCG gets taken up inside the phagosome, as you know, listeria toxin ends up leading to lysis of the phagosomal membrane as well as the cellular membrane, releasing a far more potent antigen release, and can potentially lead to uptake by CD8, uptake by dendritic cells and cross-presentation to CD8 cells, which might be very important. So again, the BCG might be engineered in a way that could be more efficacious. Vaccination, of course, BC was a vaccine and has many other ways in which it's working, but other sources of vaccines are available. This is an interesting one that's being developed using human allogenic tumor cell line, which expresses a variety of antigens. Many of them appear to be obviously very important in bladder cancer, and they've included a heat shock protein together with this cell line called GP96. And what that heat shock protein is doing is really taking these antigens together as an adjuvant carrier to dendritic cells, leading to much more optimal CD8 T cell activation, and so potentially better responses this way. I'm going to spend some time on this virus, which is really important because it's going to come into the clinical sphere very soon. Instillidrin, which the phase 3 trial, or rather phase 2 pivotal trial, was published recently this year. So Instillidrin is a replication-deficient recombinant adenovirus. Clinically, we've used interferon alpha in the bladder together with BCG to try and improve the response, but the idea here is that this vaccine is going to co-opt the cellular mechanism in the bladder and try to produce much higher concentrations of interferon alpha in the bladder. And as I showed you, the thing that we're interested in is complete response of carcinoma in situ, and this registration trial showed that in patients with carcinoma in situ, the complete response rate at 3 months, pretty good at 50%. The durability does obviously fall off, and we're looking at about a 24% sustained complete response at 12 months. Importantly, I think this is also always the flip side to look at, is how well this is tolerated. About a 4% grade 3 to 5 adverse event profile with this drug that's given intravesically. Other viruses are important. This is an adenovirus that's being developed. It's engineered such that it replicates only in cancer cells because it has a promoter that is only responsive when retinoblastoma is deficient. And so in this situation, it's going to replicate and kill cancer cells, but it's also going to produce GM-CSF, which is obviously a potent stimulator of the immune response. And this is given intravesically, and phase 2 data is obviously already a little bit available. At the interim analysis, there appears to be a very respectable CR rate that's been seen, and most encouraging is the side effect profile. That is, a very low rate of adverse events. This used to be shown at every slide before we talked about immune checkpoint inhibitors. This audience is very familiar with the vast array of the emerging ones. I'm going to focus on the PD-1, PD-L1, as well as CTLA-4 blockade. This makes a lot of sense from preclinical models. This makes a lot of sense from expression. This is a very often cited paper looking at PD-L1 expression in patients who failed BCG therapy, and you really see enrichment in granulomas of these patients of high PD-L1 staining, and really served as motivation for how do we bring this therapy into an earlier stage. We all know about the approvals in advanced disease. Even as recent as last week, we saw the FDA approve nivolumab now in the setting of adjuvant muscle-invasive bladder cancer. So we know it's active. It makes sense to bring this in earlier. And the first study of this was Keynote 057 that was published quite recently. And the response rate that we're interested in here is a complete response in the carcinoma in situ population at 12 months. About 1/5 of patients maintain a durable, complete response at 12 months. The adverse event rate at 3 to 4 was about 13%. Similar study, similar results. This was presented by Dr. Black at ASCO 2021. This data is not yet published, but with atezolizumab in a very similarly designed study, very similar response rates. So right now, the state of the art for BCG non-muscle invasive bladder cancer, we do have an approval for pembrolizumab from Keynote 057. Instilodrin is before the FDA. I think it's important to look at both the complete response rate. We have much work to do. This is about a quarter, roughly, of our patients, but there is certainly a difference in terms of adverse events profile that we'll have a discussion with. The interaction and the frequency of doctor visits are important. And I think moving forward, we'll really think about what will be the comparator arm of future trial design. I think that's really important to also think about. I'm going to switch gears and move to muscle-invasive bladder cancer. This is a disease that is far more aggressive, obviously. Once the tumor is into the bladder, the standard of care based on level 1 data is to treat these patients with cisplatin-based neoadjuvant chemotherapy and proceed with radical cystectomy as the gold standard. But I also want to talk to you about an emerging acceptable and very good treatment in terms of trimodality therapy with radiation. Partial cystectomy is really not utilized in this setting. It's very rare that we're able to do that. Radical cystectomy is radical. It involves removal of in men, the bladder and prostate. In women, it's really removal of the bladder and many times the reproductive organs. Lymphadenectomy is a critical part. As surgeons, we really know how important it is in bladder cancer care and muscle-invasive bladder cancer, both from a diagnostic, but we also know that it is critical from a therapeutic point of view as well to sample these lymph nodes adequately and in the regions that make the most sense for us. This is the typical view, of course, of radical cystectomy for most patients who perceive that once the bladder comes out, many times the only solution will be a diversion where they're left with a piece of bowel that has been brought to their skin through which they're incontinent with urine. And many times this is often the case. However, the field, of course, has continued to move forward. A strong interest of ours is orthotopic diversion, where we are using larger segments of bowel to reconfigure bowel in the shape of a sphere and connect it together. And our field has moved quite a bit along using level 1 data and comparisons with robotic and open surgery to really test from a cancer point of view, from a technical point of view, from a quality of life and complication point of view, where robotic cystectomy is potentially able to deliver a better outcome in some patients and in some benchmarks. And really, this is the state of the art of where we're at right now. This is a quick example of what we do with patients who desire and are able to have orthotopic diversion, where we've connected here a piece of bowel that's been reconfigured in the shape of a bowel to the urethra, and we're reconstructing the anterior part and really have created a replicate as best as we can of a bladder. This bladder, however, is not the best bladder that we can hope for as an off-the-shelf bladder. It doesn't function the same way. There's much to be desired, and as much as we want to push forward in giving patients this option, I think it's really critical that we continue to look at bladder preservation. And we've had a very good way of preserving bladders for some time, and this is trimodality therapy, which is very importantly the combination of completely removing the bladder tumor and combining this with concurrent chemotherapy and radiation therapy. This is work that I was able to work on at the Princess Margaret, really showing the comparison of these two modalities in a prospective cohort. And there's very respectable 5-year disease-free survival when you really match these types of patients. But as you guys know, there is obviously a lot of controversy, and we look at why this hasn't been adopted as well in North America. I think it's partly because of the lack of randomized data and the difficulty in providing randomized data of surgery versus radiation, which we're all aware of. In addition to that, obviously, the selection is very, very important and can be very limiting in terms of this type of treatment. And lastly, there remains ongoing controversies regarding functional outcomes. How do these bladders do in the long term? And that has been one of the issues that we continue to debate on and have thoughts about. So how do we move the field forward and preserve bladders better? I think broadly speaking, do trimodality therapy more, do it better, and really think about how can we induce a better clinical complete response if possible. In these patients, can we forego cystectomy? If we've got a complete clinical pathologic response, can we not do cystectomy in these patients? So this is a study that is looking at trying to improve trimodality therapy. This is the SWOG 1806 study that combines standard of care trimodality therapy with 9 cycles of atezo, and the important outcome is a new one called bladder intact event-free survival that will show us whether or not this additional combination of immune checkpoint inhibition can improve bladder retention in these patients as well as survival. This is a phase 2 study that I'm going to briefly touch on, that not only is it important to look at addition of immune checkpoint inhibition, but obviously the modality of radiation is important. So this is a triplet therapy that Dr. Ballar presented at ASCO this year, of looking at pembro in addition to a hyperfractionated regimen of radiation therapy with lower dose gemcitabine. And they had very respectable early data, a little bit over a year, but very respectable early data, obviously signaling that we need to be thinking about other forms of radiation therapy. And this really dovetails into what we're interested here in collaboration with our radiation oncology colleagues. We have opened a new clinical trial really looking at the role of high-dose rate brachytherapy and how this may be translated into bladder cancer in our study that's termed the DEFEND muscle-invasive bladder cancer study. Using brachytherapy is actually quite common in Europe. It's been adopted actually into their guidelines. And really, this study has been motivated here in North America, and for us particularly, is to try and understand if we can really push towards a focal strategy. So what we're trying to do is to combine a neoadjuvant therapy with very careful patient selection and a subsequent robotic implantation into the scar or tumor with brachytherapy catheters, and coupling this with many of the standards of care and treatment, which is a lymph node dissection as well. And the idea here is to not only figure out the best dose scheme, but also to identify and understand those patients that have the best objective bladder function return. So I'm going to show you what this looks like in real time. This is actually a cadaveric lab that we did and demonstrated robotically how we can implant these catheters. So this is a fresh cadaver. This is a catheter being introduced in through the anterior abdominal wall. This is all done robotically with the patient anesthetized. And what we're doing is tunneling the catheter in order to place our brachytherapy leads through the detrusor through the bladder in a very specific manner, using actually guidance from a cystoscope to really target the tumor. These catheters are now placed robotically. The patient has a lymph node dissection, and when they finish, they basically are waking up with their bladder intact, but several of these catheters. Believe it or not, this is very much well tolerated in terms of pain control, and I'm not sure if the simulation is going to be shown here, but we can really target that area for focal escalation of radiation therapy. So we look forward to being able to report on the quality of life. I want to end by focusing on this other concept here, which is really important in trying to induce better rates of complete clinical response by using neoadjuvant therapy. We already know this exists. We see about a 30 to 40% complete response after neoadjuvant chemotherapy with standard cisplatin-based therapies. When we follow patients who have had pathologic complete responses after cystectomy, there's a clear separation. And really what we're trying to see here is whether clinical complete response after neoadjuvant therapy can be thought about as a very good biomarker that can help us predict those patients in whom we don't have to do anything further to their bladder, such as radiation or surgery. The definition has been challenging. I'm going to talk to you a little bit about what that is. So one of the strategies might be, well, why don't we pick the people that will most likely respond to neoadjuvant chemotherapy? So this is an example of a genomically driven strategy that the group from Fox Chase presented recently. This is from Dr. Gennisman. And they defined patients genomically by identifying those who had mutations in ATM, ERCC2, things that are DNA damage response, and gave these patients accelerated MVAC regimen. And there was a substantial 46% amount of patients that had mutations of interest, and 76% of these patients did have a clinical pathologic response and were put on surveillance. Early data, short follow-up, proof of principle, much to be done in terms of identifying who fails, but we're really starting to see the signal for how these can be followed. Here's another concept that's emerging, because you've seen a huge explosion in combinatorial therapy in various stages of disease. This is combination of immunotherapy with chemotherapy in the neoadjuvant setting. This is doublet immunotherapy, really pushing our complete response rates from the 30-40% range, now pushing towards the 50%. Well, if we can do that, Dr. Galsky and colleagues at Mount Sinai asked the question, well, can we induce a better complete response rate by combining chemotherapy with nivolumab in muscle-invasive bladder cancer patients? And of course, they did this very thoroughly, and here is a great example of how to really define clinical complete response. It included not only reassessment of the bladder pathologically by taking patients back to the OR, but MRI, which we believe is superior in terms of staging, cytology. And then, amazingly, about 50% of their cohort had a complete response rate. Though they offered cystectomy or surveillance to those patients, of course, patients want this, and 30 of the 31%, or rather 30 of the 31 chose to be surveyed. Early data right now, they're not quite at the 2-year landmark for their analysis, but we can see that there are signals to be optimistic. I think the big question that's going to be answered here is, are we able to salvage those patients that have local recurrences on surveillance? And are those patients who are salvaged, and i.e. having delayed cystectomies, are they going to have as equal outcomes as those with de novo de novo muscle-invasive bladder cancer? I'm going to shift focus a little bit and talk about what we're doing and what our group is interested in here as my last topic. We're really interested in pushing forward response rates in the bladder in addition to immune checkpoint inhibition. And one of the strategies that we've been interested in is the concept of in situ vaccination. We know that radiation is an obviously important tool in the treatment of bladder cancer. What we're really interested in this study, which is a phase 2 study, is to look at a regimen of radiation therapy that's given sequentially after a PD-1 blockade. And the sequential nature of this is really important. And the type of radiation therapy that we're doing is one that is immune stimulatory. This is not an ablative dose of radiation therapy. And this is really born out of a lot of literature, including neoadjuvant work in non-small cell lung, that we're hoping pans out in the bladder space as well. Our goal here is to try and combine an immunostimulatory dose of stereotactic radiation on the backbone of sasanlimab, which is a PD-1 targeted antibody, to try and induce an improved pathologic complete response. We have some obviously important endpoints to look at, but what we're really interested also in this study is to identify signatures, both from a genetic point of view, but also from circulating tumor DNA and looking at the immune phenotype in these patients so that we can then take back and really understand who achieves a complete response so that we can inform better who are those patients in whom we may never need to do cystectomies. And I think this is really exciting. I've talked to you about multiple immune-based strategies. I think these really hold promise in non-muscle invasive bladder cancer, and we have a lot more options available to us than we did about 10 years ago, which is exciting for our field. I think we have to do a better job of widely adopting trimodality therapy than we do currently, and really examine novel approaches to radiation therapy, and really push the needle forward to try and push complete response. And at the same time, make sure that we are able to safely salvage these patients that would have local failure before distant failure. I really want to end by thanking everyone that I've had the opportunity to work with, mentors, collaborators. This is not work that we can do alone, and I really would like to thank everyone that supports our group. Thank you.
I think is this on? I hope it's on. That was Outstanding question, outstanding talk. Let me ask you some questions that will probably reveal more of my ignorance than anything else. But I'm curious, a number of years ago, there was a lot of excitement about green tea in affecting, for non-invasive bladder cancer. Has that gone anywhere in terms of active agents being useful in green tea for, I guess, chemopreservation?
Yeah, I think I'm not aware of the data, but I think that there may have been some index lesion studies that quite, didn't pan out, but I'm not aware of that data.
You can still get it at Whole Foods. They will be happy to sell you a lot of green tea. I'm also curious if the protocols that are being looked at for surveillance are incorporating ctDNA monitoring as a routine matter of course at this time.
Yeah. So I think ctDNA, as you're aware, in many other disease spaces, has made its mark. We're really interested in it both as a prognostic and predictive biomarker based on data in the adjuvant space after bladder removal, and really trying to figure out who are the best patients that are going to respond. But we're going to start seeing it move earlier into the disease space. So our trial design does have that as an exploratory marker. Interestingly enough, some of the data that came for ctDNA, and there's various forms of ctDNA, as you know, there's a panel-based approach, of course, but there's an approach that has more recently been published, really trying to look at what is more of a personalized and a tumor-specific strategy in that patient using the actual, sequence of the tumor. And that not only panned out in terms of a signal in the adjuvant space, but there was data also from the neoadjuvant space that having a positive ctDNA signal could predict response in the neoadjuvant. So we're really curious as to do that. But I also think instead of just defining positivity and negativity, I think we can actually do a little bit better and look at actually, how well the sequences that are circulating match what's going on in the bladder. The thing that I didn't spend a lot of time talking about is the heterogeneity in this disease, and a lot of work that's gone into subtyping bladder cancer and how they really respond differently to treatments. And I think that type of data can be useful for not only just picking up positive and negative, but also subtyping potentially as well.
It's fascinating. Again, a question from a non-surgeon. So in so many diseases now, we know that the number of resected lymph nodes is a crucial marker of quality and gives us more information. Has that been shown with cystectomy? And also, do you use anything like sentinel lymph nodes, or is there any imaging to help find the optimal amount of lymph nodes when you want to resect at the time of surgery?
Yeah, that's a really important and really good question. We spend a substantial amount of time focusing on lymph node dissection in the surgery because every single data that we looked at prospectively, retrospectively, has pointed all in the same direction, that both lymph node count and density are really important in terms of diagnosis, but also therapeutically. And of course, this needed to be tested. So SWOG 1011 was a really important randomized trial of extended versus limited lymph node dissection. They've completed accrual. We'll hopefully get readout in the next little while. And so really get a sense of how aggressive and how much lymph nodes that we want to remove. There's been some data from a German group that's already done a similar trial where, it really didn't make much of a difference. But what has happened is, we believed in lymph node dissection so much that if you looked at limited lymph node dissection to historical controls, we were already just really comparing super extended to, extended. So I think this is an example where we really believe as a field very consistently across the value of it, but we're waiting obviously on level 1 data, which will be important. Our group is actually interested in the concept of sentinel lymph node biopsy. We don't have that currently in bladder. We're looking at a porphyrin-based dye that gets preferentially broken down in bladder tumor cells. This is technology that's utilized to detect and identify very difficult to identify cystoscopic tumors from normal bladder. And so we have a phase 1 trial that we're designing, just a safety trial, to see whether we can get potential transport through the lymphatic system, and then using a laparoscopic approach to try and see whether we can see fluorescent lymph nodes. So I think that would be useful for our field.
A question from the virtual world. At this time, does the genomic landscape of bladder cancers influence treatment decisions for trimodality therapy?
No, but I think what's going to happen is the exploratory biomarkers that are being collected from the phase 3 studies are really going to help us, because we have a lot of retrospective data, and the training sets are all based on retrospective data. We have biomarkers that we can basically stratify patients on who's going to respond to radiation, potentially based on radiation sensitizing genes, immune infiltrated phenotypes, more chemotype phenotypes. But that's again based on retrospective training data sets. Now I think with prospective collection, I think we'll have a better example. SWOG 1806, which is that trimodality big study, that's going to really have a lot of side studies from the prospectively correlated and collected biomarkers. I think that we'll be able to have some answers for that. But as of now, we don't have a tool that tells us that this is a patient that better responds to radiation therapy than surgery.
One last question. There is some retrospective data suggesting patients with pathological node-positive disease may have worse outcomes. Would you recommend adjuvant radiation therapy or chemoradiation in these patients with pathological node-positive disease following neoadjuvant chemo and cystectomy, or patients who are found to have positive surgical margins?
Yeah, good question. I think it's important to separate, nodal dissection. We do a very, very systematic and level-based approach. Pelvic nodes behave very differently than above the bifurcation of the common iliac nodes. We can achieve in pelvic node positive disease with systemic therapy and consolidative surgery or radiation a durable control rate about 50% at 5 years. It's not great. I think it's really important to separate out what pathologic node positivity means here. If we're talking about a high lymph node, I think the chance of cure with any local therapy is very difficult. So I would really question the value of adjuvant radiation therapy in that setting. If you really look at our data for adjuvant radiation therapy, it's a very great idea, but we've been able to not accrue patients to any randomized trials to that. And if you even look at the NCCN-based guidelines, it's really based on very low-level evidence. So I think we need to, I don't think we're going to get a randomized trial on that. But I think there is a role in carefully selected patients. Patients with positive surgical margins, unfortunately, have a death sentence in this disease. This is really, really, really important from a surgical, technical quality benchmark for us. Radiation may be able to salvage some of these patients, but it's very, very challenging.
Okay. That was great.
Thank you.
That was wonderful.
Thank you.
Appreciate it. Welcome back. We have 2 more wonderful talks for you as part of the morning session, and then on to the lunch keynotes. It's my privilege to welcome our next speaker, Dr. Alessandro Grattoni. He is the professor of nanomedicine at the Academic Institute, and he's the chair of the Department of Nanomedicine here at Houston Methodist Research Institute. He's also the Frank J. and Jean Raymond Centennial Chair at Houston Methodist. He obtained his bachelor's and master's degree in mechanical engineering in Turin, Italy, and then, fortunately for us, in 2006, he came over to join Dr. Mauro Ferrari's research team in the Department of Nanomedicine and Biomedical Engineering at University of Texas. And then, obviously, has come over to Houston Methodist, where his lab is looking at a number of innovations using nanotechnology to really kind of influence the tumor microenvironment. He is overseeing the nanochannel delivery system project, and he's going to talk to us today about how this exciting technology hopefully one day can make major improvements in just how we deliver therapy for a variety of cancers. And we all know what Florence is to the world of art, Houston is to the world of nanomedicine. So, Dr. Cotoni, welcome.
Well, thank you very much again for the introduction. I'm very pleased to present today for this Cancer Center Symposium. I'm actually at the Kennedy Space Center in Cape Canaveral, Florida, because we have one of our experiments of nanomedicine going on to International Space Station tonight, flying on a SpaceX rocket. So I did my best to make sure to be able to present to you while at the same time preparing for the experiment. So it's a little bit of dealing with a number of things happening at the same time. But I'm pleased to present to you today about our intratumoral implant for cancer immunotherapy. So in the Department of Nanomedicine here at the Houston Methodist Research Institute, we have developed a number of different technology platforms that can be used for cancer therapeutics or cancer diagnostics. And they are typically related to nanoparticle systems that can host a set of different therapeutic compounds such as chemotherapy or immunotherapeutics. And but we have also looked into particles that can serve as radiosensitizers for radiation therapy, image-guided radiation therapy, as well as multifunctional particle systems that can be used for imaging and diagnostics and therapeutic application that can be regrouped in the field of theranostics. But today I will focus primarily on the intratumoral drug delivery as a mean to abrogate some of the challenges associated with systemic administration of therapeutics, which, as we all know, they are, while practical, they are in many instances affected by low therapeutic index and high toxicity. So the intratumoral approach and drug delivery approach has really been explored more recently, in the more recent year, by numerous groups around the country, around the world, given the opportunity for high therapeutic index and low toxicity to the organs around the body that would not be affected by the treatment themselves. But of course, there are disadvantages that are linked to the treatment difficulties with reaching the tumor in the first place. So we are also focusing more on the intratumoral immunotherapy. So the idea of the intratumoral immunotherapy is to leveraging the existing immunoinfiltrates within the tumor microenvironment to trigger an abscopal response that perhaps from treating a primary tumor may be able to have an effect on distributed metastases around the body, while at the same time minimizing toxicity of the treatment. As many of you are aware, there are numerous preclinical studies ongoing in this field, and several clinical trials that are currently ongoing or they are recruiting right now. I will talk about two major platform technologies in my laboratory, one of which is a nanofluidic drug-eluting seeds. We like to call it NDES. Is a very small implantable device that is the size of about 1.3 millimeter in diameter and 3.5 millimeter in length. So it's half of the size of a grain of rice. It's a hollow implant that contains a drug reservoir, and the drug is released from a nanofluidic membrane, a membrane that I will present in a second, that is mounted at one end, and the other end is enclosed with a silicone septa that is self-sealing, so allows for loading of drugs into the device. And then I will talk about the NanoLymph, which is a different platform, is a subcutaneous implantable platform, 3D printed, that allows for dendritic cell recruitment and activation against specific antigens. So why do we need the nanotechnology in this case? So nanofluidic membranes are a broader term that defines membrane technology that use nanopores or pores that are in the nanoscale range, so extremely small. So we have produced a number of different generations of nanofluidic membrane for controlled drug delivery beyond cancer. We are working extensively on HIV prevention, on obesity and metabolic syndrome, among other diseases. So we have created this technology using the semiconductor industry capabilities, saying that it's used to make computer chips to create reproducibly in large number and at low cost these nanofluidic membrane with channels that are identical to each other, and they can control the drug release by constraining the molecule they're diffusing across this channel to interact and with the surface of the channel themselves. So this nanochannel, they can be as small as 2.6 nanometers, as shown in this TEM image, transmission electron microscopy image in panel C, serve as basically as the restriction in an hourglass. So you can imagine our drug delivery system is a reservoir containing the drug on top, and that the nanochannel control the drug release in a way that is constant and sustained for extended period of time. Jumping to this, the first project that I present today, which is again related to the intratumoral delivery of immunotherapeutics, which in our opinion is a way, a nanodelivery system opportunity to alter the tumor microenvironment. You see several images in this slide. These colorful images are nothing else than the membranes observed in the microscope. You can see one of the membrane compared to a 25 gauge needle. So this membrane again is mounted onto this implantable reservoir that is either created in titanium or in stainless steel, so it's radio opaque and may enable, in fact, implantation procedure through image-guided techniques. So this implant is designed specifically to be inserted in a solid tumor mass using a trocar approach, similar to what is done for placement of brachytherapy seeds in prostate cancer or for collecting biopsies from solid tumors. You can see, in fact, once in this representation, in this schematic, you can see a solid tumor, the trocar reaching inside of it, and then using a plunger, the device can remain inside of the tumor mass and start delivering its payload by simple drug diffusion. So there is no injection of liquid. It's a diffusion of molecules from the inside of the reservoir into the device, into the tissue. And this is the trocar needle that we're using in our preclinical studies. Now, in a clinical setting, we are envisioning this technology to be used as following. So a patient perhaps is diagnosed with a primary tumor with several metastatic sites. And so the opportunity here is to use this device in a neoadjuvant setting, whereby the device will be inserted inside a primary tumor to deliver an immunotherapeutic payload in a sustained fashion for perhaps a period of a month or more. At the same time, radiation therapy will be performed. Radiation therapy would have the effect of promoting the release of tumor antigens from the tumor that would be then picked up by dendritic cells. Dendritic cells would present it to T cells and create this cascade of immunological events that would then fight back the cancer itself. Now, when this immune system approach is activated, then the tumor may be surgically resected, as it would happen in any case in many instances. And then the immunological response would be maintaining the memory and the ability of fighting distributed metastases around the body to eliminate the metastatic site. We focus our preclinical studies on triple-negative breast cancer, which, as all of you know, is estrogen receptor, progesterone, and HER2 negative. So it doesn't really respond well to many forms of treatment. So there is no good treatment in the clinic right now that for fighting this disease, and affects about 15 to 20% of breast cancer cases. So there is really no targeted therapy at this stage. So we wanted to utilize our implantable intratumoral technology, and before to do so, we wanted to verify, in fact, that it serves a purpose beyond and it's beneficial as compared to the conventional administration. So we perform a biodistribution experiment, first of all, using a anti-CD40 antibody conjugated with an Alexa Fluor 700 for fluorescence. and grow 41 tumor orthotopically in mice, and then started a treatment by either intraperitoneal administration of the Lexaflor conjugated antibody, or intratumoral injections, or the NDES, so our implant inserted inside of the tumor. As you can see from this data, we were able to show that the NDS, as compared to the other delivery modality, was able to sustain drug release inside of the tumor for extended period of time, as we capture from fluorescent images, from IBIS images. So in the tumor, at day 7 after starting out the treatment, you can see that we have a very nice and bright spot indicating high concentration of the drug. In the case of the NDS treatment, we have some little leftover from an intratumoral administration and very little concentration, barely detectable for intraperitoneal administration. Conversely, when we look at the liver, we see a lot of drug deriving from the intraperitoneal administration, while no drug for intratumoral administration. So again, we are targeting exclusively the tumor with an intratumoral approach. Again, with more details with regard to these, we were able to show with our collaborator at University of Washington that the NDS can obtain a very broad distribution of the antibody inside of the tumor mass, way more to a broader extent as compared to the intratumoral administration on the AP. And you can see clearly on this graph the extent of the difference in terms of tumor exposure of this antibody. But also, if we're looking at the different tissue and organs around the body, you can definitely tell the difference with an IP administration, where from day 1 to day 4, basically the liver, the spleen, and the lung was inundated with antibody in the case of intraperitoneal administration, while instead from the local delivery modality, intratumoral injections or our implant, there was no evidence of significant drug accumulation into the tissues. Another interesting aspect, as I mentioned, is that this technology may be used in conjunction with radiation therapy. And we were able to see during this biodistribution study that, in fact, radiation may affect the uptake of the drug within the tumor, and in fact enhance the uptake of the drug, as you can see, as compared to the no-radiation control. This is in the case of our implant, but it was the same also for the intratumoral administration via injection. So we started doing an efficacy study that this graph summarizes in terms of our protocol. We inoculated the cells orthotopically. The cell grew, and then by the time that the tumor was about 150 millimeter cube, we started at day -3, -2, -1, fractionated dosing of radiation at 6 gray. And then at day 0, so 1 day later, we started the treatment by implanting the NDS via the trocar approach, or starting 4 subsequent intraperitoneal administration of cocktail therapeutics that I will mention in a second, at every other day. At day 14, that we euthanize the animal and collect the tissue to see the response. So in this graph, I show you the results, which are actually quite compelling. So we were able to demonstrate that in the case for both intraperitoneal, so systemic administration of the combination of anti-CD40 and anti-PD-L1 plus radiation treatment, or for the delivery of the same cocktail of immunotherapeutics with radiation from our device, we had similar efficacy and reduction of the tumor burden into this animal, starting from 150 millimeter cube, which in the context of a 41 triple negative model, it's quite an interesting results, considering that this model develops very rapidly and very aggressively into these animals. So you can also appreciate from the images on the tumor that we harvested at the end, how, in fact, we were able to reduce the tumor volume substantially. This is also represented in this graph, where you can see that most of the tumor in both the AP group and the NDS group, implant group, they were, in fact, reduced in sizes compared to the first time point. Now, what is interesting, though, is while we have the same type of efficacy from the interperitoneal systemic administration and nanofluidic implant system, we did see a difference into the spontaneous metastasis formation into the lung, which are typical of this 41 model. So in the case of our nanofluidic system, we did not observe any lung nodule in the histological examination of the lung tissue, while we did observe a few into the intraperitoneal administration. And also another important fact is that we were able to extend the survival of the animal with the intratumoral system, even beyond what was achieved intraperitoneally. Even more relevant in this case is the fact that the adverse effect to the treatment. So the animal that received the intraperitoneal administration, they actually, a few days after the administration of the drug, they really lost a substantial amount of weight that was later recovered over time. But this didn't happen to the same extent for the implant technology, for the implant group. Also, when we were looking at the liver, we saw in the case of intraperitoneal administration, a neutrophil infiltration in the treated group versus complete clear liver for the implant-treated devices. So looking at, in fact, the scoring, pathological scoring, we had the IP presenting some level of, in fact, toxicity, while no level of toxicity was observed in the case of the implant. Also, in regard to this, we were able to demonstrate that among the tumor-infiltrating lymphocytes, the CD8 positive and CD3 positive T cells were increased in both cases with the co-delivery of CD40, anti-CD40 and anti-PD-L1. We have also percentage of granzyme B and CD8 positive T cell increase substantially, and also a reduction of the percentage of PD-L1 positive cancer cells inside both of the two treatment groups, which indicates that we really had an immunological response to the treatment, and that immunological response was triggered against the tumor itself. We also performed additional analysis with respect to the tumor-infiltrated immune cells, and we use imaging mass cytometry to analyze, in fact, the immune cell spatial distribution within the tumor microenvironment. So in the top panel, there is a representative staining of each one of the group, and we found that there is a significant number of CD8 T cells in the implant group, together with radiation, especially PD-1 negative CD8 T cells. And this indicates, in fact, that the cytotoxic ability of the CD8 cell is functional. So we also observed dendritic cells population increase in both the AP and in the implant-treated groups within the tumor microenvironment. So in conclusion, for this first part of the presentation, we were able to demonstrate that the implant sustained release of immunotherapeutic within the tumor and low exposure, and create a low exposure of the drug to the other tissue and to the other organs. And so the sustained intratumoral immunotherapy of anti-CD40 and anti-PD-L1 in combination with radiation corresponded to a significant limitation and reduction of the tumor burden, and with, in parallel, a limitation of toxicity via the use of our implant. Also, the NDS implant increased the CD8 T cell infiltration locally and systemically, and we postulate that, in fact, it was able, therefore, to boost an abscopal effect toward attenuating the lung metastatic sites as we showed before in the histological examination of the lungs. I want to change gears for a moment, and I want to talk about the NanoLymph. Again, these are different technology platforms that we have developed, and specifically for cancer vaccine, the dendritic cell vaccine. So the vaccines aim to form a durable immunity against presented antigens, and we often think about vaccine in a context of prevention, as in fact is the case of COVID vaccine. These vaccines are given in a disease-naive population, often given intramuscular through intramuscular injection, and to prevent, again, the acquisition of a specific infectious disease. So we can really capitalize on the same type of approach, but specific, in this case, the vaccination is to mobilize the immune system in people that already have a chronic disease such as cancer. So this therapeutic vaccine can generate a patient-specific response by using tumor antigens that are derived directly from tumor biopsies, as an example. And in this manner, the therapeutic vaccine can interface with the locally residing and resting immune cells to activate them and induce proliferation, and then allow for their ability to fight cancer, both at a specific site or distributed in metastatic sites. So the therapeutic vaccine often targets dendritic cells, which are the most powerful antigen-presenting cell in the body. So dendritic cells naturally follow a 5-step process to affect an anti-tumor immunity. First of all, the naive dendritic cell must encounter both an antigen and an immunostimulatory agent, often released by other cells within the body or locally. So this causes, in turn, the dendritic cells to undergo the activation, migrate to the local lymph node, and in the lymph node, the activated dendritic cell interface with the naive T cells, causing the T cells then to activate into effector T cells. These effector T cells will then, in turn, able to infiltrate the tumor and therefore attack the cancer cell with the release of cytotoxic granules and chemokines. So now the NanoLymph is meant to trigger this immunological response. Is designed in the following way: the structure hosts the drug reservoir that we use for chemo attractants or immunomodulators such as GM-CSF, as an example. This reservoir can be refilled at need for extending the release of these drugs for extended period of time. There is a dual reservoir. This reservoir is where tumor antigens will be actually placed and loaded. The chemoattractants have the ability of diffusing to this chamber and to create a sort of gradient of concentration around this NanoLymph in the subcutaneous tissue. And so the way that the drug is controlled is, again, using a nanofluidic membrane that regulates the release of the drug over time. So there is a nylon mesh that contains the tumor antigens reservoir that allow for dendritic cells actually to penetrate this environment. So first of all, we tested this technology in terms of refillability and safety. In terms of refillability, we implanted subcutaneously the device in mice. These were empty. Then we loaded it with an Alexa-Fluor conjugated chemoattractants. And we were able then, through IVs, to demonstrate clearly that the drug was loaded inside of the device. But also we wanted to demonstrate that the drug can actually be controlled. And if we want to remove it, we can actually flush it away, all transcutaneously, through a simple transcutaneous injection. We demonstrated that this animal didn't have any sort of adverse effect to the implantation of this device. The weights remain constant, temperature remained constant, and also looking at the liver, the ALT activity from the liver, we were able to demonstrate there was no adverse effect from implanting these devices, either loaded with PBS control or loaded with a model antigens. In this case, we use ovalbumin, or loaded with GM-CSF, or loaded with a combination of the antigens and GM-CSF. Then we tested the release of the drug, and we were able to demonstrate, as in the case of the intratumoral platform, we were able to demonstrate that using our nanofluidic approach, we can sustain the delivery of GM-CSF for extended period of time. We have shown it for 14 days, but we stretch it further, and as compared to a subcutaneous administration of the same. So subcutaneous administration only really provided drug locally for 3 days, and then for the rest of the time it was gone. Instead, in this case, we were able to localize the chemoattractant for a much longer amount of time. Now, the nanolymph is designed to be, again, implanted subcutaneously, and then we envision it to work in 4 different steps. So once implanted subcutaneously, then it's loaded with chemoattractants, immunomodulators, in fact. And then we will load also with the tumor antigens. The chemoattractants would recruit dendritic cells on site. So this constant and sustained release of drug will generate a preconditioned microenvironment to recruit even more dendritic cells. These recruited dendritic cells will then be able to infiltrate through the nylon mesh inside of the reservoir and interface with the hydrogel that contains the tumor antigens that we would have located. And at that point, the presence of the antigen and drug, with these dendritic cells will be in fact activated. At that point, the activated dendritic cells will be able to move back out of the reservoir of these implants and then migrate systemically to the local lymph node, where they will be able to mediate immunity through the off signaling pathway. So we perform a first test to really explore if the nanolymph is able to generate an antigen-specific lymphocytic response, and the experiment was performed as follows. So the implant was divided in, there were 4 different groups. A group receiving the implant loaded exclusively with PBS as control. One group receiving the antigens without the chemoattractants. Another group delivering exclusively GM-CSF and resiquimod only as chemoattractant. And then we had a combination of the ovalbumin plus the chemoattractant. And then by day 14, we extracted the nanolymph and we analyzed the immune cell population within the nanolymph to see what we actually were able to achieve. So in this case, we were able to show that the nanolymph was able to recruit significantly more dendritic cells in a drug-dependent manner. So if these recruited dendritic cells encounter antigens, they express an activated phenotype. So these activated dendritic cells migrated to a local lymph node, and then within the lymph node, the activated dendritic cells are found to express the ovalbumin antigens in an antigen-dependent manner. So this affected significantly increase in mice that were immunized with both the drug and the antigens. And together, this really indicated that the nanolymph is capable to create this local recruitment and activation of dendritic cell, generating antigen-specific dendritic cell in the local lymph nodes. So this antigen-specific dendritic cell then can successfully interact with T cells in the presence of drug and antigens together, significantly increase the presence of CD4 positive, CD8 positive T cell, generating effector T cells. And in our case, at this point, now, given these exciting data, we are interested in performing a next step in our research, which would be to evaluate whether we are able to generate a T cell against the represented cancer. Specifically, we intend to implant 2 contralateral tumors together in parallel with the implantation of the nanolymph. Then at a certain point, extract one of the two tumor, harvest one of the two tumor, and lysate it to create a cocktail of antigens. And then once we have recruited the dendritic cells, then transcutaneously load these antigens, lysate, inside of a nanolymph reservoir. And we hope to see a response into the contralateral tumor that instead will be still remaining inside of the animal. So this is an ongoing process, and we hope to be able to present this data sometime soon. In summary, the nanolymph is in fact a biocompatible and refillable platform technology that allow for sustained release of chemoattractant and immunomodulators, and can locally, in fact, recruit and activate dendritic cells. And we were able to demonstrate it with the model of albumin-loaded nanolymph that we could generate antigen-specific T cells. With this, I conclude my presentation, and I want to thank all the funding agencies from the NIH, NASA, and Department of Defense, as well as Nancy Owen Breast Cancer Foundation that have been supporting this study. And again, we continuously update our social media pages, providing update on our research. So we encourage anybody that is interested to follow us on those platforms. Thank you very much.
Great, thank you. That was a wonderful presentation of some very intriguing data. We have time for a couple of quick questions. Obviously, I'm curious, there are certain areas of the body that are very resistant to systemic disease, like the central nervous system. Is there, down the road, are we going to be able for neurosurgeons to implant this, say, after a resection to decrease the risk for recurrence for CNS disease, or is there any way to get around the issue of the blood-brain barrier now using this nanotechnology?
There definitely is an opportunity. We have not started exploring that just yet. Again, we have focused most of our research on breast cancer, and we have started working on pancreatic cancer model. But there is an interest. In fact, our technology is relatively small. Is definitely suitable for implantation within the brain. We, in fact, compare to another technology that has already been tested clinically, that is used to evaluate the response of glioblastoma to a set of 14 different chemotherapeutic agents in different patients. So, and these technologies resemble, in terms of size and shape, our device, in particular the intratumoral drug delivery system. So we really do expect that there is an opportunity for using this in a clinical setting in a broad variety of solid tumors. We are, at this stage, we are in discussion with the FDA. We actually submitted an inquiry to understand exactly what would be the regulatory process for our technology to move forward. We receive the information that basically with the basic technology, we may be able to go into clinical trial with using just a 510K approach, a regulatory approach. And so we are very excited of moving forward in that direction. And that will open really a spectrum of opportunities because, of course, in certain instances, we can use these technologies in rodent models. But of course, this becomes more challenging when we are going to look into brain tumors, also in murine models where perhaps the volumes available are much smaller.
And obviously, I imagine from a delivery standpoint, in addition to checkpoint inhibitors or immunotherapy drugs, there'd be no reason why certain cytokines or oncolytic viruses could be delivered to the exact same, with the same technology.
That's correct. And in fact, together with Jenny Chang, we had considered perhaps the opportunity to use the same system, for example, to deliver HSV-TK. So that there may be valid opportunities. there's a number of different therapeutics or even imaging agents that we could deliver from the same platform. We have tested this technology platform within the context of about 50 different therapeutics, ranging from small molecules to monoclonal antibody or even nanoparticles. We were able to see and demonstrate that we could sustain delivery of a cocktail of this molecule, in fact, from the same device by just simply choosing in a proper way the nanochannel size specific to the molecule that we want to release. And we are able to sustain the release. So there is really no limitation from that standpoint to the type of different compounds that we could deliver using this technology.
Fascinating. Great. Thank you so much for your wonderful talk, and best of luck on your experiment, and travel safe. Thank you.
Thank you so much.
Moving on to our next speaker. Dr. Abdulrahim is an assistant professor in the Cancer Center. His medical focus is on gastrointestinal tumors. He also is the medical director of the Cockrell Center, so is very involved in early drug development. He's got too many degrees to count, but the important thing is he got a PhD in pharmacology before coming on to becoming a medical oncologist. He did his training at Duke. So he's been able to build up a very robust, broad number of trials in multiple different GI tumors here at Houston Methodist. And today he's going to discuss transplant oncology, an evolving field in cancer treatment. Dr. Abdulrahim.
Well, good morning. Thank you, Dr. Berneker. It's a pleasure to be with you today, and I would like to thank Dr. Berneker, Dr. Shah, and the organizer for this opportunity to talk about transplant oncology. So I will go over a concept and historical evolution of transplant oncology. Then I will discuss paradigm shift and multidisciplinary cancer treatment that include HCC, cholangiocarcinoma, and liver metastasis from colorectal cancer and neuroendocrine tumor. And at the end, I will discuss two interesting emerging concepts in transplant oncology. So we treat cancer by immunotherapy, targeted therapy, chemotherapy. However, treating cancer by transplantation should be a treatment option for your patient. And this is actually the core of transplant oncology. So it's a new concept involving multiple disciplines of transplant medicine and GI oncology. It's actually designed to push the envelope for the treatment and research of a primary and secondary liver cancer and bridging the gaps between subspecialty. It's bring radiation oncologist, immuno-oncologist, hepatologist, gastroenterologist, transplant and hepatobiliary surgeon, in addition to the GI oncologist, quote-unquote, transplant oncologist, together to maximize the care and the cure of cancer patient through transplantation. And this can be done by transplant oncology tumor board, which actually is conducting in high volume cancer and transplant centers. The first conference on transplant oncology is actually hosted by International Liver Transplant Society in Rotterdam back in February of 2019. And actually I have the pleasure to participate in this meeting along with our transplant team, where we discuss a guideline as well as research ideas in this meeting. So as we all know, in addition to chronic and acute liver disease, liver transplant is now performed more often for malignancies. And we know that introduction of antiviral therapy for Hep C actually decreased the number of Hep C-related liver transplant by more than 30% in less than 4 years. On the other hand, there was an increase about 34% in HCC patient on liver transplant list. So as you can see, there's a paradigm shift in cancer treatment. In 1996, actually, the introduction of Milan criteria that proposed liver transplant for unresectable HCC. And it is actually believed by many, this is the initiation or the start history of transplant oncology. We know that Milan criteria include solitary liver lesion less than 5 centimeters or less than 3 nodules, each less than 3 centimeters. And they have shown that this was associated with good outcome with 4-year survival rate of 75% and recurrence-free survival rate of 83%. However, Milan criteria is restricted to only patients with small tumors. So after Milan criteria, multiple studies have been conducted to expand the liver transplant beyond Milan to allow more patients to be transplanted for liver cancer. 2001, UCSF have the criteria of solitary liver lesion less than 6.5 centimeter, or less than 3 nodules, each is less than 4.5 centimeters, with a total tumor of less than 8 centimeters. The 5-year overall survival reached 81%. Dallas criteria in 2007 have shown that 5-year over recurrence-free survival actually reached around 64%. Valencia criteria have shown that the 5-year over survival reached 69%. This followed by an up to 7, an Italian study, and showed that the 5-year overall survival reaching 71%. The French add alpha-fetoprotein as a markers on their criteria, and they have shown the 5-year overall survival reached 68%. This is followed by a Chinese study or Chinese criteria that have shown the 5-year overall survival of 72%. The Canadian did their own criteria, and it involved total tumor volume of less than 145 centimeters. And they have shown the 4-year overall survival reached 74%. And finally, another Italian study, the Metro Ticket 2.0, have shown the 5-year overall survival of 68%. So as you can see, beyond Milan criteria, they expand the criteria and include more patients to be transplanted for liver cancer. And in average, the overall survival reached 70 to 80%. Okay, that was for HCC. What about other liver primary cancer, like cholangiocarcinoma? For highlight cholangiocarcinoma, in 1990s, the initial attempt for liver transplant for unresectable highlight cholangiocarcinoma showed an acceptable outcome. The 5-year survival rate was 23%, and 84% of the patient had a recurrence within 2 years of liver transplant. Later on, use of neoadjuvant therapy, chemoradiation followed by a maintenance chemotherapy with Xeloda, it actually improved the outcome with a 5-year survival of 80%. However, this patient population favored the patient with PSC, primary sclerosing cholangitis. And this actually speaks for the role of a transplant oncologist, where involving chemotherapy before transplant. What about intrahepatic cholangiocarcinoma? Liver transplant for intrahepatic cholangiocarcinoma have been contraindicated based on the poor results that came in 1980s and early 2000s. And actually, these old studies have been criticized for a relatively small number of patients. They combined both patients with intrahepatic and highlight cholangiocarcinoma. Also, they include both cirrhotic and non-cirrhotic patients. The newer multi-center study, on retrospective study, have shown that liver transplant for early intrahepatic cholangiocarcinoma with a single tumor up to 2 centimeters in cirrhotic patient have shown an excellent 5 years overall survival of 65% and recurrence rate of 18%. Our experience with intrahepatic cholangiocarcinoma published in 2018, and we have shown that the 5 years overall survival is 83% and recurrence-free survival of 50%. This is way better than overall survival with chemotherapy alone, where it was reported for intrahepatic cholangiocarcinoma to be 16.7 months, and for other biliary tract cancer other than intrahepatic cholangiocarcinoma reached of 11.7 months. So the patient population in this study are patients who have unresectable, locally advanced intrahepatic cholangiocarcinoma with non-cirrhotic liver. And they have to have a disease stability of more than 6 months while they are on neoadjuvant chemotherapy. Okay, so that was for primary liver cancer, HCC and cholangiocarcinoma. The success with primary liver cancer led to the concept of can we transplant patients who have liver metastasis from other GI cancer? And the most common cancer is colorectal cancer. As we know, liver is the most common site for metastasis from colorectal cancer. Patients with colorectal cancer with liver oligometastasis are usually treated with curative hepatectomy, and the 5-year overall survival with R0 resection reach 25 to 40%. On the other hand, unresectable liver metastases that are treated with palliative therapy, the 5-year overall survival is 14%. Colorectal liver metastasis is considered a contraindication to transplant until recently. However, there's a patient population with liver-only metastases that are stable but not resectable. Those patients are considered for transplant, and they are being studied in multiple clinical trials. The first concept is coming from a trial called SICA-1. SICA stands for secondary cancer, that was started in 2006 at Oslo University Hospital. In this study, 21% with colorectal cancer have non-resectable liver-only metastases. And the inclusion criteria for this study was at least 6 weeks of neoadjuvant chemotherapy, complete radical resection of the primary tumor, and good performance status. They exclude patients who have extrahepatic lesions and patients who have lost weight more than 10%. The outcome from this study is that the overall survival at 5 years reached 60%, and disease-free survival at 1 year reached 35%. I want to remind you that the 5-year overall survival for a patient with chemotherapy alone is around 10 to 15%. So 15% maximum to 60% and a 5-year survival, this is a big success. The author of this paper have looked back in their data, and they look at certain factors that might affect their survival. And they found that tumor diameters, or patients with a tumor diameter that is less than 5.5 centimeters, did better than those who have tumor diameter that's bigger than that. Also, they found that patients who have a CEA that less than 80 did better than those who have CEA higher than 80. And they also found that patients who had their diagnosis more than 2 years before transplant did better than those who have the diagnosis within the 2 years after before transplant. And finally, they found the patients who have a stable disease or partial response to treatment before transplant did better than patients who have any sign of a disease progression. They put all these factors together and they give it scores from 0 to 4. And they found that patients who have factor from 0 to 1 did amazingly better than those who have factor 2 to 3, and the patient who have 4 factors altogether involved did the worst. Last year, a follow-up study called SICA-2 was published. And this study, the goal was to investigate whether more strict selection criteria can be used to obtain a better overall survival after transplant. In this study, patients were required to have at least 10% response to chemotherapy 1 year from diagnosis to liver transplant. And they highlight in their paper what we call it FONG, a clinical risk score, which is based on 5 criteria, and they give it point to each criteria. I list them here for you, which include synchronous metastatic disease, lymph node positive primary, more than 1 liver lesion, and size larger than 5 centimeters, as well as CEA more than 200. What they found in this study that the overall survival at 1 year reached 100%, and at 3 and 5 years reached an 83%. And disease-free survival reached 53 at 1 year, 44 at 3 years, and 35% at 5 years. And they also report that the disease-free survival for patients who have fungus score from 0 to 2 was not reached at that time. However, for patients who have fungus score of 3 to 4, the disease-free survival reached 11.8 months. So for colorectal cancer metastasis to the liver, a patient who have a liver metastasis that is not resectable, however stable on chemotherapy, we usually treat them with multiple, before we transplant them or before we consider transplant for them, we treat them with a combination of cocktail of chemotherapy that is listed here. The maximum overall survival for 5 years, they can reach 15%. However, if we transplant them on the right side, the 5-year overall survival can reach up to 83 years. And this actually, what we call the improvement of the outcome, and this is actually attributed to the multidisciplinary approach of transplant oncology, where we have the transplant surgeon, the hepatologist, immunologist, and transplant oncologist, or GI oncologist, if you will, working together to have a criteria selected for a patient that can benefit from a transplantation. There are multiple prospective ongoing clinical trials across the globe try to validate these data and try to expand on them and having a better selection criteria. And more data is coming in the future. What about the other transplant for a patient with metastasis from a neuroendocrine tumor? Mazzaferro and others in 2007 established a criteria to select appropriate net liver metastasis patient for liver transplant with a curative intent, and they call it Milan-NET. These criteria include these factors. Patients have to have a primary tumor low grade, grade 1 or 2. Tumor should be drained by the portal system. Hepatic involvement of less than 50%, and response to treatment or stable disease for at least 6 months before a transplant. And finally, a relative criteria of age 60 years old or younger. The Milan criteria, actually, or Milan-NET criteria, was based on a study that have 42 patients with liver transplant were compared to 46 patients with no liver transplant during the period of 1995 to 2010. And what you can see here, the overall survival at 5 years reached at 97%, and at 10 years reached at 89%. While for the patient who have no transplant, have a 5-year survival of 51% and 10-year survival of 22%. They conclude from this study that liver transplant for MET-NET under restrictive criteria provide an excellent long-term outcome. And they conclude also that the transplant-related survival benefit increase over time and maximize after 10 years. So you still need to continue to have a benefit the far out from transplant. So what's the guideline? UNOS in the United States adopt Milan criteria for their guideline for NET liver metastasis. European Neuroendocrine Tumor Society and NCCN recommend include patients with unresectable NET liver metastasis on their liver transplant. Okay, so far I hope I convinced you that liver transplant for oncological indication is increasing. And you will see more patients that have liver transplant for primary liver cancer, HCC, cholangiocarcinoma, or for metastasis from colorectal cancer or neuroendocrine tumor. And we know now that immunotherapy is continuing to be used and expanding the use for liver cancer and other cancers. And obviously, with the increased number of liver transplant for cancer and the use of immunotherapy for cancer, the concept of using immunotherapy around a transplant become obvious and become a topic of interest. This diagram shows you the number of checkpoint inhibitor approved or going to be approved for liver cancer, and that's include PD-1, PD-L1 inhibitors, as well as CTLA-4 inhibitors. The study that's led to approval of this drug exclude patients with a transplant. So we didn't have much information about use of immunotherapy in a transplant patient in a organized clinical trials. However, also, immunotherapy have been discouraged in a transplant candidate or recipient due to the potential risk of organ rejection and graft loss. So, immunotherapy can be used in two settings in these scenarios. Either it can be used post-transplant as a palliative therapy to treat a recurrence of the disease or to treat a secondary cancer after transplant, or it could be used before transplant as a bridging therapy for a transplant to get the maximum response of a tumor so the patient can be transplanted. Recent report of liver transplant recipient treated with checkpoint inhibitor showed allograft preservation in nearly 2/3 of the patient. This report discussed around 48 organ transplant patients who received checkpoint inhibitor for advanced cancer. Of those patients, 19 cases were liver transplant recipient. And they have shown that disease control rate was reported at 21%. Graft rejection was seen in 37% in liver transplant patient. And this is followed by another study, which is a report of 14 known cases of liver transplant recipient who receive checkpoint inhibitors. This table summarizes the study for you, and it showed that the reason why checkpoint inhibitor used post-transplant is for liver cancer recurrence, HCC, or for secondary cancer melanoma. And you can see they use PD-1 inhibitor like Nivo or Bembro, as well as CTLA-4 inhibitor like EBI. They show that 4 out of the 14 patients have graft rejection. Interestingly, 3 out of those 4 patients, when they check their graft for BDL status, they found 3 of them is positive for BDL1. On the other hand, the patient who have no graft rejection, the BDL status was minimum or 0. Those patients use different immunosuppression, so it's hard to conclude. But from this result, or from this study, they have shown that graft rejection was only reported in 4 out of 14 patients, which is around 28%. And they have shown that the median time to rejection is 3 weeks after the initiation of checkpoint inhibitors. They suggest that factors that might affect susceptibility to organ rejection include choice of the agent and the immunosuppression type, BDL1 status, and liver graft biopsy. However, they conclude that the data from this report are insufficient to draw conclusion about a relationship between graft rejection and tumor response. Also, the data is insufficient to suggest that one checkpoint inhibitor or immunosuppressant is better or safer than others. The predictive biomarker of rejection, they mentioned BDL1, however, more data is needed. Okay, that was for using checkpoint inhibitor after transplant. What about using checkpoint inhibitor before a transplant? The clinical outcome of patients receiving immunotherapy before transplant, as of now, is unknown. However, interestingly, earlier this year, a study came about and they showed a result of 9 patients with HCC who were successfully transplanted after receiving Nivo as a new adjuvant or bridging therapy for transplant. They have shown that one transplant, which is around 11% of the study, was from a living donor. In this study, they used Nivo as 240 milligrams given every 2 weeks. And they have shown that 8 patients, which is around 89% of the patient population, received their last dose within the 4 weeks of transplant. The median follow-up for this study is 16 months post-transplant. And what they found that no severe allograft rejection or tumor recurrence or death occurred in the study. One patient developed a mild acute rejection secondary to low tacrolimus level, which is less than 6. However, later responded rapidly to increase the dose. And they have shown that explant pathology revealed near complete, almost more than 90% tumor necrosis in 1/3 of the cases. So if I want to summarize it, this is a model I kind of put and I'd like to look at when we design our clinical trials. We are actually now opening a clinical trial where we're using immunotherapy before a transplant for liver cancer patient. And this is the model which is, I think, it makes sense. When we use a checkpoint inhibitor before a transplant, you excite your immune system and do its job, inhibiting cancer. However, the immune system will cool off before transplant. And before transplant, we use a lot of immunosuppressant. So that's one model for using immunotherapy before transplant. On the other hand, immunotherapy after transplant, the graft is there, and you excite your immune system, but the immune system later on gonna be cooled off when you stop your therapy or hold your treatment for whatever reason. And I believe there's more risk of rejection when you excite your immune system after transplant when the graft in place, compared when you use immunotherapy as a new adjuvant therapy or bridging therapy before a transplant. So this is a work in progress, and a lot of data is coming from our center as well as from others. The other emerging concept, and I think it's equally exciting for transplant oncology, is the use of utility of ctDNA for minimal residual disease evaluation and surveillance in HCC post-transplant. Surveillance for HCC for post-transplant, including images and tissue biopsy. However, both have a modest sensitivity. And liquid biopsy become an interesting topic and it's a promising tool to use for surveillance for HCC post-transplant. One report from Casey and others have analyzed 200 plasma samples from a total of 90 hepatobiliary cancer patients. 27 of those patients were HCC. And they have reported that ctDNA detect significantly associated with stage of the disease. And they also have shown there's a correlation between ctDNA level and clinical response. The clinical utility of ctDNA in HCC have been published in multiple studies, and for the sake of time, I will have to show that, or to report that the outcome from this study is the following. One study have shown the detection of ctDNA was associated with increased recurrence. Another study have shown that ctDNA can detect minimum residual disease and predict survival. Another study have shown that detection of ctDNA predicts shorter recurrence-free survival. And finally, another study have shown that detecting ctDNA in urine was feasible and predictable. Compared to tissue biopsy, ctDNA is easily repeatable, less invasive. It can give a dynamic picture of the disease and is actually give you an actual time of monitoring. On the other hand, the tissue biopsy is more invasive, interventional, inability to reflect tumor heterogeneity, difficult to repeat, and only reflect a static picture of the disease. So in conclusion, I believe the era of transplant oncology had just begun, and we are witnessing a paradigm shift in treating cancer with transplantation. I think it's time to consider our effort to discuss transplantation for primary and secondary liver cancer under the concept of transplant oncology. And finally, utility of ctDNA and immunotherapy in liver transplant is promising. However, more data is needed to confirm safety and usefulness of ctDNA. With that, I would like to thank you all, and we'll be happy to take questions.
Thank you, Dr. Abdelrahim. That was great. I do have some questions. Let me load it while it's loading. Here's one from the audience. We have used total lymphatic irradiation and cellular immunotherapy to aid in establishing mixed chimerism in renal transplant patients with success to avoid long-term immune suppression. Should we consider this strategy for transplant oncology?
I think this is a good question. And at the current stage, we don't have enough data, but this is sound like promising and been tried before. And I think there could be studied further with more data on the patients. It's a good concept to consider. And I think at this point, we don't have much information in this arena. And it's a good question and might have a potential in the future.
Two other questions, or one's that, is always a statement because you always have to make your statement in the guise of a question. So a long time ago, and I'm old enough to remember, a million years ago, we were doing huge amounts of autologous bone marrow transplant for breast cancer patients. And it was adopted at many of the major cancer centers. It was a huge volume of their therapy. So the breast cancer docs were getting a little sad because all the patients were going to transplant. And they looked at patients who met the same criteria for who got autologous BMT, but who for whatever reason didn't have transplant. And they had the same outcomes, and that was the end of BMT for breast cancer. My question is, obviously, with these studies, there's reasonably very careful selection of patients, and I'm thinking more of like the colorectal data. Patients who have responsive disease, presumably are younger, less comorbidities. All I'm saying is, while it needs to be pursued, I'm also questioning if you don't do randomized trials, which are very difficult with patients who meet the same tumor burden, et cetera, and so forth, it's going to be hard, I think, to conclusively prove that the transplant, because you might be selecting better patients who are going to do well anyway, right?
Very good question, and actually this is was one of the questions that is discussed before when there was the initiative to design clinical trial in the future. I want to get you back to the slide when we showed that is Milan net criteria. That study was small, and there was like around 42, 46 patients, and they are kind of in each arm. So that maybe represent your question. As far as a clinical or transplant for colorectal cancer, this is a good suggestion, and the clinical trial that is I highlighted across the globe, they are considering the randomization. However, all the data from SICA-1, SICA-2, and other smaller study, which is I don't mention here, they try to maximize, and it came in from places or country that have a lot of liver donation and availability of liver. So that's definitely a good future study design, and to conclude the validity and the usefulness of liver transplant for metastasis from colorectal cancer patient.
Great. And one last question from the audience. How soon can you start transplant after the last dose of immunotherapy?
Good question. There's multiple case reports here and there, and they show that in this study that published early this year, 4 weeks before a transplant, the last dose of immunotherapy was okay. However, there was discussion about the safety of checkpoint inhibitors and the dissociation of checkpoint inhibitors and the time for the immune system to cool off, and if there is a parameter to check before a transplant patient. There have been discussion about 3 half-life of the checkpoint inhibitor used for that particular study. For example, atezo-bev is the drug of choice to use for HCC before transplant. Half-life of atezo, with atezolizumab, is 27 days. So we are considering like at least 3 half-life from the last dose of atezo before the transplant. However, the study, which is in around 9 patients, came in from Mount Sinai, the 4 weeks was okay for Pembro. So, but there's a case report, the immune checkpoint inhibitors given shorter than 4 weeks, and the graft was rejected right after transplant. So at least 4 weeks, better to have at least 3 half-life of the checkpoint inhibitor that you are using. We need parameters, we need markers, and this is actually what we are looking for during our study now, what we're conducting here. We look at certain parameters for immune system, when it is hyper and when it's going to go down, and we make sure that the immune system is down before we transplant. And this is also going to be a point of discussion when you're going to get your liver transplanted, given that availability of the livers vary. So you can use it in pre-transplant, but you have to make sure that you give an induction period and then a washout period before transplant.
Great. Thank you very much. It was a great talk.
Thank you for having me.
For our lunch keynote, and hopefully everyone out there in virtual land is snacking, we really wanted to highlight some talks from, because they say it takes a village, from some of the other disciplines that are instrumental in helping provide excellent cancer care to patients. So you're going to hear from physical therapy, some acupuncture, and then I'd like to introduce Renee Stubbins, who's a PhD. She's our tireless, I guess, and dedicated registered dietitian who works both with some of the transplant patients and our outpatients in the infusion center, many of whom end up needing supplemental nutrition or feeding tubes. And she's going to speak to us on nutrition and cancer, why it matters. Dr. Stubbins.
All right, good morning. Thank you, Dr. Berneker, for the introduction, and thank you for giving me this opportunity to talk to you guys. So, no surprise here. The big topic here with cancer is going to be malnutrition. Up to 80% of oncology patients present with weight loss at diagnosis, and up to 30% of those have significant weight loss, which is classified as greater than 10%. And the problem is with cancer treatments, it can result in further weight loss. Most cancer treatments are very metabolically demanding on the body, so that includes surgery, chemotherapy, even immunotherapy, and of course radiation. Then, in severe cases, we have cancer, cachexia, and sarcopenia. And the big thing that I want to highlight here is that these are independent of BMI. So just because you have a person that comes in with a BMI of 30 and they've told you they've lost 50 pounds, and they usually kind of joke and they're like, oh, well, I needed to lose the weight. It's still not okay, because a lot of the times the weight loss that we're seeing there is going to be muscle, which I'll elaborate here in a little bit more about that. So this is the screening tool we use currently at Houston Methodist. It's called the Malnutrition Screening Tool, or abbreviated MST. And the good news about it is that it's short and easy. The not so good thing about it is that it gives you a lot of false positives. So it's 2 questions. Have you lost weight, yes or no? And if so, how much? And are you eating poorly because of decreased appetite, yes or no? So if they score greater than 2, then they're considered at risk for malnutrition. All right, so when should we screen? It might surprise you that although several validated tools for screening for malnutrition are out there, there's no universal standardized process for screening patients with cancer for malnutrition. Currently, at Houston Methodist, what we do is we screen them during their first chemotherapy infusion appointment and at radiation oncology. And of course, we screen them while they're inpatient as well. When should we screen? So we should be screening when they're first diagnosed at surgical oncology, and of course, continue to screen them throughout their chemo treatment and radiation treatment. Why should we screen? There is not a systematic nutrition screening process, and it's not considered standard of care in most institutions. It's quite sad because most oncology organizations recommend it, but they don't require it. In fact, most cancer centers do not have a dietitian. A study published by the Oncology Nutrition DPG Group and the Journal of Oncology in 2019 found that at NCI designated institutions, they employ about 3 dietitians. At non-NCI institutions, there's only 1 dietitian. And nationwide, there's 1 dietitian for every 2,300 patients. So why is it such a big deal? Malnutrition correlates with reduced tolerance and efficacy of treatment. It increases risk for clinical and surgical complications. It reduces quality of life. It lowers survival rates, leads to longer hospital stays, and ultimately increases healthcare costs. So what I think our goal should be, in an ideal world, we should have early screening for early detection of malnutrition, have a dietitian intervention, prevent malnutrition, improve patient outcome and quality of life. That's our goal. All right, so let's say a patient comes up positive at risk for malnutrition. So this is the criteria for malnutrition. In cancer, it's considered a chronic illness, so that's what that red box is. And there's 2 degrees of malnutrition. You have your moderate, and then you have your severe. I'll be honest with you, most of our patients are severe. So it's less than 75% of estimated needs for greater than a month. So they're eating, if they're supposed to be eating 2,000 calories, they're only eating 1,000 calories for a month, resulting in significant weight loss classified as greater than 5% in a month, or 7.5% 3 months, greater than 10% in 6 months, and greater than 20% in a year. You can also look at their fat and muscle stores to see if there is wasting and how severe that wasting is doing the nutrition-focused physical exam. And also look for edema, because that can also affect the weight, which could ultimately affect how people are being classified. And of course, grip strength. All right, so severe case of malnutrition is cancer cachexia. This is an international consensus statement from 2011, and I think it's pretty accurate. Cancer cachexia is like my archenemy. It's a multifactorial syndrome of ongoing loss of skeletal muscle, loss of fat muscle, that cannot be reversed by conventional nutrition support and leads to progressive functional impairment. So as much as I believe in the power of nutrition, it can't reverse cancer cachexia. So what do? Well, we try to catch it at pre-cachexia. So pre-cachexia, we still have a chance to reverse. And we catch pre-cachexia by catching malnutrition through early screening and detection and intervention. Causes of cancer cachexia, again, it's multifactorial. I don't think I need to read the slides to you guys because y'all are very well aware of the situation. You have pain, you have surgery, we have metabolic changes, you have altered absorption, potentially GI obstruction, things don't taste right, you also have depression, and of course we have the side effects from chemo and radiation. So the other side of that is secondary sarcopenia. So BMI matters not. As I mentioned earlier, just because a person has a high BMI doesn't mean that they're not at risk for malnutrition. They're in fact at almost a greater risk for sarcopenia. And secondary sarcopenia is disease-related. So think about a person who has a BMI of 30 and they weigh 300 pounds and they've lost 100 pounds. And now you have a person who weighs 300 pounds walking around with no muscle mass. They're at greater risk for falling. They overall have more complications, higher infection rates. So there's a pretty progressive movement to start quantifying muscle mass using CT. There's even a school of thought that thinks that we should dose chemo based on muscle mass versus body surface area. Because if you diagnose a body surface area, you could potentially giving too much chemo to someone who doesn't have enough muscle mass for it. So this is the diagnosis criteria for secondary sarcopenia. You have decreased muscle strength, again, confirmed low muscle quantity using a CT. You also have severe decreased physical performance using gait speed. So this would be like a 6-minute walk test. But I'll be honest with you, the 6-minute walk test is very challenging for most of these patients. All right, so summary of nutritional issues. Nutritional impairment, usually at the first medical oncology visit, is about 50% of our patients are having issues when they first see their oncologist. You have involuntary weight loss, pretty significant, up to 50 to 80%. That's usually why they go to the doctor. They notice that they're losing weight and they don't know why they're losing weight, so they go see the doctor. And most of them, it's severe weight loss. You have cachexia up into 80% in advanced cancer patients. Unfortunately, a lot of my patients these days are very advanced cancer just because they've had delayed screening and doctor's appointments because of COVID. And you have sarcopenia, which is also very prevalent in this population. All right, so what causes the weight loss? So this is what I think I kind of summarize as nutrition impact factors. What's going to affect a person from eating? I tell my patients the biggest complaint I get is fatigue. They're just tired. But there's quite a few other issues here as well. So a lot of them can be exacerbated through chemo and radiation and surgery as well. All right, so what do dietitians do? Why do I think they're so important? So I once had a patient that I got a referral from, and I don't think he was very happy to see me. I think he was a little upset that the nurse asked me to go see him. And so he's like, what do you do exactly? And I told him, he's like, oh, so you're like a professional snacker. And I was like, yes, actually. I really like that analogy. And I was like, I do tell people how to professionally snack. So it kind of stuck with it, and I always kind of joke with my patients about it. But we do a little bit more than that. We do what's called a nutritional assessment. So we first find out, okay, are they really malnourished? And if so, how much? What are we dealing with here? And then we try to figure out, how did they become malnourished? I ask them, is your appetite okay? Are you digesting food okay? Is food tasting okay? Are you having any nausea? And the other important questions that I think don't get a lot of attention sometimes is, do they have access to food? Are they too tired to make their food? That's actually a very common barrier, is that they're too tired to get up and prepare something, or they're home alone and their caregiver has to go work to pay the bills to get their cancer treatment. So a lot of this is, multidisciplinary. I'm very blessed to work with some amazing social workers and nurse navigators that can help come up with interventions to address some of these issues. So some nutrition interventions. So this is my favorite slide, so I'm going to warn you guys ahead of time. It has a lot of information, but I think you're going to like it. All right, so you can't just tell someone to eat. It doesn't matter. I've had many patients, more than I can count, that will confide in me, that tell me, my family's getting really mad at me because they're telling me to eat, but I just can't, and no one's listening to me. And so you really have to take the time and almost do detective work to figure out why they're not eating. So here are some quick tips. All right, they say they're nauseated. Small, frequent, bland meals. Another thing that surprises people sometimes is try to tell them to eat cold foods. Cold foods don't have a strong odor, so they're typically a little bit easier to tolerate. I also check the medications. Do they have medications? Are they taking the medications? If so, how are they taking them? Are they having diarrhea? All right, the brat diet, the good old-fashioned bananas, rice, applesauce toast. The other thing that I tell patients sometimes that is a little bit counterintuitive is you want low insoluble fiber and a high soluble fiber diet. I've had multiple patients that they get diagnosed with cancer and then they're going to change their lifestyle. They're going to eat all this healthy food. But then it's too much fiber for them. It's great that you want to eat whole grains and salads and fruits and berries, but it's too much fiber. It's too much work on your GI system. So that's when they need to do a more soluble fiber diet. So this is all those white starchy carbs that we're not supposed to eat too much of. So your potatoes, your white rice, your pasta, your toast. Again, check the medications. Constipation, when was the last bowel movement? What are they taking to manage the constipation? And are they on pain meds? Is that contributing? Also, a good old-fashioned hint is warm fluids. A half a cup of hot prune juice really goes a long way. Are they too tired? Again, the fatigue. Focus on convenience foods. Ask about support at home. Consider home physical therapy. They might need it. Or consider getting a referral to the social worker to see what other tools we can get them to get them help at home. Food access. Houston Food Bank has a senior box program that's free for patients who qualify. And again, utilize your resources. We have some great social workers that are very, very good at what they do. Taste changes. So if I had $1 for every time I gave out my baking soda salt rinse recipe, I would have a lot more money. But you also want to check for thrush and dry mouth. So my recipe is a bottle of water, so 16 ounces. You put 1 teaspoon of baking soda and a half a teaspoon of salt. You have the person rinse before they eat and after they eat, and it cleans out any bacteria that might be affecting their taste buds. This really can go and do wonders. It also helps prevent mouth sores, it helps prevent thrush, and overall will just help make them enjoy food better. Just not hungry. This is probably my least favorite answer that I get from a patient because this is where you really have to get creative. It goes into motivational interviewing, figuring out why, what's going on. If they don't tell me any barriers that are obvious, maybe there's depression. Maybe they need to talk to one of our social workers and do counseling, but we still need to figure out why they're not hungry. All right, why it matters. Nutrition gives the patient and their caregiver some control back in an uncontrollable situation. A lot of our times our patients get to the internet and they start going down the, dark places and trying to figure out what they can do in addition to chemo to help manage their cancer. And it's our job, our responsibility as a healthcare team to give them evidence-based tools and education. That's what we're here for. So the solution, early screening, detection of malnutrition, multidisciplinary intervention, and persistent follow-up. And I will be happy to take any questions.
I'm curious, you must get frequent questions about the use of cannabis or marijuana. How do you advise patients who ask about that as a stimulant, appetite stimulant?
So I do think dronabinol or Marinol can be successfully used. I've had quite a bit of success with it, especially helping with nausea, even sometimes pain. I think it indirectly can help appetite. Sometimes patients just get a sense of euphoria and they just feel better. Sometimes it's a placebo effect. And they just, they feel better because they're taking something and they feel, again, they have that control. And since they feel like they're actively doing something, it makes them feel better, so they're more likely to eat more, is when I've seen it be the most helpful.
I also imagine when people get sick. There's no question that a lot of times diet becomes one of their biggest issue of contention with loved ones, and which is understandable. I'm curious, is there any data on the keto diet, and do you get a lot of questions about patients wanting all of a sudden to go straight pure keto?
Oh, yes. Haven't got one of those in a long time. I first like to ask them, what do they define as keto? Which is always a really fun thing to do, because a lot of times they're like, oh, well, I'm just cutting out processed foods, and I'm just eating, clean foods, and I'm eating fruits and vegetables and whole grains, and so then at the end of the day, I figure out, okay, you think you're doing keto. You're not really doing keto. You're just eating really healthy, but we can call it keto if you want to. So I do think it's too early to say. There are some research studies that show it's very effective in like glioblastomas. I've had some patients that have done like pseudo keto. They do more plant, based fats and plant-based proteins and a very plant-forward diet, and they focus on whole grains, which I think is, not a bad idea. There should be some promising, evidence in that area. So there's just not a lot of strong evidence. So I always like to just kind of open the question up to them and see what they're defining as keto and go from there. And most of the time, they think they're doing keto, but they're not really doing keto.
And then the last question, what was the baking soda recipe recommendation?
All right, so it's 16 ounces of water. So I just usually recommend the bottle of water. 1 teaspoon baking soda and a half a teaspoon of salt. And then you tell them, take a sip of it, swish it around 20 seconds, spit it out. Do it right before you eat and right after you eat.
Perfect. That's great. Thank you so much.
Thank you.
That's great. For our next lunchtime speaker, Dr. John Paul Yang is going to discuss acupuncture and cancer care. He's the former president of the Texas Association of Acupuncture and Oriental Medicine, and he's currently the president of the American College of Acupuncture and Oriental Medicine. He's a former chair of the accreditation committee for that group. He oversees all of the college's acupuncture outreach here at the Methodist Hospital. He received his Bachelor's of Science at Cornell in 1997 and his Master of Science in Oriental Medicine from the American College of Acupuncture and Oriental Medicine. He works with a lot of the medical center institutions, and again, he'll talk to us today about the use of acupuncture as an adjunct in cancer care. Dr. Lang, all yours.
Okay, so acupuncture, as some of you might know, it's been around for thousands of years. And when I got here, actually, I started acupuncture in 1998. And when I came over here and started doing acupuncture, it definitely was not what it is today. Definitely, it was considered as voodoo medicine, and so it was a different time period. But around 1999 to early 2000s is when acupuncture started having a lot of research studies done. And so you can kind of see in this slide, it's one of the, cancer research is one of the bigger conditions that NIH and other researchers have done in related to acupuncture. The other one, of course, is pain management along with infertility. So if you kind of see in the slide here, a lot of research has been done for side effects of chemo and radiation. And you see the nausea, along with actually fatigue. We're doing some in neuropathy as well. Unfortunately, my father in December also had prostate cancer, so we're experiencing firsthand the benefits of acupuncture for side effects of radiation, which he's having a lot of digestive issues, depression, and some pain. So, there's a lot of research that is being done there. A lot of if you see the second one here, a lot of the treatments that we do along with the parts of the body is related to the ear as well. There's about 70 plus points on the ear. And so the ear will tell us a lot about the body's condition as well. And I'll show you a little bit later some of the diagnostics that we do in order to determine how healthy an individual is. So you see here, there's drug therapy, acupuncture combined with drug therapy for cancer pain, also improving quality of life. And then there's some of research being done for mechanism of acupuncture, which they found to increase a lot of circulation and reduce inflammation. So acupuncture is basically, for those of you who are not familiar, it has 12 regular channels and 361 major points in the body. And a lot of times these channels will start on the extremities, whether it's in the fingers, the toes, or the head, and then it'll run up, connect to the organ that it's related to, and then it'll keep going to the other end of the body and connect to the next channel. So for example, the liver channel will first start out on the big toe, and then it'll move up, connect to the liver, and then it'll keep going all the way to the head. So that's one major reason why a lot of times when people say, oh, I have a headache, and we put needles on the feet. And sometimes people think, oh, he has no idea what he's doing, or he didn't really understand what I was saying. And actually, it's not that. It's just that the liver headache in acupuncture is related a lot to the liver system, and the liver channel starts at the feet. And so that's why a lot of times it's kind of like you can treat from one end of the freeway, and it'll get there. The treatment will get to the head. So, this applies to a lot of different conditions. A lot of times, whether it's neuropathy or pain management, fatigue, a lot of times you see us putting needles actually on the lower limbs as well. In terms of philosophy, you probably have heard of the yin and yang theory, which is something that a system that they came up thousands of years ago. And it's basically two opposing forces that support and contradict each other. So you hear anywhere in the universe, you look at it and you have positive and negative, protons, electrons, male, female, yes and no, healthy and sick. So there's always a dual type of issues, and acupuncture is no different. It's based on theory of yin and yang. Without one, you don't have the other. And so when we start, what they did is they categorized everything in the world into two parts. Either a yin category or a yang category, and I'll go over why that matters later. So in terms of the yin category, when you talk about temperature, it's mostly cold weather. When you talk about gender, it's female. If you talk about passive or aggressive, it's on the passive side. Activity level, it's inactive. And then when you talk about colors, it's more related to the white color, tongue coating, whereas the yang category, if you see here, is related more to the hot temperature, the male gender, more aggressive, very active, and a yellow and red tongue coating. So one of the reasons why it's important is because we have to determine if the patient's condition is either a yin condition or a yang condition, because if the patient is already on the yin side, which is cold, they are already feeling cold, for example, we don't want to do a treatment that increases the cold, because that will make things even worse. So when we start looking at different conditions, we really want to see also the degree in which a person is having a yin condition or a yang condition. So let me move to the next slide. One of the ways that we do a lot of the diagnostic, because thousands of years ago, they didn't have MRIs or X-ray machines and other tools that we have today. And so they had to look at more, they have to observe, use the five senses in order to really observe the human body. And what they did is they started looking at people's tongues, they started feeling the pulse, looking at the ear, and looking at the face. And so I actually use a lot of ear diagnosis. The simplest one is actually looking at the tongue. And so I'll show you a little bit about how you can look at your own tongue and see what kind of disorders there are. And I'll show you some of the common post-chemoradiation type tongues so that you can see generally what happens. When we look at the tongue, and it's actually the tip of the tongue is the heart system right here. And when you stick out your tongue, if there's a discoloration, for example, a red tip, that usually indicates that you have a little bit more anxiety issues, maybe a little bit of stress. We see a lot of that when we're teaching our students. We see during finals week, we see a lot of this red tip in the heart system. And in acupuncture, the heart and the mental are tied together. So when people get stressed out, we say that their heart actually starts to pump a little bit more and a little faster. The side of the tongue here at the edges is the liver and gallbladder. Anytime we start looking at issues related to liver and gallbladder, for example, liver, if there's any tumors, cancer, any type of, we start looking for discolorations here, which we would expect to get darker on the two sides. A lot of times, actually, the simplest way you can look at it is actually for females. Acupuncture, the menstrual cycle belongs to the liver system. So whenever you're having PMS or you're having your menstrual period, you can start looking at both sides of the tongue and seeing if there's any dots on red dots or dark dots on the two edges of the tongue. If there's a lot of very dark colored, purplish color type dots, we would expect you to have more pain, more clots on your menstrual cycle, and then more discomfort. So, and then after the period ends, this disappears. So that's how you can see what's going on here. In terms of the center is the digestive system. The digestive system is more, especially if you start eating very unhealthy, we can tell because there's going to be a little greasy coating. And then in the back of the tongue will be the urinary and intestinal system, bladder as well as kidney. So depending on, in terms of cancer, depending on where that tumor or the cancer is, you start looking at different discolorations. And a lot of times we start looking at the tongue, and if we ever identify something that's a little bit darker or unusual, that's when we start referring people to their physicians, because it will require a little bit more testing. So a normal tongue coating is a very thin white, is a pink body with a very thin white film. Anything else is actually considered a disorder of some sort. So a yellow coating, as we mentioned before, is more considered a yang quality, while a white coating will mean more a yin quality. So let me show you a few examples of generally what happens. If you notice the first picture over here, there's a lot of cracks. It's very dry here, and almost like you're at in the desert. And when you look at the desert, it's so dry that the ground starts cracking. And this is one of a more common also post-chemo radiation type tongue that we see a lot. And it's because there's a lot of inflammation there and a lot of heat inside the body. And so this is where there's not enough fluid, and then the tongue starts to almost crack a little bit over here. Over here actually is the opposite, where typically we see a lot of that when there's a digestive issues, or maybe kidney or urinary bladder issues, where it's actually a little bit swollen over here. And you see teeth marks on the side, and generally that usually indicates that there's a swelling on the tongue, and the tongue will press on the teeth, and therefore you have teeth marks on the side of the tongue. And so generally there's a lot of fluid retention that we see here because the body is not metabolizing water as well, and therefore you start having some issues there in water retention. Here, this is what I call a lot of inflammation, a lot of heat. It's almost like you see a lot of that in menopausal type tongues, but you also see that when there's a lot of inflammation after radiation or chemo. Sometimes it's a lot of heat in there, and some people actually, some women will actually experience menopausal symptoms after chemo or radiation, and we see a lot of this. I kind of joke about it in that sometimes you might have your significant other have this type of tongue, and that's when you really want to watch out for any fights, because you're not going to win this one. So if you see these type of tongues, just kind of step away and don't fight. But this is where we actually do a lot of treatments to cool the body down, take a lot of the inflammation out, so that you have a more pinkish color tongue. If you start noticing over here, it's a little darker at the tip of the tongue where the heart is. That might have some palpitations, some anxiety issues. On the back here, there's a little bit of a greasy coating in the back, so that's the intestinal system. We would expect them to have a little bit of constipation because of the color, how red it is, along with the yellow coating. That usually means a lot of heat. Here's what I was talking about in terms of the greasy coating in the digestive system, where it's so greasy in there that the diet is really poor. And that's when we start looking at the dietary issues here. And even if you were to brush your tongue, within a few hours, 3 hours or so, this coating will come right back. And so there's really no hiding. And you just have to fix things from the inside. Here is also another type of inflammatory tongue that we look at. You see the cracks again, very dry, yellow picture, and you start seeing some pressure of the liver. I'll show you the next one. It's even worse. Here is the red tip again, and really dry coating, a little bit pale on the overall compared to the previous picture, how red it is over here. You start seeing a little bit pale, maybe a little bit some anemia, blood deficiency that's going on over here. Here, this is where we start referring to your physician, and you look at the side. There's nothing, there's no swelling, no mass on this side of the tongue, but on the right side of the tongue there is, and that usually you start wondering what's going on with the liver system. And that's when we would refer back to the physician to take a look and maybe do some examinations and tests. Same yellow coating here that you see, a little bit of dryness on the top, red tip, some dots on it. If you notice it, it's a little bit, and then overall tongue body is a little bit pale. So you start wondering if there's some anemia as well in this tongue, but something's going on here with the liver system. Some of the more common things that we hear about acupuncture is we take care of low energy, nausea, immunity issues, pain management, neuropathy, depression, digestive issues, and then stress and sleep. And so acupuncture has been pretty popular in trying to take away a lot of the side effects and improve the quality of life. And so that's kind of my presentation, and then I guess we can open it for questions.
Thank you for that overview. That was great. I do have one question. In terms of coverage, sometimes patients are concerned about, expense and out-of-pocket stuff. Are a lot of these services covered by insurance, or the issue is just trying to know when we refer for whether it's post-chemotherapy nausea or neuropathy pain, is this out-of-pocket for them, or is there coverage?
I would say for the most part it's out of pocket. I know at Methodist Wellness Services, they do charge a little bit lower rate of $45. And generally with insurance companies, it depends on the insurance coverage, but usually the copay is $35. So it's not as big of a difference compared to the $45. On average, if you go to outside, it's probably around $70 to $80 per treatment. But I think that's one of the places where I think Methodist has really cared a lot about the patients.
That's great. That's great. Super. Okay. Thank you so much. We really appreciate it. Thanks.
Thank you so much.
This is Shilpan Shah, I'm one of the hematologists here at Houston Methodist, taking over from Dr. Berniker. So I'll be moderating the afternoon session, and I apologize for any technical problems. I'm kind of remotely moderating this due to recent diagnosis of COVID. So the next speaker is Preeti Mehta. Preeti is a graduate of Auckland University of Technology in New Zealand. She's a board-certified clinical specialist in geriatric physical therapy to the American Board of Physical Therapy Specialties. She works at rehab education as a rehab education specialist at Houston Methodist Hospital, where she has worked for past 7 years and has extensive experience working with complex acute care patients, primarily in oncology and cell and gene therapy units, inpatient units. She's also a faculty member at the Houston Methodist Hospital Acute Care Physical Therapy Residency Program and is a certified clinical instructor for PT students to the American Physical Therapy Association. Welcome, Preeti.
Today, I will be talking to you about cancer rehabilitation in the acute care, and it's going to be a physical therapy perspective. So here we go. I have no disclosures. So some of the topics that we will be looking at is cancer rehab in acute care, the role of PT, OT, and SLP, challenges that impact cancer rehab, overview of PT role in acute care, and rehab follow-up options. So usually when I walk into the patient's room, these are some of the common questions that I may get. Who sent you here? Is a common one. Why do I need PT? Are you going to take me for a walk? Well, that's not exactly all that I do, but a part of it. What are you going to make me do? Do you think I can do that? And I want to go home. You know, why can't I go home? So it usually starts off with that baseline. And what can you do for patients that can't put weight on one leg? This is from staff and from patients and the family too. So, and a common thing that I hear across the board is, if I can walk, I can go home. Well, one of the things of this presentation is I want to pull together all the different aspects that physical therapists are involved in conjunction with the wider multidisciplinary team. So just the next few slides are just going to talk about cancer rehab and PT and OT role, and after that I'm going to dive into the physical therapy role. Okay, we all know that cancer rehab is integrated and presents with significant physical, psychological, and cognitive impairments, and the goal of cancer rehab is to restore function. And the key is that we are working with the medically complex population group, especially in the acute care environment. Some of the phases, preventative, where we minimize the risks associated with cancer-related therapies. Restorative, the goal is little to no disabilities. Supportive, to advocate, collaborate with the team. And palliative, and we are involved in the palliative and hospice care too, where we look at what can we do for this patient. Physical therapy in acute care, these are all the things that we can be consulted for and are consulted for. Prolonged bed rest, changes in baseline status, advocacy for discharge needs, a new need for assistive devices, and last but not the least, discharge planning. Okay, physical therapy role. Currently, 17 million cancer survivors living in the United States. By 2040, the increase is projected to be 26.1 million. We all know that exercise provides a myriad of health benefits. Exercise prescription is complex, and it is across the continuum of care and diagnosis, and it is a patient-centered pathway. It is what the patient can do, wants to do, and you work with them where you individualize the care. Our colleagues, occupational therapy, they work with all these points listed on the slide here, including wheelchair assessment and splinting. Speech language therapy with neurocognitive rehab, treatment strategies to improve speech and swallow, and education about the conditions. Okay, from physical therapy, some of the domains that I do take into account when I get a consult is I'm looking at the cardiometabolic status, where I'm looking at the risk. What was the, do they have a history of heart disease? How does that impact exercise prescription? To the oncologic specific population, I'm looking at cancer-related fatigue, chemo-induced peripheral neuropathy. How is that impacting the sarcopenia? I know Renee spoke about that. What is the age and comorbidities? So, for example, frailty that can present in addition to the oncologic diagnosis. Behavioral characteristics, lack of time, energy, and motivation. Some will tell you, leave, don't come back for 2 days, but there's a way that you want to work with them. And last but not the least, environmental factors in terms of access to care, follow-up with home physical therapy or outpatient physical therapy. This graph here just highlights the issues faced by patients in rehabilitation. As you can see, a significant number of patients have fatigue, and there's different areas of psychological issues, PT-specific joint range of motion limitations and weakness. So the gamut is complete, different areas are impacted. So from now on, we're going to talk about some of the challenges for PT in acute care. And one thing that I just wanted to highlight here is this is in what the patient's perspective is. So some things that they tell me is you have to know that I never cry, but today I just can't stop. It's coming from the inside. It hurts so bad, I cannot rate it on that scale when they have bone mets or severe cancer-related pain. I can tell you my spine precautions, so even though you worked with them for a week or two and some still can't remember what the spine precautions are. In terms of nutrition, everything tastes bad. I can't keep anything down. And I feel like I'm falling without even moving me, and thank you for working with me. All right, here are some of the challenges not listed listed for us all to understand what the patients that we work with. So patients come in, some of them are very medically, a lot of challenges that they're presented with, from pain to electrolyte abnormalities to obviously pancytopenia. That's an issue. Frailty, chemotherapy and radiation therapy, bone mets and how that presents in terms of pain or lack of range of motion to complete a movement. And fear. Fear is a big thing that sometimes, if not asked, will not be told to you. It's fear of falling and fear of movement. So the minute they kind of, even in the bed in supine, they may feel like they're falling off the bed. So you can imagine how somebody is going to tolerate movement. Other challenges as listed in this slide. So when we get a consult here in PT, we get it from MD or NP, consults PT services. A complete chart review is done, and care is coordinated with providers, and any clarifications with our nurse practitioners, medical team. And we individualize the plan of care, and of course, goals are patient-centered and realistic. Okay. These are all the different components that I look at when I evaluate a patient. What is the baseline function? Falls history, the vitals. With the vitals, I'm looking at, well, are they orthostatic? How is that presenting with function? Muscle strength, functional mobility, balance, endurance. So these are all the components that go into me being able to say, well, the patient can walk, or no, they can't walk. Well, we don't know. We'll figure that out. Okay, and here is a pictorial. This picture, I want you to look at the left, your screen on the left. It's a left foot drop. And this, we're going to build on how this is impacting physical therapy. Now, when they're at rest, we use some of positioning boots to maintain the muscle length as best as we possibly can when patient is educated to look at skin integrity and, a wearing schedule is set up. Now, over here, I'm going to play this video. This is a functional mobility assessment. This is an individual attempting sit-to-stands. As you can see in the slide, there's two of us, thanks to Julio, one of my techs. We have a specialized walker, which you will see a little bit more in detail. So yes, the patient can complete a sit-to-stand, but we need to appreciate how much effort and how much assistance is required. And the sit-to-stands not happen, it could be about 3 or 4 or 5 sessions for somebody to be able to do that. It's the repetitions. So this is gait retraining. So this is, in other words, walking. But please appreciate the left foot, the foot drop, the equipment needed, the level of assistance that the patient requires to complete that activity. Again, you know, for PT and rehab, OT and SLP, we're involved in multiple aspects of care for the cancer survivors, and it goes from inpatient. It's rehab starts on day 1. That's what I tell my patients. 1 day is too late. You have to start on the same day, and continues through outpatient therapy. There are some patients that undergo therapy for 3-4 years, depending on what their limitations are. But this is a whole host of things that we look at, starting from inpatient all the way to outpatient. One thing that I wanted to point out in this slide is the driving. You know, that is so important for patients to return back to their functional status, and sometimes we get, can they drive? Well, there is an assessment that needs to happen, and here at Houston Methodist in our outpatient clinics, at one of the locations, we do have specialized OTs that put the patient through a driving simulation and help with that. So when I am looking at the patients, I do rely on my evidence-based practice to provide the best care. And some of the things that I look at are some outcome measures. So one of the, in different areas, so I look at what are they age-matched norms in the community, how are they presenting. So in terms of endurance, I could look at the 2-minute walk test or the 6-minute walk test, the Borg, and some of the strength tests. So as an example, a modified 30-second sit-to-stand is a good indicator of lower extremity muscle strength. And the research done in 2014 and most recently in 2019 in the older 65-plus frail patients, 7 repetitions is what they consider as a cutoff to minimize fall risks. So that is so important for minimizing falls and also function, because if you don't have strength in your legs, you can't do a lot of things, even simple things like standing up from a chair. Okay, and some of the balance tests that I administer in the acute setting are listed here. And the one thing that in the middle of the screen, you can see activity-specific balance confidence scale. This I use for patients that are very fearful of any movement, and that gives us an idea as to what area they're afraid of. And gait speed is another one. The reason I have highlighted, I've boldened the 2 points here, the timed up and go and the gait speed in red and underlined it, because you'll see a recurring theme of these 2 tests in most literature. So this is it's a reliable test and easy to administer, and this is what this looks like. So this slide just talks about the benefit of gait speed, and just to summarize this is discriminative in determining rehab potential, because I get asked by the team and the providers, you know, where should we send them? And this is one way that it helps me make a determination in addition with the function. This is what this looks like: walking speed, gait speed, called the 6th vital sign. In this slide, the things to look out for are just with the meters per second, that's how it's measured. So if somebody's gait speed is 0.2 meters per second, you're looking on the left-hand side of your screen, and you're seeing that the patient is dependent in their ADLs and is more likely to be hospitalized compared to somebody whose walking speed is 1.2 meters per second. The normative walking speed required is 1.2 to 1.4 meters per second for you and I, for anybody to cross the street. So there's a lot that goes on with that, and it is measured over this. Lot of research articles out there that talk about the 4 meters or the 6 meters or the 10 meters. I stick to the 4 meters, and that is it's doable in the acute care setting. Okay, a few things. There's in 2020, the scoping review was conducted, and that showed that the negative effects of chemo are present during the 3 to 5 years of survivorship. And again, timed up and go and gait speed were the two tests that was done in addition to a whole gamut of tests, and these were shown to be decreased across the survivorship spectrum. Mobility measures in older cancer survivors, again, 2020, Dr. Blackwood and her team looked at 50 cancer survivors, 65 plus, and again, gait speed and timed up and go were impacted across all the all different points of follow-through. Again, published in the Journal of Geriatric Oncology. When they looked at it, they said that gait speed was correlated with frailty, disability, falls, and hospitalization. And last but not least, the cognitive function of patients is also impacted. So when in the study, they looked at immediate word recall, delayed word recall, executive function, and as that decreased, then gait speed decreased, and the participants were at a higher risk of falling. So initially in the acute care setting, that's why I like to get some of these measures to determine how the patient is doing and what we're aiming for. Okay, this is the same, slightly different superimposed slide on the walking speed that you all saw. Over here, it just has like the risk of hospitalization, which correlates with the gait speed areas. Okay, there are resources that we rely on in the cancer rehab areas, which is published by Acute Care APTA. We have a vital sign interpretation guide. The APTA oncology section is involved in how best practice care is provided to our patients. I will not go through all the details here, but we do have, we always look at the hemoglobin and the platelets, some guidelines, but of course, for the next few slides, I want to emphasize that it is symptoms-based approach, because the risks of bed rest are far worse than movement, but again, when we do decide to work with the patient, we do take into account different values. So the previous slide you saw was the hemoglobin, these are the platelets. Going from here, anemia, as it says, it's a simple symptoms-based approach, and I use scales like the rate of perceived exertion or modified RPE scales to gauge how effortful, and of course monitoring vital signs and any signs of adverse events. Thrombocytopenia, again, we do work with patients that are thrombocytopenic, albeit with some parameters. Dr. Fu and his team in 2018 came up with some guidelines that are used, and most recently in hematology was published by Morishita and colleagues about some parameters, and this is what we follow, and as you can, with this is below 20,000 resistance is not recommended, but after 20,000, 20 kPa, then gentle resistance, and basically getting patients back to rehab and moving. Rehabilitation, by that I mean across the setting, acute care, home, outpatient. But of course, as a PT, I am going to be following symptoms-based guidelines and patient tolerance. Further, the Canadian Physiotherapy Association and the APTA looked at some clinical practice guidelines for patients with multiple myeloma, and it's along the same pathway for hemoglobin, platelets, and anemia. Neutropenia, of course, is symptoms-based with the infection. But with this, I want to talk about the bone lesions, bone mets. That's something that we encounter. Bone lesions are not an absolute contraindication to PT. We can work with patients where we modify activity by avoiding high-impact activities and appropriate mobility aids and braces. Just general safety measures is, of course, no progressive exercise in the affected limb, offloading affected limb with assistive device, avoiding spinal flexion, extension, and rotation, the spine precautions, which can be very hard for a patient to remember. There's a lot that complete change in activity. And as a PT, I will be monitoring for increasing functional pain. Okay. Again, with bone lesions, what do? Are we exercising patients, or is it more activity? The answer is it really does depend, because sometimes with functional activities, that is what a patient can do. You know, if I go in there and tell them, I want you to do 10 reps of this versus do you want to get in the wheelchair to move, you know, so we got to weigh up what is the best for them. Again, spine precautions, bracing. With bracing, again, we're in touch with the team because, you know, bracing, it's just not one section of the vertebrae that you can brace. Weight-bearing precautions, pain issues, and DME recommendation and management. So wheelchair, it could be a manual wheelchair, custom power wheelchair. We look at the home access along with the OT and ramp access. All right, this is my colleague, Cody. We just wanted to simulate and show you what a wheelchair transfer actually looks like. So we make it look easy, but I can guarantee you that it is not easy for somebody. This is where you can see the patient is non-weight bearing on one leg. And this is walking, right? But how effective will this walking be? Because this is non-weight bearing, and there's a lot of upper extremity use and non-weight bearing. And imagine if their pet comes running to them, they're going to be on the floor. There is no point of balance. This is another equipment that you initially saw from the rear view, but this is a Sarah Steady. This is somebody who's weak. What I want you to notice in this video is we simulate the knees buckling or giving way, and there it goes. So that is something with weakness, that is something that can happen, and this is a specialized equipment that we're using. Again, another specialized equipment, which is Sarah Steady, when patients have decreased tolerance to standing, where they can rest, and this is some ways of improving function, improving standing tolerance, and moving. Okay, just almost there, just energy conservation guidelines, because we want to teach our patients and also our caregivers with planning activities, prioritizing. If it's transferring using the sliding board, you know, how energy efficient is that? How much energy is required to complete that activity? Pacing activity, positioning, and of course breathing. These are some things that we incorporate in the functional activities. We do, in terms of termination for criteria for termination, you know, when there's a decrease in heart rate, I'm looking at the vitals, I'm closely monitoring the patients, and again, symptoms-based. But when there is decrease in heart rate and blood pressure with increasing workload, I'm going to stop and reassess and take it from there. New onset of dysrhythmias and SATs, decreasing SATs, so in rest rate, you know, less than 5 or greater than 40. So all systems are in one when we look at the patient. And physical therapy, very important in terms of discharge recommendation. In a study that was done, it showed that where discharge recommendations were not followed from the PT, the patients were 2.9 times more likely to be readmitted to the hospital. So discharge plan is a team effort. Physical therapy does continue after the hospital setting, and these are all the list of places that patients can continue with the physical therapy sessions. Here at Houston Methodist, this, I understand it may be a little bit hard to read it, but I just wanted to show you that patients can follow up in different clinics where there is a driving assessment, there's different bioness if needed. Vestibular rehab is an important thing. So just take-home points, individualized plan of care, outcome measures are very important, communicate and collaborate with the team, consider functional status and social support. Discharge plans evolve, and I can tell you that today we're planning on discharge home, but tomorrow is a different story. Education is important for patients, caregivers, and the team that we work with. I want to thank Dr. Shah and Dr. Berniker for inviting me here, and I appreciate it, and this is all I have to say. Thank you for your time.
So I'm glad you touched base on the blood counts, because, you know, that's always my question. It seems like the absolute number of the counts, the hemoglobin and the platelets, is not a big problem. You go by symptoms usually. And from the slide you showed, it sounds like thrombocytopenia, even if it's less than 10,000, should not be an absolute contraindication for you guys to work with the patients in the hospital. Is that right?
Yes, that's, again, for the most, yeah, when patients are able to be transfused, they get transfused usually in the mornings, and then I'm working with them. Again, symptoms-based, but I do collaborate with the team when, in cases where transfusion is not appropriate, and we still work with the patient. So again, I would say it's symptoms-based. Sure.
Okay, and I have one virtual question that would be the only one because of time constraints. Okay. Is all the special equipment available for inpatient rehab and the admission setting also available in the outpatient and home setting?
Yes to the first part. Most of this equipment here at Houston Methodist in our rehab unit, we do have access to the Sarah Steady and the Sarah Plus, that equipment that you saw. But unfortunately, no, not in the outpatient setting. And in the home setting, no, because if patients are requiring such specialized equipment, then we need to work with them. We have to look at what their function is in terms of discharge home. I use this where appropriate to start off improving their tolerance and their strength, and then progressing them from there to equipment that they can take home and with insurance and all.
Okay, well, thank you very much. Dr. Julie Rose. Dr. Rose is the Newman M. and Mulready Harris Professor and Chief of Division of Oncology Hematology in the Department of Internal Medicine at UNMC. She graduated from medical school at UNMC, completed her internal medicine as well as chief residency there, followed by a Hem-Onc fellowship, and has been on faculty there since 1990. She also completed MBA in Health Administration to the University of Colorado Business School. Dr. Rose is an internationally known leading expert in the treatment of patients with Hodgkin's and non-Hodgkin's lymphoma, as well as CLL. She's actively involved in many novel clinical trials, including targeted agents, monoclonal antibodies, and cellular therapy. Dr. Rose has published over 400 articles in high-profile medical journals, most of which deal with finding optimum care and treatment for patients with lymphoma. She's also active with national and international hematologic and oncologic societies, and served as the 2016 president for American Society of Clinical Oncology. Welcome, Dr. Rose. Thank you so much for sparing time. You can begin whenever you're ready.
So what I'd like to do today is to just talk about an update on some novel therapies for non-Hodgkin's lymphomas. And there's a lot of them, so this is not meant to be totally inclusive. There's so many new things today. Happy to answer questions for other things also after the end of the talk. These are my disclosures. So areas that I was going to cover today included some CAR T-cell therapy, as far as just a little bit of background, talking about some of the newer constructs and clinical trials, talking about some other monoclonal antibodies that also have looked very interesting and are approved, and some of the new bispecific antibodies and some of the information that was presented this past year, and then some antibody drug conjugates as far as the makeup of those, and also some that have been approved and are being looked at in the future for lymphoma. So this first slide just shows the currently available CAR T-cell commercial agents for diffuse large B-cell lymphoma. And as you know, we have 3 commercial agents available: axicabtagene ciloleucel, fusogen ciloleucel, lisocabtagene maraleucel. And they all are just very slightly different with respect to their co-stimulatory domain, or in the case of liso-cel, that the CD4 and CD8 are manufactured separately and then given back together to the patient as one single agent. They all have kind of similar outcomes. I'm going to go over the next few slides. So this is from the axicabtagene ciloleucel, or AXA-CEL study, and demonstrating now with really long-term results that if patients are in remission, typically at 1 year after treatment, very few of those patients actually relapse, and the progression-free survival from this original ZUMA-1 study was about 40 to 45% of patients remained in complete remission without a relapse. If they were in remission at 1 year, the majority of those patients stayed in remission. So very long-term results now. These were patients that really we felt would not be otherwise cured of their lymphoma. So we probably are curing a percentage of these patients that would otherwise not be cured with other therapies. So obviously very, very exciting and very interesting results from these original studies. This is from the Transcend study, and this is the Lysocell product. Kind of very similar with respect to complete response rates from all of these regimens were in the range of about 50% to 60% range, overall response rate 70 to 80. And again, if patients are in complete remission at 12 months, many of these patients stayed in complete remission, and in this case, about 60% of patients. So very long-term results are looking like they're maintaining these and hopefully continue to do so over time. And this is from the third product, and this is from the Juliet study, from the Tesogen Laclusol product. And again, those patients that are in complete remission after the treatment maintain their progression-free survival and overall survival in an excellent fashion. So any of these products that are currently commercially available, you can see that they have slight differences in toxicity, which I won't talk about necessarily today, but they do produce long-term disease-free survival in a number of patients. So very promising. Of course, CAR T-cell is now expanding for other types of lymphomas, such as this particular study, the ZUMA-5 study, which again looked at the axi-cell product for follicular lymphoma patients. And in this study, you can see this is compared to the SCHOLAR-5 study, which was a matched group of patients that had follicular lymphoma with respect to outcomes, and the ZUMA-5 information, looking at these patients, many of which had failed multiple prior therapies, 3 or more, in some cases many more, and many of which had failed within short periods of time, so-called POD 24. And the patients that were in the ZUMA-5 study were very high-risk patients, yet they appeared to do much better than this historical control, the SCHOLAR-5 study. And again, these are not very long-term results because the study was more recently done, but we're hopeful that these results can hold up over time and continue to benefit some of our patients. So this is currently approved for patients who had failed 2 or more prior therapies, and the majority of patients that were in the study had actually failed more than that. And then the ZUMA-2 study, which was also similar to the axi-cell product for, in this case, mantle cell. And this was a global phase 2 study. You can see that there were about 68 patients that actually ended up getting the treatment. Primary endpoint was overall response rate, and these were very multiply heavily treated patients with 1 to 5 prior therapies, but the majority of them had multiple prior therapies. The majority could be apheresed and could be manufactured, and successfully manufactured in 95% of the patients and administered to 92% of the patients. Again, excellent results in these heavily pretreated patients. Overall objective response rate was 93%, with 67% of those actually being complete remission. And you can again see that the duration of the response is quite good, with, again, if they are in remission at 12 months, it appears that about 60% of those are staying in remission. This is now commercially available and being utilized in more patients. I'm sure we'll have additional data from some of the commercial use that will be presented at the ASH meeting this year. And this is a study that was presented at the Lugano meeting, ICML 2021, looking at the Transcend CLL study, which is the product that is the Lysocell product. In this particular study, they looked at patients that are very heavily treated with CLL or SLL. They had to have progressed on ibrutinib, had features that would show that they would be more difficult to treat, multiple prior therapies, and they looked at, again, the Lysocell product in some different dosages. Patients received the standard lymphodepletion of fludarabine and cyclophosphamide, and then there was some different dose escalation cohorts. There's also cohorts that are currently ongoing, trying to add a BTK inhibitor or add other agents to this study to see if they can improve the results even more. but very interesting initial results. This was looking at the best overall response rate and looking at undetectable minimal residual disease. And you can see that all the patients here had a high complete response rate, which of course you don't see in patients with PLL very often, and also had very high undetectable MRD in blood and marrow that was in all the different dosage cohorts. So I think we're going to be seeing a lot more of this, and of course undetectable MRD is something that's pretty difficult to obtain with some of our standard treatments we currently have. I think you'll be seeing more of this also presented at the ASH meeting this year. This shows that same study with respect to median duration of response and median progression-free survival. Again, short follow-up, so it's hard to know, but these very heavily pretreated patients do have some very exciting early outcomes that we'll be watching with all longer follow-up and more patients. So what are new directions for CAR T-cell? Obviously, looking at CAR T for other types of lymphomas, perhaps using them earlier in the course of the disease. We have had some early information on the randomized trial that are patients who have relapsed early. There were 2 out of the 3 that appeared to be positive from press releases, but I'm sure, again, we'll be seeing a lot of this at the ASH meeting this year. Also looking at the use of pre, during, or after CAR T add-ons, that is other agents that would be anti-lymphoma agents, radiation therapy priming, possibility of using other immunologic therapy to try to enhance the effects of CAR T-cell. And a lot of those are in clinical trials currently. Novel antigen targets, all of the current ones that we have are all CD19, and then of course the myeloma ones are BCMA. But we're also looking at other targets that may be appropriate for targeting for lymphoma and in dual targeting agents. Armored CARs are looking at trying to enhance the cytokine production even more by manufacturing alternatives. Allogeneic CARs are universal CARs using off-the-shelf products where we don't have to manufacture that in each individual patient. There's some pros and cons to that, as I'll talk about in a minute. And then NK CARs, which also appear quite promising and are going forward in further clinical trials. So bispecific CARs are dual targeting. There's been some of this early presentation. This was from ASH this past year of the AUTO3 trial. They had a bispecific CAR with CD19 and CD22 targeting, and this was followed by an anti-PD-1 in patients with refractory DLBCL. So this is the CAR targeting CD19 and CD22, and this is dual targeting to try to look at 2 independent CARs delivered in one single retroviral vector. It is humanized binders and has the 4-1BB and OX40 costimulatory domains. It has independent targeting of the 2 agents, so 2 targets, I should say. So perhaps in each individual cell there may be different targeting, but less escape, hopefully, with this bispecific CAR. So very early study information was presented at ASH this past year, and I'm sure we'll be seeing more. Build a better CAR would be trying to look at maybe 3rd generation products, such as having 2 costimulatory domains, as opposed to our current 2nd generation CARs, which have 1 costimulatory domain. So lots of different ways to possibly engineer and enhance our product. Allogeneic or universal CARs now have many different clinical trials. I won't go into specifics, but there are some advantages to this type of CAR T-cell. There's no leukapheresis that's needed, potentially decreased costs because there's not individual manufacturing for each patient. Multiple vials can be made from one donor, and different banks could be maintained with different HLA subtypes so that each individual one didn't have to be matched for a patient and manufactured. It could be off the shelf. Automated platforms possible for manufacturing in large bulk, and decreased time to infusion, certainly since that manufacturing time does not need to be present. Quality of the T cells may be better because they're taken from normal donors and there's no prior chemotherapy given to that donor. So it might be that perhaps even less of a dose would be necessary. Potential disadvantages could include risk of graft versus host disease because you're taking, of course, someone else's cells. HLA-matched or gene editing may be necessary, and persistence of the cells possibly less with this due to some of these reasons. But lots of different studies going on in this universe as well. We'll be seeing results, I'm sure, at our upcoming meetings the next few years. I'm going to switch now to talk to monoclonal antibodies in lymphoma. Of course, we used rituximab for a very long time and other new antibodies such as obinutuzumab. But there's one that's a little bit newer that I want to touch on, tafasitamab, anti-CD19 antibody. CD19 is very broadly expressed in B-cell lineage, and it's not on stem cells and not on plasma cells, which are helpful. It is, in this case, a humanized monoclonal antibody, and it is engineered to have 2 amino acid substitutions to potentiate ADCC. This has been done and looked at in a number of different studies now, and there was a phase 1 in CLL that established the dose and had a fairly high response rate, and then a phase 2 in relapsed or refractory non-Hodgkin's lymphomas, the subtypes are listed there, that patients that had failed prior therapies, as is our usual population, and they received, you can see, 12 milligrams per kilogram every week for 8 weeks, and then went on to a maintenance schedule. Toxicities were some cytopenias and dyspnea, but there was very few patients that actually discontinued the product. The responses to tafasitamab in different studies are shown on this slide. Overall response rate, about 25 to 30% in the different lymphomas as a single agent. And you can see the complete response rate is pretty low. But there were some durable responses, and the toxicity was manageable. And so this was certainly looked at further in further clinical trials. The next idea was to combine tafasitamab with agents such as lenalidomide, which appear to enhance the NK cell-mediated ADCC. So this is originally a phase 2 study with relapsed refractory diffuse large B-cell lymphoma, 81 patients who had 1 to 3 prior lines of therapy, including a prior anti-CD20 monoclonal antibody. They were either ineligible or failed an autologous transplant. And you can see the exclusions there. The treatment was in 28-day cycles, and tafasitamab was given, as you can see, day 1, 4, 8, 15, 22, and then weekly after that. Lenalidomide was given at 25 milligrams per day for 21 days and adjusted, of course, if there were cytopenias. We looked at the outcome for these patients and appeared to be quite interesting with respect to increasing the overall response rate quite a bit to near 60%, and complete response rate was 40% in these heavily pretreated patients. There were some adverse events, including cytopenias for the most part. There were about 5% what were felt to be related deaths, respiratory, CVA, worsening PML, and a sudden death of uncertain origin. But the response rates are quite high, even if the patients had many prior lines of therapy. So this is an option for some patients who relapse after transplant, not transplant or CAR T-cell candidates, or other agents have already failed multiple times. This is the outcomes for the tafasitamab plus lenalidomide progression-free survival. If the patients had a complete response, you can see that many of them are durable, even out to past 2 years. And this is an ongoing trial, anxious to see further outcomes. So tafasitamab and lenalidomide is very active and tolerable in many patients. It's non-randomized, so obviously we really need to see a randomized study to know that for sure. Can you use tafasitamab as a single agent? Hard to say. It appears that the outcomes, of course, are much better with the lenalidomide. It may be that we can use some of these for our patients who, again, have not been able to go on to transplant or CAR T-cell. It's really unknown if we can use this post-CAR T-cell failure, since it also attaches to CD19. There's a number of different studies that are currently ongoing and enrolling, looking at different combinations of tafasitamab plus rituximab and lenalidomide, tafasitamab plus bendamustine, plus or minus rituximab. That one actually failed early futility analysis and has been stopped. the top line, which is looking at tafasitamab plus different agents in lymphoma or CLL, and Cosmo study looking at tafasitamab plus idelalisib or venetoclax for CLL, SLL. So lots of different potentials for this particular agent. I'm sure we'll be hearing more about that. I'm going to go on to bispecific antibodies for lymphoma. Bispecific antibodies are a very interesting class of agents. We're trying to target the tumor antigen, whatever that might be, in this case, B-cell antigens, and also in the same component, target the T cells by CD3, which may allow us to attract the Fc receptor accessory cells and co-stimulatory molecules, cytokine release, to be able to cause tumor cell kill. This is just a diagram of that phagocytosis and lysis of the cell. So there's 5 CD20, CD3 bispecific antibodies that are potentially on the horizon, several of which have had clinical trial information presented over the past year I'm going to go over. So there's mosunetuzumab, glofitamab, odronextamab, epcoritamab, and plamotamab. All right, interesting name. So mosunetuzumab is an IgG1, CD20, CD3 bispecific antibody that helps to direct the T cells to engage and eliminate the malignant B cells, as we talked about a minute ago. There has been some single-agent mosunetuzumab activity in relapsed refractory diffuse large B-cell lymphoma, and also there's been some interesting studies trying to use this as combinations or earlier in the course of the disease. So this slide just shows some of the efficacy of mosunetuzumab as a single agent in relapsed refractory diffuse large B-cell lymphoma or transformed follicular lymphoma. And you can see here that there was fairly good activity, particularly at the higher dose levels. Some of the lower dose levels had less good activity, and especially in the diffuse large B-cell lymphoma. You can see that's a complete remission rate here in the blue line. Does appear to be durable in some patients and is ongoing in many of the patients. So the overall response rate was about 35%. Complete response rate was about 19%. This is continuing to be studied not only as a single agent, but also in combination. This is an interesting study from ASH this past year, looking at a phase 1/2 study of mosunetuzumab as a first-line treatment in patients who were elderly or unfit and weren't felt to be able to take standard anthracycline-containing regimens. These were treatment-naive diffuse large B-cell or high-grade B-cell lymphoma, either over age 80 or 60 to 79 with greater impairment of greater than 1 or equal to 1 activity of daily living, and unable to tolerate standard chemoimmunotherapy. There was an optional pre-phase also with prednisone and vincristine, step-up dosing during cycle 1, given on day 1, 8, and 15. And then with subsequent cycles, the mosunetuzumab was given on day 1 of each cycle. This was a very interesting abstract from ASH this past year. I think the most interesting part was although it was a small number of patients, there were a fairly high complete and partial response rate, especially at this higher dose level of 30, only 14 patients, but there was a 50% complete response rate with single agent, which I find quite interesting. So there's potential, I think, for combinations with mosunetuzumab, particularly for these patients who can't tolerate our standard therapy. Moving on to some others, odronextamab, or the Regeneron 1979, is also a CD20, CD3 bispecific antibody. CD3, of course, binds to T cells, CD20 on malignant B cells, which triggers the T cell-mediated cytotoxicity. This, again, is off the shelf, doesn't have to be manufactured, and for IV infusion. Anti-tumor activity is shown on this slide. And you can see that there's a very high overall response rate and even a 70% complete response rate for relapsed refractory follicular patients. About 81% of CRs were durable and ongoing up to 41 months. So for follicular lymphoma, this looks quite interesting. For diffuse large B-cell lymphoma in patients who had failed CAR T-cell, the complete response rate was less, only about 20%. However, for those patients who did have a complete response, it was quite durable, and CRs were ongoing for up to 20 months. So this may be very exciting for a very specific subset of patients if we can figure out which patients respond to this. Toxicity, of course, is always an issue, and there were no greater than equal to grade 3 tumor lysis syndrome events, or there weren't any high-grade ICANS neurotoxicity or tumor lysis syndrome or cytokine release syndrome. Patients, for the most part, had very low-grade toxicity, and this particular agent was fairly well tolerated. Another agent to talk about is epcoritamab, and this is a novel subcutaneously administered CD3/CD20 bispecific antibody, which induces T-cell activation by binding to CD3 on the T-cells, and then, of course, CD20 on the malignant cells. Promotes immunological synapse between those, and then programmed cell death. Binds to a very distinct epitope on CD20 that is different from the epitopes rituximab and obinutuzumab bind to, which may be beneficial in certain patients who are rituximab refractory. This particular study there was a first study that was sort of flat dosing, and then there was a second study that was step-up dosing every 28 days. Inclusion criteria, as you can see here, patients who failed multiple prior therapies, and they had step-up dosing, primary response objectives, secondary response objectives, of course, safety and tolerability. Response rates for this diffuse large B-cell lymphoma had a fairly high response rate. 6 out of 10 patients were ongoing that had a complete remission. You can see here, especially again at the higher doses. Follicular lymphoma also had many complete remissions. Mantle cell, there's only a couple patients that were treated. But very exciting results, and interesting, and this is ongoing, of course, just further studies. Glofitamab is a T-cell engaging bispecific antibody, and it's interesting in that it has a unique 2-to-1 molecular configuration associated with that. So you can see here it has actually 2-to-1 configuration on the CD3 T-cell engager, which potentially is felt to be an improvement for targeting. Obinutuzumab is also given as a pretreatment to try to mitigate cytokine release syndrome and allow dose escalation of the glofitamab. This was presented by Dr. Hutchins at the ASH meeting last year. Those studies, as well as the other ones, are presented on this slide with comparison, just showing that there have been quite a few patients now treated with these different agents. The overall response rate is very similar with respect to kind of in the 60s or upper 50s, and complete response rate varies from 37 up to 91% in some cases. Complete response rate is noted there. Cytokine release syndrome. There is a low-grade cytokine release syndrome with the majority of these, but very few had grade 3 or higher cytokine release syndrome. Neurotoxicity, also low-grade for the most part, and very little high-grade neurotoxicity. So potentially better tolerated as compared to some of the CAR T cells. One disadvantage is that you do have to continue to give this agent. It's not a one-time treatment like the CAR T cells. So there's pluses and minuses to all these treatments. Antibody drug conjugates. This is just the format of an ADC seen on this slide. So we have the tumor antigen that are abundant in the tumors, have minimal expression in the normal cells, and hopefully would lead to internalization. And the antibody properties, we want some good affinity and good internalization. Connected to that by the linker, which is the cleavable or non-cleavable linker, which helps to get the cytotoxic agent into the cell. And the cytotoxic drug that we can use, many of those are microtubule inhibitors such as MMAE, but also DNA damaging agents, as you can see here. And this can also vary by the number of ones on a cell as well. Several good antigens for targeting with these agents. CD19, 22, 25, 30, 37, and 79B. And you can see some examples of agents that are either approved or in clinical trials. We're going to go through some of these individually, but and certainly some are already available, such as rituximab vedotin. But they have pretty high response rates in many of these different studies and are a very interesting alternative, different type of treatment for patients. There's currently a number of different antibody-drug conjugate payloads. Most of them currently available are microtubule inhibitors, either auristatins, such as MMAE, or maytansines. There's also DNA-damaging agents, as you can see here, that are in some of the newer molecules. So this slide shows comparison of the free drug potency. So you can see here the current kind of chemotherapy agents, and then the antibody-drug conjugates payloads here with respect to free drug potency. Potential payload options that are being tested in other malignancies also: camptothecin analogs, cryptophycin-based tubulin agents, RNA polymerase II, RNA splice inhibitors, and also, of course, other toxins such as ricin or diphtheria have been tested for quite some time. Always have to worry about potential side effects from some of these payloads that might get outside of the cell, but for the most part, many of these have less toxicity than some other agents. So this shows the mechanism of action of the antibody-dependent cytotoxicity in cells. The antigen would be antigen recognition from the ADC, internalization. They have linker cleavage, and then the payload is released. DNA, of course, is incorporated, and then there's microtubule disruption in the case of many of the ADCs. So building an ADC, we have to pick an antigen and an antibody combo. These are some of the current ones that have been looked at in clinical trials. Choose a linker. Do we want it to be cleavable or non-cleavable? Do we want it to break off when it enters the cell, or do we want it to be maintained? Conjugation, either heterogeneous or site-specific, and then to pick your payload of the different options here. A couple of the agents that have been previously FDA approved, polatuzumab vedotin. I think we're just starting to realize that this is a really potent agent when combined with other chemotherapy or other monoclonal antibody therapy. And I think there's a lot of potential here. The FDA did approve this in 2019, and this is indication with bendamustine and rituximab for patients with relapsed and refractory diffuse large B-cell lymphoma who have failed 2 prior therapies. You can see here that it will, polatuzumab will attach to CD79B, be internalized, and the data is quite interesting with respect to the original study. Multi-center retrospective study compared to bendamustine rituximab alone versus bendamustine rituximab plus polatuzumab. And many of these patients had failed CAR T-cell therapy. 7 of the 12 patients did respond to the pola-BR, and the benefit was long-lived in some patients. You can see from the CR rate, it was actually quite a bit higher in the pola-BR, up to 45%, as opposed to only 17.5 in the control arm. So this led to the FDA approval, and I have to say I have used this combination in patients. It's very well tolerated and something that you'll probably be seeing in the future. The other way this is sometimes used is polatuzumab plus rituximab without the bendamustine if you don't want real cytotoxic therapy, potentially as a bridge to CAR T-cell. This is CD79B, which is the humanized cleavable peptide with MMAE. Again, FDA approved for combination with BR, sometimes we drop the B, and potentially using for bridging to CAR T-cell therapy. There was a press release about the potential for this Polaris trial that is, sounds like it's going to be presented at ASH this year, where frontline treatment, this was taken in the frontline in combination with our chip, and I think we'll be seeing this presented at ASH this year. Sounded exciting. Blanca tesirine, is a CD19 monoclonal antibody that is a cleavable peptide linker to PPD, and this was approved just earlier this year for relapsed refractory diffuse large B-cell failing at least 2 lines of therapy. Overall response rate was about 48%, complete response rate 24%, and they're currently having a variety of ongoing studies with this combination. Blanca, again, was approved in April 2021, and mechanism of action you can see here, CD19 targeting, and then it's conjugated with the linker to BPD toxin. The LOTUS trial, you can see, looked here with the overall response rate of about 50%, about half partial and half complete remission, and looked at the median overall survival of these patients. Some patients did get quite a bit of mileage out of this particular agent. The multi-center trial, phase 2 study, with greater than or equal to 2 prior therapies for relapsed refractory diffuse large B-cell. You can see the design of the trial here. They had first 2 cycles at a higher dose, and then after that, they had a lower dose. You can see that the patients did have some toxicities, of course, cytopenias, anemia. A little bit of unusual toxicity for this agent is edema or effusions are present in about 1/3 of patients. It can also cause some skin and nail disorders in about 40% of patients. You have to watch for liver enzyme abnormalities. But it is an agent that some patients respond to when they haven't responded to other agents. The slide shows the overall response rate, again, about 50%, complete response rate about 25%. But for those patients who do get a complete response, it is somewhat durable in those patients. Looking forward to the future possible modifications for induction therapy, I think we're going to be seeing that there's lots of potential substitutions. As I mentioned, the polatuzumab addition to induction therapy sounds like it may be a positive study, the first kind of frontline add-on therapy that we've seen as a positive study, if that's the case. And be very anxious to be able to look for those results in the future. Autologous stem cell transplant, I see that being used possibly less often for our patients. Certainly, the standard indication, a late relapse that is chemosensitive goes into a second CR. I think that's still going to be a standard use for those patients, but unfortunately, not all of our patients go into complete remission with salvage therapy, or they relapse early, and 2 out of those 3 studies I mentioned sound like they're going to be positive for the use of CAR T-cell earlier as opposed to later in those patients. Second-line treatment for CAR T-cell, we haven't looked at the data, so it's hard to know, but maybe that'll be supported by those studies, and we'll be anxious to see that information. Bispecific monoclonal antibodies, I think, are going to be very useful for some patients in relapse, especially for those that are non-CAR T-cell candidates or potentially for relapse after CAR T-cell. One downside, of course, is that you have to continue to dose the patients as opposed to one-time dose for CAR T-cell. So they're definitely going to have their pluses and minuses. They're probably a little bit easier to give from the toxicity standpoint as compared to CAR T-cells. So I think we're going to be continuing to look at that in the future. Certainly lots of other antibodies or immunotherapy in development. We talked about a few of them today. We didn't really talk about all of them. But I think we're going to be seeing just tons and tons of clinical trials, trying to be able to make sure that we can find out which patient is most appropriate for which particular agent, and to be able to kind of modify those as appropriate based upon the patient characteristics, age, comorbidities, and other issues that we take into account every day. And with that, I'll complete my talk and be more than happy to answer any questions if there are any.
Thank you so much, Dr. Walls. That was an excellent overview of all the new treatments. It sounds like this decade for non-Hodgkin lymphoma is going to be like myeloma in the last decade, where we'll have plenty of options and plenty of confusion to choose.
Yes, I would say that's probably true.
All right. So let's see if we have any questions online. I don't see any yet. So I had a few of my own. In the non-Hodgkin, especially the CAR-T part that you presented in the beginning, have they looked into IPI risk stratification affecting the outcomes, or does that even matter anymore?
Yeah, IPI not so much, but definitely tumor volume has been found to affect the outcomes quite readily. So it is helpful to be able to get the tumor volume down before you actually do the CAR T cell. That's a pretty big risk factor. But IPI itself, not as much.
Okay. Yeah, it was interesting to see use of obinutuzumab before the BITE that you presented. So that was interesting. So in the very beginning, you presented the long-term data of ZUMA trials and Transcend, and as you said, about 50% plus minus a little bit have long-term cure or CRs. How do you compare that with the traditional transplant data? Is this something similar in terms of outcomes?
Yeah. So in that particular patient population that was in the CAR studies, those are a lot of patients had already failed transplant or weren't transplant candidates. So it's a little bit difficult to directly compare that particular study. But the three studies that we've all been looking for were where the patients relapse early within the first year and have high-risk lymphoma, and they were randomized to CAR-T or autologous transplant. These are going to, they've all just read out recently and going to be presented, I'm sure, at ASH this year. But 2 out of the 3 studies showed that the CAR-T had, at least according to the press, that the CAR-T had better outcomes as compared to autologous transplant. The third study was, which just came out the other day, said that was negative, so I don't have any of the exact data. But at least in the early relapses where we know that autologous transplant doesn't work very well, maybe CAR-T would be a better option. The later relapses, there's not really necessarily a head-to-head comparison because most of the original studies were patients who weren't transplant candidates or relapsed after transplant. So a little bit hard to know in that circumstance. But I do think that the CAR-T is going to take over some of the autologous stem cell transplant business where perhaps they're not very good candidates for that.
Okay, yeah, excellent. One thing that I worry about in the leukemia world, at least, is loss of target when we use the subsequent therapies like Blina with CAR-T following for CD19. I saw that there are different CD markers being targeted, but it sounds like most of the focus is still on CD19. Do you think that's going to be a problem or even a concern when you select agents?
Yeah, so what they did in some of the original studies, they, of course, biopsied the patients when they relapsed, and about half of them had lost CD19 at the time of relapse, and the other half were still positive. So I think it is going to be a problem for using some of these other agents after CAR T cell, and possibly the patient's going to have to be biopsied to find that out. It's also a bit of a problem on the other end. We don't know for sure if we can use these agents before CAR T cell because it may block the CD19. So there's a lot of studies that we probably need to do to be able to safely use that in both directions there.
Okay. I think I see a question from the audience.
Okay.
Can you read it?
Yep. Would dual targeting CAR T therapy have more substantial toxicities or more frequently reported higher grade CRS? At least according to that original autologous study, which I didn't present all the data, but according to that, the toxicities were really not anymore. They appeared to be pretty similar, if not maybe a little less, at least in that particular study. So it didn't appear that it caused any additional cytokine release syndrome or neurotoxicity. Okay, got a couple others here. What do you see the future of in-house CAR Ts using local GMPs rather than industry-produced CAR Ts, or do we need GMP or FACT accreditation for all CAR Ts? I guess I'll start with the last thing first. I think we do need GMP and FACT accreditation for all CAR Ts, even the in-house ones, because this is a living product, and I think we need to feel safe that the manufacturing is appropriate and the potency and the safety for the patient is there. So in-house CAR Ts, I think definitely have their place, but it's hard to mass produce those obviously in a in-house CAR T GMP facility. So we'll see what happens. I think there's probably going to be more, I should say, less individual CAR T manufacturing and more of these off-the-shelf CAR Ts, but we'll see what happens in the future. What are your thoughts on radiation as a bridging therapy to CAR T? Some have suggested there's synergy between radiation and CAR T, and that's very true. There have been some, just anecdotes, and I would say I have some anecdotes as well, where we used radiation to one or two areas in between the time we did the apheresis and the cells were being manufactured, and the patient needed some kind of therapy, and they had just one or two locations to use kind of localized radiation therapy, and then went on to the CAR T, and many of those patients have done quite well. There is some theoretical benefit to that. Of course, that's hard to do if the patient has a lot of different sites of disease, but there are some studies that are just starting up using radiation as bridging to CAR T, and so I think we'll be seeing over the next year probably some of these being reported as well, and we're going to be doing that here as well. Is there a concern for loss of antigen following dual targeting? Yes, I think though there's going to be that same concern in all of our CAR Ts that there could be loss of antigen. We definitely know that in the CD19, about half of them have loss of antigen, and I think the dual will have that problem as well. There isn't really enough data out there yet to know that for sure, but I'm sure, again, we'll be seeing it over the next few years, and they always do biopsies at the time of relapse to try to figure that out.
Okay, I was interested in the CLL Transcend study you briefly presented by Bill Weirda, and I wondered if there's 17P patients in that small population.
Yes, there were quite a few. I didn't present all that information, but there were quite a few 17P patients and other poor prognosis patients. Most of those patients had failed 4 or 5 prior lines of therapy, and they were very heavily treated, and there were a lot of 17P patients. So yeah, it's very interesting in those patients. They don't have a lot of other options after that point. So I think that's potentially a good option for those patients. That trial's still open, by the way, and we have it here. So lots of different places. So I think that it's a good trial for those types of patients.
I think we are done with the questions. I again want to appreciate all the efforts and great presentation. Thank you so much, Dr. Wose.
Yep, thank you. Hope you guys have a good rest of the meeting.
All right. So Dr. Chi Andrew Hu has earned his bachelor's degree from China Medical University, master's from National Sun Yat-sen University in Taiwan. During his military service, he taught histology and performed research at National Defense Medical Center. He pursued his doctoral training at New York University School of Medicine to study membrane protein assembly on the surface of the urinary bladder. He pursued postdoctoral training at MIT to study functions of endoplasmic reticulum in normal B cells. His academic journey started at Moffitt Cancer Center, following which he was recruited at UPenn, where he became a full professor, and then he's with us, luckily, at HMRI since December of 2020. Dr. Hu's laboratory investigates the biology of endoplasmic reticulum in normal and malignant B cells. His lab develops small molecules to target some ER pathways and continues to identify and characterize ER resident proteins that can be targeted for therapy of human diseases. Welcome, and thank you, Dr. Hu, for being here.
Yep, thank you very much, Dr. Shah, for your kind introduction. And today I would like to share with you guys on how we have done in the past few years in targeting ER resident protein for the treatment of B cell cancer specifically. So as you all know, that B cells function is produce antibody to help us fight against infections. So on the left panel here, you are seeing a naive B cell, and these B cell, when they encounter with its cognate antigen, within a week or two, these B cell will differentiate into a plasma cell. And when you compare these two cells, what is really a dramatic difference is that they have the same size of nucleus, but the plasma cell can increase its size for over 100 times when compared with this mature B cell. And all these expansion, when you see these inside this plasma cell by TEM, all this expansion is actually due to the expansion of the endoplasmic reticulum. And the purpose of expanding the endoplasmic reticulum is, of course, to help the B cell prepare to become a factory of generating antibodies. Leukemia and lymphoma are tumors that comes from mature B cell, while multiple myeloma is a cancer of plasma cells. So what makes the B cell expand its endoplasmic reticulum to become a plasma cell? There's an important factor that sits on the ER membrane that is responsible for doing that. So IIE1 is the enzyme that when it receives signal from innate immunity activation or adaptive immunity activation, for example, by seeing antigen or toll-like receptor ligands, IIE1 is going to undergo dimerization or oligomerization. And when IIE1 is oligomerized, IIE1 can then further excise 26 nucleotides from the XBP1 mRNA. So XBP1 mRNA is originally a mature mRNA that encoded a 34 kD protein, which is non-functional as a transcription factor. But once IIE1 excises 26 nucleotides from the XBP1 mRNA, and as you know, X26 is now a multiple of 3, and 3 nucleotides will give rise to 1 amino acid. Now, when the splice XBP1 mRNA is ligated together, now translation go through, and this is going to cause a frame shift in translation. So the original stop codon will become a sense codon, and the translation will continue until it hits the next stop codon. And now this splice XBP1 mRNA is making a 54 kD protein that is a transcription factor, functional transcription factor that could enter into the nucleus, where it upregulates the production of lipid and also chaperones. So you can imagine now with more lipid synthesis, you can expand the size of the ER, and with the chaperone, you can help the folding of immunoglobulin antibodies so that the plasma cell can now secrete all these functional antibodies to help us fight against infections. My laboratory, back in 2012, we have published a paper that we show that the ER stress response is really important for the survival and growth of chronic lymphocytic leukemia. And as I mentioned to you earlier, leukemia and lymphoma are disease that comes from mature B cell, which you don't really see much endoplasmic reticulum in TEM. But indeed, they still express ER. They have much higher level of ER when compared with mature B cell, although it's not as striking as a plasma cell or multiple myeloma. So in the paper, we have demonstrated a number of chaperones and ER-associated degradation protein were upregulated. And that paper was the first one that demonstrated that ER function is really important for CLL survival. And what is CLL? It's still incurable B-cell cancer, and also the most common form of adult leukemia in the U.S. as 30% of as it represented 30% of all adult leukemia. And by studying human CLL cell line and also human CLL cell, primary human CLL cell from patients, we have indeed found out that IIE1 and XBP1 is constitutively activated in these cells. And to further understand the function of XBP1 in CLL, we have decided to generate a XBP1 knockout CLL mouse model, and in which case we actually take advantage of the fact that emu-TCLL mouse model is arguably the best CLL mouse model so far to study this disease, and including ibrutinib and venetoclax, the two FDA-approved compound was also originally tested in preclinical study using this mouse model. And this mouse model was provided to us by Dr. Carl Kochi at the Ohio State University. And this was done by placing the 14 kD proto-oncogene TCL1 under the control of immunoglobulin heavy chain promoter and enhancer. And between 8 to 12 months, this mouse would develop CLL without fail. So when we cross imu-TCL1 with B-cell specific knockout XBP1, mouse model, we could now ask whether the lack of XBP1 would decelerate molecular progression of CLL. And through these studies, you can see now we take 5-month-old mice, spleen from 5-month-old mice, and we analyze their B cell population in the spleen. And you can see now we analyze the B cell population by marking B cell using IgM first, and further analyze this population for the presence of CD5 positive B220 low CLL population. When compare the wild type with the XBP1 knockout counterparts, you could clearly see XBP1 knockout indeed develop much less CLL positive cells in their blood, and also spleen. And in this case, we have examined more mice here, and you could clearly see XBP1 deficiency in CLL cell does not block CLL progression, but it does slow down the progression of the disease. And indeed, with that, the mouse also survive longer. So with this genetic data to justify the effort of targeting this pathway, we went on to develop inhibitor that target this pathway. So what we have done is that, we take advantage of the fact that IIE1 will cleave on the XBP1 stem loop here and here. So if you come from the cytosine all the way to the guanosine, this will be exactly the 26th nucleotide that I talk about. So now we take advantage of the XBP1 stem loop on its 5' end. We install a Cy544, and on C terminal, we install the Bracco quencher. So now if we purify the human IIE1 enzyme from insect cell and titrate it into the test tube, you could cut the substrate open. And because now Bracco quencher is liberated from the substrate, so now you could observe fluorescence in the test tube. And in the same test tube, if you titrate in the inhibitor, you could have this suppression assay that could allow you to use for screening inhibitor that inhibit IIE1 RNase activity. And so indeed, we have discovered and identified an inhibitor as our lead compound BH09 that have 111 nanomolar IC50 inhibiting the RNase activity of IIE1. So with a number of several years of medicinal chemistry exercise, we have come to our first compound that we believe that can be used to treat CLL, and that is called BI09. And as you can see in this example, BI09 stand out from all other inhibitors that show up here to potently inhibit the growth of CLL. And not only that, this happened in the mouse CLL cell, but also in all human CLL cells that primary human CLL cell that we have tested. When mice was injected with 15 mg per kg of this BI09 inhibitor, this inhibitor reaches the maximum plasma concentration of 39 micromolar within 15 minutes. And this compound have 1.5-hour half-life. So it's a little bit short half-life, but probably due to it has such a short half-life, we have tested in many studies in vivo, more than 10 different mouse models, there is no observable toxicity. And indeed, in the specific CLL mouse model, you could clearly see BI09 cause leukemia regression, and also it does hit the target XBP1 because when you purify CLL cell from the treated mice, you could see XBP1 protein is inhibited. And at the time when we developed this inhibitor back in 2014, it's also about the time ibrutinib was just approved to treat CLL, to first treat mantle cell lymphoma and then CLL. So because we noticed that the BI09 phenocopy XBP1 in not just inhibiting the ER stress response, but also can compromise B cell receptor signal. So we ask ourselves whether BI09 would help ibrutinib, to kill B cell leukemia, lymphoma, and multiple myeloma, with the understanding that in clinic, more than 50% of the patients treated with ibrutinib, they have to be dropped out of the therapy due to toxicity. And when we have, in this case, we have choose all these different cell lines representing, B cell leukemia, multiple myeloma, and human mantle cell lymphoma, and we carefully titrating the two drugs using these cells. this BRO9 treated with BRO9 and ibrutinib, we found out that indeed BRO9 can nicely synergize with ibrutinib, and we have determined such a true pharmacological synergism using the child-tolerant method. So in all these cases, you can clearly see good, quite outstanding synergism. And in the past few years, what we have been doing is that, as I told you, that our drug has a 1.5-hour half-life. So what we have been doing is we were, performing medicinal chemistry to try to modify this R1, 2, 3, 4 functional group with the hope to develop a better inhibitor. And today I will actually introduce you to an inhibitor called DF07. So what we have done here, for a long story short, is we want to develop an inhibitor that could have a long-term potency and also higher stability, and also have spatial temporal controllability. So for example, in this DF07 compound, by adding the methyl group to the nitrogen here, and also by modify this C9 position with methoxy group, these will make our inhibitor bind stably to IRE1 by forming an additional hydrogen bond with IRE1 enzyme. And R2 is a very important functional group because originally there was an aldehyde here, and that is responsible for this inhibitor to interact and form shift base with lysine 907 on IRE1, thus causing the IRE1 RNase activity to be inhibited. So we have found out in order to extend the potency of the inhibitor, we have to modify the aldehyde group using different functional groups such as the dioxin acetal or dimethyl dioxin acetal. And what we have found out very interestingly is that when the compound is modified now with 1,3-dioxin or this dimethyl dioxin, this inhibitor completely turn into a blue compound. Now it's emitting very strong blue fluorescence, and it completely makes sense because as you can see here is a coumarin ring. And originally, the aldehyde group is quenching has the electron withdrawing activity, so it's actually quenching the fluorescence emitted by the coumarin. But now, after you protected this aldehyde group using dioxin, now you destroy the aldehyde, so the compound completely becomes fluorescent. As I can show here, DF07 now is a fluorescence compound. And what is even more interesting is that what we have found out in the CA position, there's a hydroxyl group. And this group, if you modify it with any cage compound, now this cage compound is going to forever stabilize or permanently stabilize the cap that you put onto the aldehyde. And so here's the example. So we have decided to put a photo cage onto this hydroxyl group on the CA position. And even better, we actually install a nitro dioxide here to quench the fluorescence of this inhibitor, the DF07 inhibitor. And when we now treat the cell using this inhibitor, and then shine these cells with UV for just 10 seconds, you can clearly see now the DF07 is liberated. Now this photo cage is cut off, and DF07 is liberated inside the cell. And now you could see the blue fluorescence now shown as green color here in the cells. So this would allow us to track the inhibitor inside the cell and also in vivo. And what is even more interesting is that indeed here, this DF07 once is liberated, and if you take these cells and further using Western blot to test for the expression of XBP1, you could also see XBP1 is suppressed and is suppressed more potently. So with this new discovery, we have in last year published a paper, and now there's another paper that is in submission, in which we modify the R4 group using a boron cage, which can be cleaved by reactive oxygen species like H2O2, and we have installed on R4 a thioreactive cage that can be cleaved up by glutathione or cysteine. And as it is well known that the tumor cell express much higher level of reactive oxygen species, and also glutathione and cysteine. We expect and have demonstrated in our paper that indeed, this compound is more specifically killing tumor cell, but not normal B cells. So now I would like to summarize the first part of the talk by telling you, that, again, reminding you that blocking XBP1 of the IIE1 XBP1 pathway of the ER stress response can decelerate malignant progression of CLL. And also the combination of the IIE1 inhibitor and ibrutinib represented a potential good strategy to treat CLL, mantle cell lymphoma, and also multiple myeloma. And inhibitor prodrug that we have developed, is good for, it's not just inhibiting XBP1, but it's also good for checking the inhibitor inside the cell and also in vivo. And we have been able to spatial temporal control the activation of the inhibitor inside the cell and use the cage group to enhance the cytotoxicity of our compound against cancer cells. So the second part of the story is also coherently tied to the first part of the story. That's when we discovered that IIE1 protein was actually interact with a protein called STIN from our mass spectrometry studies. And this example here is just to show you that we could actually, from the cell line, say, pull down IIE1, and by Western blot, we can actually demonstrate that indeed IIE1 and STIN are both come down together. So they're suggesting that STIN is confirming our data that STIN is indeed a IIE1 intellectual protein. So what is the stimulator of interferon genes? STIN. So it's been known, back in 2008, the first paper published by Glenn Barber at University of Miami, STIN was hypothesized to be a DNA sensor inside the cell. And as you know, DNA present in the cytoplasm is a bad thing, so you don't want that, and it's a dangerous signal. So later study actually showed double-stranded DNA can actually activate a protein called cGAS, and this would allow cGAS to take ATP and GTP from the cytoplasm and link them together to become a 2,3-di-cGMP that could now also bond nicely to STIN. And when STIN is activated by cGAM or potentially DNA, now STIN will move from ER to Golgi, where it's now phosphorylated by 10 protein binding kinases. And when STIN is phosphorylated, it becomes a scaffold protein for the docking of the IF3 transcription factor. And when IF3 is now docking onto STIN, IF3 will undergo phosphorylation and move into the nucleus that will now trigger the production of type 1 interferon. So it's been well known in the field, and many studies have been using STIN agonists to activate immune system, to activate NK cell and T cell to help fight cancer. But what we have found is really interesting. When we expose B cell to STIN agonists, what we have found is that B cell just very rapidly, for a very short time, they produce type 1 interferon, but very quickly, within 4 or 5 hours, they begin to undergo very potent apoptosis through mitochondrial activation, mitochondrial-mediated apoptosis. Here's the example. So in this case, we have exposed A20 B-cell lymphoma, CL cells, and also 5G-GM1 multiple myeloma cell to STIN agonist GAM. And you can see in all these cases, all the cells undergo apoptosis, but that is not true for the cell that is exposed to the control agonists. And the Western blot data here showing you that indeed these apoptotic factors are indeed activated. You have cleaved caspases, and also caspase substrate POP is also cleaved. And here are the dose-dependent and time-dependent experiment showing you that when 5G-GM1 multiple myeloma is exposed to cGAM, you can clearly see STIN phosphorylation. And after that, when STIN is phosphorylated, IIE1 is downregulated and XB1 is downregulated. And again, I want to remind you, also the anti-apoptotic gene MCL1 is also downregulated, suggesting this, CL supporting or tumor supporting factors are now all downregulated. And this is accompanied by the activation of all these apoptotic markers. And same is true, when you do the time-dependent studies. And indeed, STIN is responsible for the death, because when you knock out STIN from A20 cell or 5G-GM1 cell, there is no apoptosis anymore. There is no activation of these apoptotic markers. And if you take the CL mouse model, immune TCL mouse model, and you inject them with STIN agonist cGAM, you clearly see, after 3 weeks of injection, you can see clear apoptosis marker stand in CL cell, in the histology section from spleen dissected from the immune TCL mouse treated with the STIN agonist. So how does STIN activation cause apoptosis of B cell? So to further understand that, we decided to make a mouse model that would replace valine on the 154 residue of STIN with methionine. And when STIN now forms dimer, the methionine interaction will mimic the agonist bonding. So now STIN is constitutively activated, as I can show you here. Now from the B cell isolated from V154M mouse model, you could see STIN is constitutively activated, as evidenced by the fact that we can only detect phosphorylation of 365 residue on V154M B cells. And what is so interesting is that when we begin to look at this cell, this V154M cell, in this past chest experiment shows you that it could produce antibody, the pentamer and hexamer antibodies, IgM, and secrete it outside of the cell. But what is so interesting is you see the missing of this upper band here. So what is this upper band? Through a biochemical separation using Trident X114, we were able to separate the membrane-bound IgM from the secretory immunoglobulin IgM. So now you are only looking at the IgM that is membrane-bound. So now you could see the ER formed by IgM. After 30 minutes of chase experiment, it actually acquired complex sugar and moved to the cell surface. And this is completely not true in V154M STIN-constituted activated B cell. And a functional BCR consists of not just the IgM, but also Ig alpha and Ig beta. And so in a different post-chest experiment, we also can show that is also the case, that Ig alpha and Ig beta also fail to acquire complex sugar, as you can see here. They fail to acquire complex sugar in V154M mutated B cell. And if you use flow cytometry to determine the cell surface IgM level and Ig beta level, indeed they are much lower in the V154M mouse model. So what actually causes, what is the molecular mechanism? Actually, after much study, we actually discovered that STIN, when activated, can bind to cell 1, which is a E2 ubiquitin ligase, and E3 ubiquitin ligase, HER-D1. And when it binds to these two, and the data is here, it has much higher affinity in binding to these two proteins. So when that happens, they will cause IgM to be specifically degraded through this channel formed by cell 1 HER-D1 complexes, and there could be, and this pooling from the ER into cytoplasm the ATP is provided by the P97 hexamers, and now the misfolded protein would then enter into the core of this P97 hexamer and be delivered to the proteasome for degradation. So now with these B cell receptors degraded, you can easily imagine now if we activate this B cell using the FAB'2 to cross-link the B cell receptor, you will see much less Ig alpha phosphorylation and also much less phosphorylation of spleen tyrosine kinases. And in BCLL, I want to sort of mention a little bit background about the CLL. There are two types, right? Generally, there is this type called the IgHV mutated type indolent CLL, which require just watch without treatment. And there was also another type of CLL that require treatment, is the IgHV unmutated type aggressive CLL. And the phenotype of these aggressive type CLL is that they have very robust BCR signal. So we collaborate with Javier Pinilla and Moffitt, and also Anthony Matto at Penn. We have analyzing the human sample from these two doctors, and and when we analyzing the STIN expression level in these cells, we often found that in the unmutated aggressive type of CLL, they express almost no STIN or very little STIN when compared with the mutated type of indolent CLLs. So they make us hypothesize, perhaps CLL not just want to downregulate STIN to dodge immune attack, the anti-tumor immunity, but also it potentially can downregulate STIN to upregulate the BCR signaling. So in order to demonstrate this hypothesis is correct, we decided to generate a STIN flux allele, which will allow us to knock out STIN from B cell when we cross the STIN flux mouse model with CD19 CRE mouse model. So now STIN is indeed gone in the XBP1 in the STIN knockout B cells. And if we take the STIN knockout B cell, STIN knockout mouse, and further cross it with eMUTC1 mouse model, now you have a STIN knockout eMUTC1 CL mouse model for the study. And it's indeed very interesting. Now STIN is gone. And the first thing that we have tested is that when STIN is not there, are these cells still sensitive to STIN agonist and can undergo apoptosis? So the answer is no. Right now STIN is gone. So when you treated this cell and also mice with STIN agonist, their B cell, their CO cell don't die at all. And also there's no activation of apoptosis. And the next question we like to ask is then now, when you activate the STIN, you have the degradation of the BCR. And now if you take the CO cell and now you knock out STIN, will you have upregulated B cell receptor? So the answer is yes. No, now by flow cytometry analysis, you again analyzing the B cell the CO population using CD5 and B220 marker, and now you analyze their surface level of IgM and also Ig beta. You can constantly find in the XBP1 in the STIN knockout mouse model, their CO cell constantly have much higher expression of not just IgM but also Ig beta. This indicating, and these are the data from more mouse, much more increased numbers of mouse numbers. All right, so this data suggesting that indeed when STIN is knocked out, you have, the CO cell can present a higher B cell receptor on their cell surface. And with this, now you can imagine that these CO cells can be also more responsive to BCR activation. And indeed, when you trigger them with antigen or with toll-like receptor ligands, these STIN knockout CO cells also proliferate a lot faster than their wild-type counterpart. So with this, I'd like to conclude the second part of the talk by telling you and reminding you STIN agonists are potent in killing B-cell leukemia, lymphoma, and multiple myeloma, not just only in culture but also in mice. And constitutively activated STIN can actively regulate the BCR signaling by engaging ER-associated degradation of the BCR, and this could explain why when B cell is activated by, or CO cell is activated by STIN agonists, they prone to undergo apoptosis. And also downregulated level of STIN in CO cell actually contribute to the increased B cell receptor signaling and also proliferation. So what are we doing now? So with what I have been telling you, so now you would remember that CO cell have downregulated STIN. So what we have planned to do, right, is that when now STIN is downregulated, most likely they have very much upregulated B cell receptor on their cell surface to support their growth, right? So our idea is that we will use BI-09 to inhibit IIE1, and with this inhibitor, not only XBP1 ER stress response can be inhibited, but also, by inhibit XBP1, you can compromise BCR signaling. And we would like to combine the BI-09 inhibitor with the ADU S100 agonist for STIN. And this agonist has been used in clinical trial to treat head and neck tumors and lymphoma. So our idea is that this ADU S100 agonist can still activate the remaining STIN inside on the ER membrane, causing the degradation of IgM. Therefore, can also shut down IgM B cell receptor on the cell surface. And B cell receptor signal, of course, is very important to support CO growth. And what is even more interesting is that when, our hypothesis is that when we treated the mouse or eventually human with ADU S100, this ADU S100 can also activate STIN in endothelial cell, fibroblast, epithelial cells, and causing these cells to produce hyperinterferon and further leading to the activation of natural killer cell and T cells, CD8 T cell, to help suppress CO cells. Okay, with this, I would like to thank people in my laboratory highlight in red here. They all contributed to the result that they generated the result so that I can show the result to you and, talk to you about the story today. And I also want to specifically thank my chemist collaborator to help us and collaborating with us with medicinal chemistry expertise to allow us, synthesize the next generation compound to target IIE1 XBP1 pathway, and Carlo Kochi from Ohio State University for providing us with the mouse model, and also clinician Javier and Anthony. And now, collaborating with Dr. Pingali, we are further exploring what is STING function in CLL, because as you see, some of the CLL cell, even they are unmutated, they still have expression of STING, while the mutated CLL, some of them don't have STING. So we would like to figure out what is going on in these, what's the role of STING in CLL by studying human CLL cells. So with this, I also want to thank the funding agency that funded work in my laboratory, and with this, I'd like to take questions.
So I was interested in how the mutated and unmutated correlate with the STING expression, and it seems like that's also related to the BCR expression on the surface. So I think there seems to be some potential prognostic and therapeutic value there once we can modify these expressions.
That is correct. Thank you for the suggestion and comments. That's exactly why Dr. Pingelli and I, we have submitted an R1 very recently that we using this preliminary data that we have generated in the laboratory, and we propose to explore whether STING could be a biomarker for us to choose ibrutinib, or BTKI, as Dr. Pingelli would say, as compared versus venetoclax for the first-line therapy for CLL.
Okay, I think we have a question come up. I don't know if you can read it or you want me to read it.
I will read it. ER stress, 14 and 14 protein, and role of HISHA protein are extremely important for B-cell homeostasis. Do you see any particular B-cell malignancy being more sensitive and dependent on ER stress over the others, like mantle cell lymphoma cell line, more dependent than CO cell lines? Have you tried BL09 and MCO1 cell line? Okay, this is a really good question. So turn out, our inhibitor is not very, as a single agent, right? I have shown you the combination is very useful for treating CLL, mantle cell lymphoma, and multiple myeloma when it's combined with ibrutinib. But if you use it as a single agent, it's not really, actually only CO cell is more sensitive to the inhibitor, and also some mantle cell lymphoma, primary cells are sensitive. When it comes to multiple myeloma, it's not as sensitive, and you can easily imagine why, right? Because multiple myeloma have so much expanded ER, so it could not just simply rely on one pathway for their ER expansion and survival, right? While CL and mantle cell lymphoma, they look more like mature B cell. 95% of the cell volume is actually occupied by the nucleus. So in the case, these mantle cell lymphoma and CLL cells, they are more sensitive to BR09 because their expansion of ER could potentially just rely on the activation of this pathway that I talk about today. So this is really a very interesting question. And we haven't really very extensively tested our compound in primary mantle cell lymphomas because, we did not really have access to that, so there was only one time. So most of the work that was done in cell line, there was only one time Eduardo Sotomayor and Moffitt provide us with some cell, and we tested it, but the data was never published, so we haven't really do very comprehensive study using mantle cell lymphoma.
Okay, I don't see any more questions. Thank you so much for your time and your excellent work, and welcome again to Houston Methodist.
Thank you very much.
It is my great pleasure to introduce Dr. Carlos Ramos. He earned his medical degree with honors from University of Lisbon, Portugal, completed residency in internal medicine at Baylor College of Medicine in Houston, followed by a fellowship in Hem/Onc at Memorial Sloan Kettering in New York. He did fellowship in blood and marrow transplant at University of Texas MD Anderson Cancer Center back to Houston. He joined faculty at Baylor College of Medicine, where he is currently professor of medicine in Center for Cell and Gene Therapy and Department of Medicine Hem/Onc section, and an attending in blood and marrow transplantation service at the Houston Methodist Hospital. He is also the co-director of quality assurance for stem cell transplantation programs at Houston Methodist, Baylor, and Texas Children's. As a faculty member, Dr. Ramos has focused his research efforts on T-cell therapy for malignancies and viral infections. He has broad experience in cellular therapy for heme cancers, being the principal investigator in several first-in-man trials using chimeric antigen receptor modified T-cells targeting CD19, CD30, and kappa light chain as therapy for hematologic malignancies. He's also implementing cellular therapy approaches for patients with human papillomavirus-associated malignancies using HPV-specific T cells to treat anogenital and oropharyngeal cancers in phase 1 clinical trials. Thank you for being here, Dr. Amos.
Thank you, Shilpan and Eric, for inviting me to be here and talk a little bit about our work in CAR T cell for lymphoid malignancies. I know that Dr. Vos already talked quite extensively about the applications of CAR T cells for lymphomas, both Hodgkin and non-Hodgkin. So I'm going to do a little bit of a different approach because Shilpan had asked me to essentially do an introduction to the CAR T cell technology. I'll talk a little bit on how some of the technology emerged and also how we make a CAR T cell, and then a little bit about some of the new trials that we have ongoing here at Methodist, and also how some of the trials that we conducted here helped to advance also the field. These are my disclosures. And so CAR T cells are a type of, or a branch of a growing type of therapy called adoptive T cell transfer, in which we remove lymphocytes from the patient, obviously we're interested in T cells, and then we do something to those T cells outside the body. And they're usually grown in culture flasks, and while they're growing, we select them to be specific for some antigen that are interested in targeting the tumor. And then after we've expanded them to numbers that are sufficient to infuse back in the patients, we give those cells back to the patients with a therapeutic intent. And actually, one thing I like to remind people, especially because I do bone marrow transplant, but is that actually this concept is not entirely new. And actually, when we do an allogeneic stem cell transplant, we're doing adoptive T cell therapy. Although for a long time, that effect was not appreciated. What we thought we were doing was just giving mega amounts of chemotherapy to the patients and then save them with a healthy bone marrow. But actually, as part of the stem cell products, what we are infusing in the patients is also T cells. And those T cells are responsible for activity against the tumor, what we call graft versus tumor effect. And actually, the realization that that happened led to other strategies of adoptive T cell treatment, including what is commonly known as donor lymphocyte infusion, which we use often with limited success, but to treat the underlying disease for which a patient got an allogeneic stem cell transplant when that disease recurs after the transplant. Actually, knowing that there's some immune activity against cancers led to other groups exploiting actually the presence of lymphocytes that are specific, in this case, in these two cases that I'm showing here, for EBV antigens that drive a type of malignancy that can happen as a complication of a transplant. We call it post-transplant lymphoproliferative disorder. And by selecting those lymphocytes from the product or from the blood of the original donor for the stem cell, those groups were able to isolate cells that were specific for EBV antigens. Those EBV antigens were expressed by the tumors that those patients had developed, and they were able to cure some of these patients. So the problem is with this approach is that most of the tumors that we deal with have no exogenous antigens, including these viral antigens that are relatively easy to target with the immune system. And so most of the focus in these adoptive T cell therapy platforms has been to try to define ways of recognizing antigens in the tumor that doesn't depend on the presence of some of these foreign antigens. But the way to do that has been to modify T cells with doing genetic modification of T cells in order to introduce new receptors into the T cells that allow them to bind to the tumors and tumor antigens that we're interested in targeting. And the two most used approach, one uses native T cell receptors, and the one that I'm going to talk to you today that has quite a bit of success in therapeutic terms is these chimeric antigen receptors. A chimeric antigen receptor is a totally artificial construct that combines the antigen binding portion of a monoclonal antibody to the part of the signaling machinery of the T cell receptor. And when we retroviral, or when we virally transduce these cells, when we introduce these cells, these receptors into T cells, what happens is that they will start being expressed, and when they're expressed in the membrane, these cells then are able to bind to the antigens that are in the tumor, provided that they're on the surface of the tumor. And then by doing that, essentially we're tricking the T cells into thinking that they are dealing with an infected cell, and so they deploy the killing machinery and they destroy the tumor. As with everything that we describe in the laboratory, this works really well in vitro. When we do the experiments in our laboratories, what took a little bit of time was to take this approach from the laboratory to the clinic. And so just to stress one important point in terms of to see how CAR T cells are more applicable than some of the other approaches at modifying T cells, is that if you remember from your immunology, T cells have this complicated way of dealing with antigens. So they recognize bits of proteins that are presented on the surface of the cells, and then they're able to recognize those epitopes by their own native receptors that we call TCRs. And the issue with recognizing the epitopes through this system is that essentially this is specific for every individual, and that's actually the reason why for bone marrow transplants we need to match individuals in terms of that HLA type. For a chimeric antigen receptor, we can actually use the same receptor for everybody because we are recognizing the same protein through the same means, and in a way the receptor is universal. The cells that we're making are not universal because we still need to think that those T cells, they still have their native receptors, they still have the HLA molecules, and so the majority of products that have been developed so far, although there are people looking into other ways of making these CAR T cells, these products are autologous, and so we need to make a product from a particular patient to give to the same patient. We cannot share products between patients in the majority of cases. So these CAR T cells using these chimeric antigen receptors were actually started to be used like in the late 90s, early 2000s. And this first generation, I'll explain a little bit what a generation of CAR is in a couple of slides, but these first generation CAR T cells were feasible. You could deliver these, you could make these cells in the laboratory, you could deliver these to patients. Actually, the first published account of using these CAR T cells was actually not in a hematological disorder. It was actually for renal cell carcinoma, targeting a specific antigen in the tumor. But in most cases, what we would see is really very little toxicity, but also very little activity. And the easiest explanation is that those cells, once we introduced them in the patients, when we looked for them, they really persisted very little time. And so we know that in order to activate a T cell, we need more than just having that T cell recognize the antigen that has been, that T cell is directed to. We also need other signals that are involved in this process. We call it co-stimulatory signals. And as you can imagine, tumors have no interest in displaying the molecules that bind those co-stimulatory receptors in T cells. And actually, we know nowadays, and that's why we use checkpoint inhibitors, that tumors, if anything, instead of showing stimulatory molecules, they display inhibitory molecules that interfere with the function of T cells. But because we're dealing with engineering T cells and modifying T cells, the simplest way of resolving this problem was to include in the chimeric antigen receptor, apart from that, the zeta chain of the T cell receptor, was to add a second stimulatory signal, a co-stimulatory signal, usually CD28, sometimes 4-1BB. And by doing that, we were able to, even in the laboratory, to demonstrate that these cells had improved activation and improved proliferation in the presence of tumor and improved killing activity. And so this led to this creation or this definition of different generation of CARs. The first generation containing only one stimulatory domain, the second generation containing one extra co-stimulatory domain, and even third generation CARs, there now includes more than the two stimulatory domains. So most of the work that has been done and all the drugs that really have been approved, or the cell products that have been approved so far, are of second generation. And actually, most of the work and the initial drugs that were defined were actually against B-cell antigens. And probably because CD20 had already been targeted with rituximab, CD19 actually became the main target, the main interest of people that were developing these approaches. And the idea here is that, remember, so we're targeting antigens that we want to be specific for the tumor. And for instance, a viral antigen could be just specific for a tumor, but actually CD19 is not specific for lymphomas. We know that the majority of B-cell lymphomas will be CD19 positive, but so will be other cells, the rest of the B cells in the body. And so by targeting the lymphoma, we're also going to be targeting normal cells, and that can cause problems. But depending with what organ system you are targeting, in this case B cells, the consequences actually can be addressed in a relatively safe way. And so again, it's probably why the field has started by targeting B-cell malignancies. So we're actually, as a group, and we and others, but our group here at Baylor and at Methodist were actually involved in a study that actually proved that the concept that the first generation CAR T cells here in blue were actually worse when we infused them in patients than second generation CAR T cells here in red. So this was a clinical trial of patients that had diffuse large B-cell lymphoma, and for each patient we actually made two products, one a first generation CAR T cell and the second one a second generation, and we were able to prove in that particular trial that second generation CAR T cells were better than first generation. This was really, now they've been the basis of most of the products that as I mentioned, have been approved. The other thing they also were able to demonstrate here with a trial that was conducted here at Methodist and at Baylor was that while we were trying to minimize the toxicities that we cause in these patients by just using cellular therapy, and you can do that in some circumstances, but what we found out is that in order for, at least in our stated knowledge, in order for CAR T cells to actually be active when you give these to patients, you need to pre-treat those patients with some sort of combination of chemotherapy drugs that we call lymphodepleting chemotherapy. Most of the drugs that are used are the drugs that are used in most cases are cyclophosphamide and fludarabine. And the idea is it's probably a little more sophisticated or more complicated than I'm going to say, but the idea is to carve space in the immune system of the individual that we're treating, so that then the cells that we've expanded outside their body and that we put back in the body have room to expand and do their job. And this was a trial that I mentioned was conducted here. And what we can see is that we had a cohort of patients that received lymphodepleting chemotherapy. They were infused with a second generation CAR, and compared to another cohort that did not receive lymphodepleting chemotherapy, you can see that the expansion of these cells and also the activity of these cells was better in this setting. So when you use second generation CAR T cells and we use the lymphodepleting chemotherapy, you start seeing in patients that have been usually multiply treated and that they are unable to proceed to conventional treatments such as high-dose therapy and autologous stem cell transplant, like this patient that was actually treated here at Methodist, and he was a 67-year-old gentleman. He had a transformed lymphoma, so essentially diffuse large B-cell lymphoma. He had gone through the standard therapy and also some experimental therapy because his disease had never really been in remission. And at some point he had stem cells collected for an autologous stem cell transplant, but when he was about to start the process for the stem cell transplant, he had a PET scan that showed active disease. And so this patient was treated in one of our protocols. He received cyclophosphamide and fludarabine, and then he was given CAR T cells. And what happened to him was that 10 days after he received the chemotherapy, he developed fever. He was admitted to the hospital. We drew blood cultures because at the time he was also neutropenic. All those cultures were negative, but he had evidence of essentially inflammatory reaction happening in his body with increase in inflammatory markers. But at the point he was having fever, if we looked at his peripheral blood, we could see that the population of lymphocytes that were in his blood were the cells that contained the CAR. So these were CAR T cells that had expanded. And I didn't mention that to you, but actually this was also one of those trials in which we're comparing two types of populations. But what we saw here was that actually the second generation CAR T cells and the third generation CAR T cell grew essentially within the same range and at high levels. And what happened to this patient actually resolved, his fever resolved spontaneously or just with supportive care. And then 6 weeks later, he was deemed to be in remission, and is actually now in remission more than 5 years ago. So it was one of our successes. So we were able to put him in remission, but as you appreciated from the clinical history that I mentioned to you, it seemed that we created new toxicities, that there was a new set of toxicities that we started to see in the context of these patients being treated with lymphodepleting chemotherapy followed by CAR T cells. And one of them is what he had 10 days after he received the cells, which is something whose cardinal symptom is fever, and that we currently call cytokine release syndrome. We think that and we call it cytokine release syndrome because what we see when these patients are having fevers at that particular point is that there is we measure cytokines, so the hormones of the immune system. When we measure in the blood, we see that there's increase in several of those cytokines, including, importantly, interleukin-6 and some of the type 1 interference. And because that is happening, essentially, the body senses it or is behaving like if you have an infection. So it's almost like a sepsis-like picture. So apart from the fever, these patients will have low blood pressure. They can start having tachypnea because they may have some capillary leak in the lungs. And then if this goes to the point where your vital signs actually are compromised, then you can have pretty much any end organ dysfunction that you can imagine. At the same point, and probably driven by interleukin-6 and other cytokines, you will see inflammatory markers such as C-reactive protein that we often use to gauge the activity of the cytokine release syndrome and see whether it's improving or worsening. Ferritin's another one of these markers, but mostly we've been managing these patients by their clinical manifestations because most of the laboratory changes lag behind those clinical changes. So how do we treat cytokine release syndrome? There are different guidelines that we use to deal with these patients. The actual products that are being approved, actually, they have their own RAM system that describes when they think that we should address and treat these patients. But the most important thing is really supportive care. So these patients are mostly treated with drugs to decrease their fever. Most of them will be neutropenic at the time that they have CRS, so they'll also be receiving empiric antibiotics just to make sure that we're not missing any infection. We'll support their organ function. And then if we reach a certain grades, and the grades are a little bit different depending on the scale that you're using, but we will use one antibody that is active against the receptor for interleukin-6, which is tocilizumab. And that's actually a very good antidote. Most patients that receive these, they'll end up, their fever actually ends up resolved. If that doesn't work, then we add steroids. There are other drugs that we can use. The concern in the beginning was that we didn't know whether interfering with these cytokine loops actually would affect the function of our cells, but it seems that it's safe to treat these patients early on, and we will not have a decrease in the anti-tumor effect. Another side effect that is seen frequently with CAR T cells directed at CD19 is what's now been most recently named immune effector cell-associated neurotoxicity syndrome, or ICANS. It's easier to call it neurotoxicity, and essentially it's a brain dysfunction. So you can have anything from confusion to seizure. And in some of the products that were never approved, there were complications such as cerebral edema that led to deaths in those patients. This can happen usually at the same time as CRS, sometimes happens afterwards. Again, there are guidelines to deal with these complications. Again, the best is supportive care, with very often we involve our neurology colleagues. And then there are some antidotes that we can use. Interestingly, tocilizumab does not work, even though these cytokines may be involved also in the development of neurotoxicity, but it's a big antibody and so does not cross the blood-brain barrier. And so first-line treatment for ICANS is steroids. There are other drugs that are being studied for this particular complication. Apart from these acute complications, we also see some late toxicities from these CARs. And one I kind of briefly mentioned, so we have often, we would like only to target the tumor, but the fact is that we're also targeting healthy cells in the body that also express, in this case, CD19. We call these on-target off-tumor effects. And so these, because we're using cells, this is a little bit different from dealing with a small molecule. Usually with a small molecule, you stop the molecule and everything improves. Here, these cells, they're alive, so they have the potential to stay in the body for a long time. And so some of these insult against normal B cells can continue. And so some of these patients develop B cell aplasia, and because of that, they'll have low levels of antibodies, and they may need to receive replacement of those of antibodies with IVIG periodically. And then there's also some complications that I don't think they're due to the CAR T cells, although some of the inflammation that they cause could be contributing to these. But one of them is persistent cytopenias, and this can be prolonged. I think this mostly has to do with the fact that a lot of these patients have been heavily pretreated, so they've received a lot of chemotherapy, and then with the cyclophosphamide and fludarabine, these can cause problems in that particular setting. But despite all these toxicities, these products have been approved, and these are the 3 approved products for diffuse large B-cell lymphoma and some other types of lymphomas, but these were the first 3 that got their approval. The second one has also been approved for ALL in children, but they're all second-generation CAR T cells targeting CD19. They differ a little bit in terms of their co-stimulatory domains, but in most of them, most of the studies that have been shown so far, and this data actually is not totally up to date, but we see complete response rates between 40 and 60%, and these complete responses are sustained, and so in the order of 40% in the studies that have the longest follow-up. So pretty impressive activity, because these patients, or for the majority of these studies, patients whose disease had returned after they had undergone high-dose chemotherapy and autologous stem cell transplant, or they were patients that were not able to take the transplant because they were not responding to chemotherapy. So so CAR T cells have great activity against CD19. Can we actually target other molecules that are involved or that are expressed by tumors? And the answer seems to be yes. And I'm going to give you an example of CD30 targeting, which has also been developed here by us at Methodist. And the idea of targeting CD30 is that we know that it's been validated as a target. Think about brentuximab vedotin as a monoclonal antibody targeting CD30. And Barbara Savoldo and Pietro Dotti, when they were here at Baylor, they had developed a preclinical model of Hodgkin lymphoma using a CD30 specific CAR. And with that in mind, we actually developed a series of phase 1 trials. This was the latest one. This one was actually conducted here at Methodist in Baylor and also at UNC. And we used autologous T cells from patients that had, they could have any type of CD30 positive malignancies, but turned out that most of them had Hodgkin lymphoma. Those cells were prepared specifically for each patient. Each patient received lymphodepleting chemotherapy before they received their CAR T infusion, and then we followed them for a number of weeks for toxicity and for effect. We saw the same type of toxicities that we see for the CD19, except we actually did not see any neurotoxicity in these patients. We do see CRS, which was more limited than also in the majority of studies that have been published. What we did see for CD30 was this rash that was maculopapular, could be quite dramatic in a lot of the patients, but was essentially asymptomatic. Patients did not complain of itching. That was not painful. We did do a biopsy in a few of these patients, and we got the usual pathology report that says that it's spongiotic dermatitis, which essentially means nothing, but it could be anything. But we don't know exactly what the mechanism of the rash is, but we don't know whether there's a few cells in the skin, like these are a few rare cells express CD30, whether that was triggered by the presence of those cells, or whether it's just, again, the different cytokine loops that get activated when these cells recognize the tumor, whether it could non-specifically cause these rashes, because I'm told that some patients, although this hasn't been reported, but some patients even with CD19 can have rashes as part of their cytokine release syndrome. And so in this setting, this was actually the first patient that we treated at Methodist, and he had a disease in the bone, mainly Hodgkin lymphoma, and he was in remission 6 weeks after infusion. His remission lasted about 9 months. And we had, for this particular, in this particular trial, about half of the patients achieved remission. Some of them actually are durable, although the numbers compared to CD19 seem to be, the numbers of sustained remission seem to be smaller than what we see for CD19, so we don't know whether any of these patients are going to be cured just with the CAR T cells. But the results are encouraging, obviously, and we'll continue developing this approach, and there's currently phase 2 trials that are looking into Hodgkin lymphoma, and also phase 1 trial looking at other lymphomas, particularly T-cell lymphomas that express CD30. So there's been a major interest in developing this technology, not just for B-cell lymphomas, but also for other diseases. I didn't mention anything about multiple myeloma, but BCMA is a target that is present in plasma cells, and there is a product that has been approved by the FDA. All these products have unpronounceable names, but they're very catchy commercial names like Kymriah and Yescarta and Breyanzi, and all of those have been approved for the CD19. I showed an example for CD30 that kind of expands the treatment to potentially to T-cell lymphomas, but there's also a large interest into actually targeting other antigens that are specific for T-cells. This brings about quite a bit of problems, because you can imagine we are growing these cells in culture. They are T-cells, and so if we train them to recognize an antigen that is present on T-cells, chances are that that T-cell is going to kill the brothers that are in culture. So we see what we call fratricide. There are ways of circumventing that, and we have a few trials now being open for targeting CD5 and CD7, but it does bring a little bit more problems, both in the manufacture and also potentially in the clinical effects, or the clinical consequences of using these targets. So this is just an example of a trial that we have opened here at Methodist, targeting CD5. So this was a patient that had a peripheral T-cell lymphoma expressing CD5, and he again had a very good response to the treatment with CAR T cells, with limited toxicity. And again, the follow-up for this patient is still short, so we have to see how durable these responses are. So if I think I'm about done, so I offer some conclusions. So I talked to you about adoptive T cell therapy. Definitely CAR technology has expanded the scope of that type of therapy. We have remarkable results, mainly in B cell neoplasms that have been approved to treat the conditions that I mentioned to you, and also ALL, although ALL only children, so we were not able to use commercial products to treat adults, but we have studies in which we can treat adults. In general, all these products are approved after failure of 2 or more therapies, but this is a field of research. People are interested to see where these treatments fit. We can target more than just the CD19. We can target other antigens, but we did create a new type of toxicities that we need to be able to deal with and manage as we see in these patients. Just the last slide to show a few current questions in this particular field. I mentioned, I alluded to one of them. It's really, so most of these products are being used as treatment after a failure of a couple of lines of treatment, but we are interested in seeing whether we can bring these therapies early in the treatment course. I told you that it was a little bit like doing a transplant, and so something that sows terror in the heart of someone like me who does transplant for living is that there is this possibility that actually these CAR T cells could be used instead of transplant, but we're still early in that course. We're interested in dealing with when patients relapse, whether we can target alternative molecules, and also we are interested in studying whether we can decrease the toxicities of the lymphodepleting regimens that we're using. And finally, kind of the big elephant in the room is that these products are very effective, but they're very expensive, and so we're looking into, can we make these cheaper by coming up with ways of, for instance, making truly universal products that we can have on the shelf and we give to patients when they need it. But this is it. So this is what I had to tell. I'll be happy to answer any question. Thank you.
I don't see any questions yet on the questions board. I had a few of my own. What do you think about you think that the off-the-shelf products are eventually going to replace autologous CAR, because obviously they look much more, they are faster, they have their own advantages, but what do you think is going to happen there?
So it's very early, right? So we don't know. There's the majority of, if you look at the potential activity of the cases that have been published, because there are no large series, it seems that the autologous cells have, they have higher activity, but one of the problems is that the autologous cells probably persist in the body for a longer period of time because they're not rejected from the body that receives the cells, right? Well, the allogeneic products, even though people are trying different ways of preventing rejection, like removing the HLA molecules and so forth, they probably have a much more limited lifespan in the body, and so you probably would not expect to see the same effect. But it's still, everything's still in the infancy, right? So people are looking, in most cases, a lot of the work that has been done has been using T cells that have been somehow modified to be less immunogenic in the sense to be like decrease the risk of rejection. You also need to think about the other things that T cells can cause in an immunosuppressed individual, which is graft-versus-host disease. And so a lot of those cells have to be extensively engineered, and so it also may affect their function. There are people looking at other populations, like, for instance, gamma delta T cells that have TCR that is more universal, so less polymorphic, and so in theory could be used easily in different individuals. We're interested in this specific cell population called NKT cells that also have a less polymorphic receptor, and so not having to make extensive modifications in those cells can make them more active. But I think we'll have to wait for the larger trials to be developed. It's in a way some of these products, the fact that the autologous products have been approved limits a little bit our ability to do some of the trials for the allogeneic products, because we know that we have a product that is active, and so we're not gonna. It wouldn't be really fair to give a patient a product that we don't know it's going to work or not. And so most of the patients that we're treating are patients that have already received some sort of cellular therapy. And so they may not be the patients in which we would see the highest activity for that new product. But it's definitely an area that is being extensively studied now.
I think the question was with the problem getting TOSI easily, the other anti-interleukin agents, are they easily replaceable, or have they been studied enough?
So most of this, or the majority of the studies were done with tocilizumab, and so actually the actual RAMS for each of the product includes tocilizumab. There is, and tocilizumab blocks the receptor for interleukin 6. Siltuximab is another interleukin 6 antibody that actually binds the cytokine, not the receptor. I think it's been used anecdotally, but there are no large series evaluating the effect. So I don't know if that's going to be as helpful or not as tocilizumab. Steroids, they definitely have effects, and there's kind of varying opinions of whether the fact that when you give steroids to these patients, whether you are affecting the anti-tumor activity. But that could also be used if the tocilizumab is not available, steroids are efficacy. There's some data from MD Anderson that shows you may actually be decreasing the anti-tumor activity of the CAR T cells, but other centers claim that they do not see any effect, as long as they are given to patients that not immediately, obviously not together with the CAR T cells, but you wait until you see an effect. And then there's other compounds being studied, like anakinra, which is interleukin 1 receptor antagonist, and so it's that could also potentially be used, and it seems also it's a smaller molecule, so actually may be useful for neurotoxicity for ICANS. And so, but again, we don't have a large series of patients that have been treated with those compounds to know. What we're trying to, like in most centers now, that we're aware that, and because the rules are you need to have enough, whenever you treat a patient with CAR T cells, you need to have enough for 2 doses of tocilizumab. And so we're trying to, we make sure here that, and in all the centers, that we have it. And so far, we've been able to get some from other places, but if it really becomes a larger problem, I'm sure a lot of people will start using the siltuximab and other available antibodies.
I think that's it for now. Thank you so much for coming up with this excellent talk and your time.
Thank you. Bye.
So for the final section today, we have 3 abstract presentations from the abstracts that were submitted for the conference. So the first author will present. Each one will be about 20 minutes. Think about really hard questions for the authors. The first one is being presented by Dr. Abdul Esmail, and it's early relapse detection and monitoring disease status in patients with early stage pancreatic adenocarcinoma using circulating tumor DNA.
And being honored to be selected for to present our poster orally. So today we're going to go over using ctDNA or circulating tumor DNA in pancreatic adenocarcinoma. So we're gonna go over history and definition, and then materials and methods, and result and conclusion. So in 1948, cell-free DNA was first time to discovered in bloodstream by Mandel and Mattei. And then in 1965, cell-free DNA found to be involved in metastasis and associated with some disease. Then after 30 years, they found tumor-specific mutations in cell-free DNA of plasma samples. So after like 3 years, in 1997, cell-free DNA started to be clinically implanted. A digital PCR methods known as PEACE, inversion and amplification magnetic was utilized in 2005. So circulating tumor DNA is a tumor-derived fragmented DNA in bloodstream that is not associated with a normal cell. So we shouldn't confuse between cell-free DNA and ctDNA. Now ctDNA has been utilized in clinical trials to monitor tumor response to targeted therapy, and also to monitor the development of resistant and minimal residual disease. Numerous circulating biomarkers have been evaluated to deduct of minimal residual disease in pancreatic adenocarcinoma, also for surveillance. But all techniques, those techniques, has limited to early pancreatic adenocarcinoma because poor sensitivity and specificity. But now we have an ultra-sensitive, personalized, tumor-informed ctDNA. So ctDNA as a biomarker has been emerged as a promising non-invasive biomarker, cost-effective of detection for minimal residual disease. So this picture gonna explain to us a little bit about the ctDNA and normal cell or cell-free DNA. In this study, ctDNA was clinically validation study in colorectal cancer. This study was published in JAMA Oncology for patients with colorectal cancer. The sample size was 125. 5 of them were in stage 1, and 39 of them were in stage 2, and 81 of them were in stage 3. They collected around 795 plasma samples pre-surgery and day 30 and quarterly up to 3 years. They found the median time of ctDNA positive within 6 months of surgery, 82 days, and median time of ctDNA positive study-wide was 139.5 days. Overall positivity rate for colon patients was 9.1% and rectum with 14.9 and 11.5 for colorectal cancer. So the same concept has been applied in Houston Methodist in cancer for pancreatic adenocarcinoma. So the pancreatic adenocarcinoma has one of the most aggressive cancer histologies and the 4th leading cause of cancer death in the United States. So they expected by like 2030, the pancreatic cancer is going to be the second cancer killer. Pancreatic adenocarcinoma, high recurrence rate with 85%. The 5-year survival rate is 9%. And the tumor marker of CA99 level may be sometimes high abnormally in patients with non-malignant condition like gastritis. CA99 level are commonly utilized in clinical settings to predict prognosis and evaluate tumor response to pancreatic cancer treatment. So the materials and method in our study, to our knowledge, this is the first study to investigate the validity of using ctDNA in pancreatic cancer in correlation with tumor markers such as CA19 and imaging. It was single center study, retrospective study, reviewed patients with pancreatic cancer, done at Houston Methodist Cancer Center, and the idea and concept was established by our GI oncologist, Dr. Abdurrahim. The sample size was 9 metastatic pancreatic adenocarcinoma, are reviewed between May 2019 and March 2021. All plasma were collected post-operatively prior and after adjuvant therapy. And the personalized mutational profile derived from tumor tissue via whole exome sequencing were used to design patient-specific ctDNA assays for variant detection in plasma sample, which is Signatera. So the result of our data, the median follow-up was 57 days, and the 44.4 patients were like relapsed, and those patients have 100% ctDNA detected prior to or at the time of recurrence. And this table, I would like to highlight some few things. So if you see in the patients in green light or in green color, all of them have ctDNA negative, like the patient number 1 and 5 and 6 and 8 and 9. All of them negative ctDNA, and you will see no relapse. However, the patient with the positive ctDNA, all of them they have reported with relapse. But on the other hand, the CA in patient number 1, the CA99 was elevated, but no relapse. If you see the ctDNA status was negative and no relapse, but the CA19 status was elevated and no relapse. So this is the patient overview plot. Like we recorded like 4 patients relapse, which is 44.4. And the association here, you will see the association relapse-free survival with ctDNA and CA99. So we found that significant difference between survival curves between patients with the ctDNA positive and ctDNA negative was significant, which is p-value is 0.011. And the survival curve between patients with CA19 elevated and CA19 normal were not significant different. The p-value 0.082. So this curve for ctDNA and this curve number of CA19. This picture highlighted for 4 patients for ctDNA for early relapse detection and disease status monitoring with CA19. So our samples or patients in this picture, all of them found ctDNA associated with disease status. You will see here like CT scan negative and ctDNA negative, and CT scan negative, 10 here. All of them, like here, CT scan was positive and ctDNA positive. In this slide, you will see all patients' ctDNA was informed prior to imaging patients. But I would like to highlight the patient number 3 and patient number 4. you will see the patient did a ctDNA in July 2020 and back positive. But in July 2020, the ctDNA was done and the CT scan done and back no evidence of disease. So we have conflict right now. But later on, the ctDNA is still positive and the CT scan confirmed recurrence. And the same thing happened for patient number 4. So in September of 2020, the ctDNA positive, and 1 month, like in October 2020, the CT scan was like no evidence of disease. So we have a conflict. But later on, the CT scan confirmed liver metastasis with the patient. In conclusion, the presence of ctDNA after surgery in early stage of pancreatic adenocarcinoma is associated with reduced recurrence-free survival. The ctDNA was found to be a better prognostic marker in comparing with CA99 and CEA. Also, the ctDNA can be used to inform on disease status prior to imaging. And finally, we are expanding our research in this patient population in future as prospective study with large patient size. And thank you.
Excellent talk. I have, I'll hold this up. We'll get this little award to you. For our second abstract, Dr. Hussein Chen Liu is going to discuss intratumoral delivery of CD40 agonist antibody via nanofluidic drug-eluting seed-reduced tumor burden of murine pancreatic ductal adenocarcinoma.
First, I want to thank the organizer for giving me this opportunity to present my work on intratumoral immunotherapy delivered device to treat pancreatic cancer. So most of the pancreatic ductal adenocarcinoma patients were diagnosed at advanced stage, and the tumor was metastasized at that time. Therefore, the 5-year survival rate for pancreatic cancer is very poor. The clinical challenge to treat pancreatic cancer is the desmoplasia barrier. This stroma tumor microenvironment prevents appropriate vascularization, which results in insufficient drug delivery. Immunotherapy has been shown success in many cancer types, but the success in pancreatic cancer is limited due to the poor immune cell infiltration in the tumor microenvironment. The immunotherapy is utilizing the host immune system to eliminate the cancer cells. First, license the antigen-presenting cells, then prime the T cells to recognize the antigen and eliminate the cancer cells. The therapeutic antibody is a common passive immunotherapy approach that's being used nowadays. So in our study, we use agonist CD40 antibody to enhance the host immune response. CD40 is expressed on macrophage, dendritic cells, and B cells. The CD40 activation is critical to activate the anti-tumor T cell response. Then how do we deliver CD40 to tumor? Conventionally, immunotherapy can be given systemically through IV injections. However, the whole body exposure to the therapeutics is low therapeutic index and high toxicity. Intratumoral delivery approach is a more effective way and low toxicity compared to systemic delivery methods. Although intratumoral delivery shows high therapeutic index, the repeated injections is not feasible in the clinical setting. So to address the clinical needs for intratumoral drug delivery, our group developed an intratumoral delivery system, nanofluidic drug-eluting seed, NDES. So the NDES is the size of grain of rice. It consists of a stainless steel drug reservoir and a silicone membrane with nanochannels where drug will release from. So the device was implanted intratumorally through the trocar system, And the in vitro analysis showed the sustained CD40 antibody release for about 7 microgram a day. The mice were inoculated with KPC pancreatic cancer cell line on the flank of black 6 mice. When the tumor reached to 120 millimeter cube, mice were randomized into 2 treatment arms. One is the NDS loaded with lyophilized CD40, and the other received 4 doses of CD40 through the IP injections. The tumor growth rate showed IP CD40 and NDS CD40 both significantly reduced the tumor burden. And when we look at the tumor immune microenvironment, we observe both IP and NDS delivery showed increase of CD8 effector cells and CD8 central memory cells. These indicated CD40 promote the functions of CD8 T cells. The FOXP3 CD4 T regulatory cells represent an immunosuppressive response. NDS group show significant decrease of Tregs compared to the control groups and the IP delivery group. We also observe a correlation of local delivery and systemic effect in NDS treated groups. In tumor-infiltrated lymphocytes, we observe a significant decrease of M2 polarized macrophage in CD40 treated groups. M2 macrophage is an indicator of pro-tumor activity. And M1 polarized macrophage, which indicated anti-tumor activity, was increased in the CD40 treated groups. When assessing a tumor-draining lymph node for systemic effect, intratumoral CD40 delivery approach shows significantly reduced M2 cells, but not in the IP delivery group. CD40 treated groups also show increase of M1 cells in both IP and NDS delivery approach, though the statistic analysis didn't show significant impact here. Next, CD40 showed prolonged pancreatic cancer survival rate. IP and NDS CD40 treated group can even achieve tumor clearance. Lastly, we monitored the weight changes to evaluate the toxicity that associated with different delivery methods in the mirroring model. IP treated groups show mice were losing weight while the treatment started. Though the body weight gained back later on, it is a sign of treatment-associated toxicity. We also submit our liver histology samples to pathologists to score for liver inflammation. All the IP-treated samples show moderate inflammation. NDS only show mild inflammation as well as the control groups. So in summary, CD40 agonist antibody has a great potential to treat pancreatic cancer. And CD40 treatment improves anti-tumor activity of macrophage polarization and an increase of CD8 cytotoxicity T cells infiltration. The sustained antibody release of NDS showed a competitive outcome as IP delivery. NDS delivery show low toxicity compared to IP delivery. So overall, our study demonstrates that NDS immunotherapeutics delivery approach offers a promising strategy to improve therapeutic index and clinical response for pancreatic cancer. So I would like to thank everyone in Dr. Guertoni's lab helping on this project. Thank you.
So in terms of the M2, M1 switch,
yes.
Did you say they were equivalent to the IP and the NDES, or was there a difference?
What we saw is there's no difference between the IP and IP and NDS. We didn't see the difference there. But when we saw no difference in the tumor-infiltrated lymphocytes, which are the immune cells inside the tumor. But when we look at the adjacent tumor, we usually call it tumor draining lymph nodes. We did see how the NDS treated one still maintained the M2 decrease, but not seeing the IP treated one.
So down the road, obviously these are animal models and they need to move forward to eventually be in humans. I assume that the cartridge stays in, and so eventually either that'll have to come out or it'll magically biodegrade. But we'll worry about that once we start moving to human studies. That was fascinating. Okay. Thank you very much.
Thank you so much.
Our final abstract presentation will be from Lily Fu, who will be discussing transitioning inpatient chemotherapy administration to the outpatient infusion center.
Thank you very much for the opportunity to allow me to present our project at today's Cancer Symposium. So a little bit of background about our project. So there are a lot of complex chemotherapy regimens. Usually they include multiple drugs, multi-day infusion. So historically, they require cyclic inpatient admission for extended infusions. And so, but those inpatient chemotherapy administration create strains on the hospital bed utilization and also pharmacy staffing, especially, staffing for the evenings and also weekends. And also, it's not very convenient for the patient or the family. And it's a big patient dissatisfier. So with the evolution of monitoring strategies and expansion of the outpatient infusion center services, and recently various inpatient chemotherapy regimens have been successfully transitioned to the outpatient setting. Just to give you an example, REPOC is a five drug or 6 drug 5-day chemotherapy regimen for aggressive B-cell lymphoma. Include those 6 drugs listed, and plus the Neulasta growth factor after the chemotherapy. So it has been done in the inpatient setting. However, recent years, there have been some studies to show this regimen can be safely given in the outpatient setting. And those are some listed of, studies. And, usually they are in the academic center. So from the resources used and also the benefits for the hospital and also for the patient. And so the patient satisfaction based on those studies reported in 70 to 100% of the cases. And the hospital days saved estimated to be, around 350 days to almost 1,000 days. And also the cost savings, and it's somewhere around $500,000 to $1.1 million. So at Houston Methodist Sugar Land, we start planning this process for about 5 months last year. So first we'll reach out to other institutions, and like UT Southeastern Hospital in Dallas, University of Arizona, and also some ACC members. And it's a multidisciplinary effort from a physician, pharmacy, nursing, and also bed management and patient access team as well. And we had a week-long work group meetings via Kaizen this method, and we also had a support from our hospital administration. So we have divided our tasks and accomplished by those work groups like central line placement, either PICC line versus port, and also atrialization management, and ED or oncology staff education, home skill kit, and bed management checklist to screen what patients qualify for those outpatient administrations. And we also created policy specific for this process and for approved by PNT. So from the pharmacy preparation standpoint, so the difference is instead of those 3 drugs, the first 4 days, those 3 drugs, doxorubicin and Christine Topstat, if the patient admitted in the hospital, Those 3 drugs will be administered through 2 separate bags, infused 24 hours for continuous 4 days. So for the outpatient change, so we combine those 3 drugs in 1 bag. So the patient will go home with this bag infused with this CAT pump. So each day the patient will come back to our infusion center for the bag exchange for day 2, day 3, and day 4. On day 5, the patient will come back to have the pump disconnected and have the cyclophosphamide and Rituxan to be infused, and along with Neulasta at the end of the chemo. At home, patient will also be taking prednisone orally, from day 1 to day 5. So the purpose of the study to evaluate impact of the transitioning inpatient chemo to the outpatient setting on the hospital days, healthcare costs, and also patient satisfaction. We have implemented this new process since April last year. And so the data, we did retrospective observational study. So we collected data from April 1st to December 1st of last year. So the data collection, still continue. So those patients include the age, over 18 years and older, and they'll be screened and receive the following chemo regimens in outpatient infusion center, including REPOX, RDHAP, which, contains rituximab, cisplatin, cytarabine, prednisone, and also AIM, doxorubicin, ifosfamide, and mesna. So the primary endpoints are hospital days saved and patient satisfaction improvement. And the secondary endpoints are cost savings and outpatient chair time utilization, adverse drug reactions, and also treatment response. So the baseline characteristics and endpoints were collected via the manual chart review and analyzed using descriptive statistics. So the patient satisfaction was assessed through a 12-question survey based on a 5-point Likert scale. So in this 8-month study period, so there was 7 patients screened for outpatient chemo, 4 patients eligible to receive, those chemos in outpatient setting after they meet those criteria. So 2 patients received R-CHOP and with 5 and 6 cycles respectively. 1 patient received 2 cycles of RDHAP, and 1 patient received 3 cycles of AIM and pembrolizumab. So 2 patients are male, 2 patients female. 3 patients out of those 4 are stage 4 diffuse large B-cell lymphoma. 1 patient with metastatic malignant peripheral nerve sheath tumor. And the performance status, 1 patient has, 0, and 3 patients, performance status score of 1. Median age, 55 years old. So the primary endpoint, out of those 11 cycles of REPOX, 66 days hospital, 66 hospital days saved, average 6 days per cycle. And the 3 total cycles AIM, about 15 days saved, and 2 total cycles DHAP, 8 days saved. So to combine, there were about 90 days hospital days saved, and patient satisfaction improvement 100%. All the patients, 3 out of 4 patients responded to our survey, and they answered all the questions with 100% satisfied, or they prefer outpatient chemo administration versus inpatient stay. And total cost saving is about $250,000. That's based on $2,800 per inpatient day for a nonprofit hospital in Texas in 2019. And total outpatient chair time utilized is about 25 days. We convert the average administration time or chair time per each cycle, and we convert to about 25, outpatient days. So that's about 5 weeks. So the outpatient assistance program applied to one patient for 5 doses of Keytruda. And, for inpatient administration, the assistance program cannot be applied. It's not eligible to be applied. So only can be applied to outpatient administration. So regarding the treatment response, 3 patients had a complete response with the diffuse large B-cell lymphoma. One patient had partial response. The patient with, peripheral nerve sheath tumor. So the side effects, so most are grade 1 and grade 2, and there's no extravasation occurred, and one patient stopped AIM therapy because of repeated febrile neutropenia, and one instance of pump malfunction occurred at the very beginning of the process, but it has been subsequently resolved. So in discussion and conclusion, so the multi-day complex chemotherapy regimen were successfully transitioned to the outpatient setting in the community hospital, within the 8-month period. So most adverse reactions were classified as grade 1 or 2, no extravasation episodes occurred. All the patients had either partial or complete response to the therapy. All the patients extremely satisfied with outpatient chemo administration and prefer it over inpatient chemo. So the total inpatient days saved for only 4 patients were about 90 days, and this translated to cost saving of approximately $250,000. So the potential for cost saving will be much more significant after this practice is adopted system-wide. So as a follow-up, this policy has been adopted by the system, and it was approved in July. So we are still collecting the data. Hopefully, in a year from now, the data should be, much more significant and impressive. So this transition led to improvement in patient satisfaction and significant cost saving through reduction in hospital days without compromising patient outcome. A little background about the timing of this process change. When we started this, it was April last year. That's when the COVID just hit us. And so it was also from the infection control standpoint, it's beneficial to our patients to receive those chemos in the outpatient setting. So here are the references. With this, I'm open for questions.
That's a very thought-provoking, great presentation. It's amazing that that the cost savings for only these 4 patients were $250,000, $250,000. So next, after you guys perfect outpatient chemo, then you'll start giving it at home. Just think about how much that'll save. We'll get you your little award. I don't think there are questions. Thank you very much for that presentation. That is the conclusion of our symposium. On behalf of my co-course director, Dr. Shah, I want to thank you all for attending. Hopefully next year, we'll all be here in person. Don't forget your CME and your evaluation. Thank you very much. Have a great day.